with more expansion in our subjects and more comprehensive approach, and trying to involve most of our colleagues in their distinguished areas. This year, I promise you that it will be really rich in the lectures and in the interaction, inshallah. Our first session will be moderated by our two distinguished hematopathologists, Dr. Reem Al-Rabih and Dr. Muna Al-Faraj. Dr. Reem is a board-certified pathologist consultant in hematopathology, and she's currently practicing in King Fahd Specialist Hospital at Dammam. Her areas are in hematopathology, general hematopathology, lymphoma, and transfusion medicine. Our distinguished moderator is Dr. Muna Al-Faraj, and she is a hematopathologist and blood transfusion consultant at the MOH, currently in Qatif Health Network. So I will leave the microphone to them, and inshallah, I hope that you will all enjoy the event today. Thank you.
Good morning, everybody. It's my pleasure to be here as a part of this great conference, and it's my great pleasure to introduce my dear colleague, Dr. Nahla Al-Ghasham. Dr. Nahla Al-Ghasham is a highly respected hematopathology consultant at King Abdulaziz Medical City in Riyadh. She has been serving as a consultant hematopathologist since June 2019 and is also the site director of the Hematopathology Residency Program for King Saud University Fellowship. Dr. Nahla is a member of the Resident Training Committee for Clinical Pathology Residency Program and is a member of the board of the director at the Blood Bank Friend Charity. She's also a member of the scientific committee at the Blood Bank Friends. Dr. Al-Ghasham received her medical education at Al-Qasim University, where she earned her Bachelor of Medicine and Surgery. She then went to complete her rotating clinical internship at Al-Qasim University in 2007. Dr. Al-Ghasham completed her residency program in hematopathology at King Saud University Fellowship from 2007 till 2012. She then completed her fellowship in hematopathology at King Faisal Specialist Hospital and Research Center in Riyadh towards Saudi Commission for Health Specialties Fellowship in 2013 and 2014. Dr. Al-Ghasham is an active member in many hematopathology organizations, and she has many publications in local and also international journals. Dr. Nahla will talk about WHO updates on MBN and MDS. Welcome, Dr. Nahla.
Thank you, Dr. Amuna. Thank you, Dr. Amuna, and I would like to thank the organizing committee and scientific committee for the kind invitation. So today I'll talk about the WHO updates on MBN and MDS based on what's published last year on the leukemia journals. And also I will expand more based on what is available online now as a beta version for the WHO classifications for hematolymphoid tumors. Today my talk is only the updates in MPN and MDS, so I'll touch more on MDS, MPN if I have time. We know that the MBN, based on the four major categories, the CML, polycythemia vera, ET, and primary myelofibrosis. And also we have the chronic neutrophilic leukemia, eosinophilic leukemia, and MBN unclassifiable. In this version, the WHO add the juvenile myelomonocytic leukemia to be considered as a childhood MBN. There is no much change on the diagnostic criteria. However, there is a slight modification on the chronic phase and also a renaming on the, and some changes in the diagnosis of chronic eosinophilic leukemia. So in this version, the classification express more on the importance of mutational analysis in MBN, especially in myelofibrosis, and also in ET and MBN if there is atypical feature or sign of a disease. Also, they stress on the presence of germline predisposition in patients of MBN, as first-degree relatives of MPN patients have 5 to 7-fold increase in the developing of MPN, and also since the JAK 461 haplotype allele is present in about quarter of population, and it's hyperactivated and enriched in patients diagnosed with MPN, especially with JAK V617F mutation. I'll start with the chronic myeloid leukemia. So all of us been surprised when the 5th edition classification removed the accelerated phase of CML. We all know that the CML is either biphasic or triphasic, presented with the chronic phase, then accelerated phase, followed by blast phase. However, some patients will present from chronic directly to blast phase. However, in the era of TKI, they feel that the accelerated phase is less useful, and now they call it a high-risk chronic phase, and we will explain more on this. They highlighted an essential and desirable diagnostic criteria for diagnosis of CML. So the patient must have a peripheral blood leukocytosis together with detection of Philadelphia chromosome by karyotype, FISH, or molecular analysis. And this is enough and essential for diagnosis. However, if the bone marrow aspirate is available, this is very important to confirm the disease phase. And a bone marrow biopsy is not that important unless the patient aspirate cannot be taken. The definition of blast phase for CML, more than 20% myeloid blast in the bone marrow or peripheral blood, presence of extramedullary proliferation of a blast, or presence of lymphoblasts in the peripheral blood or bone marrow, even if it's less than 10%. So if lymphoblast is present, this is enough to call it blast phase CML, even if the blast is less than 10%. This is the features for increased risk of disease progression. We have a high risk, or what they call it a high risk chronic phase CML. So at diagnosis, present of increased blast up to 19%, or more than 20% basophils, or additional chromosomal abnormalities in the cells carrying the Philadelphia chromosomes, or presence of dysplastic changes in the megakaryocytes as micromegakaryocytes as seen in the MDS. This, or fibrosis. So this is what we called before accelerated phase. Now it's still there, but they call it a high-risk chronic phase. During a treatment, if there is a resistance to the TKIs, if there is a loss of response, if there is a new additional chromosomal abnormality or mutation in the BCR-ABL, this is also included in the high-risk chronic phase. For polycythemia vera, the diagnostic criteria is almost the same. However, they mentioned that if the patient is negative for JAK mutations, a higher hematocrit target could be considered. So if the third criteria if the third of the major criteria is not available, the 2 is enough. However, they are targeting a higher hematocrit level. For diagnosis of essential thrombocythemia or ET, the diagnostic criteria is almost the same. Also, the diagnostic criteria for post-essential thrombocythemia is similar to the last edition. They explained more in the prediction of myelofibrosis post-ET, thrombosis with ET, transformation to blast phase ET, with more explanation. So they are saying that any patient more than 70 presence of fibrosis, more than 1 anemia, leukocytosis, JAK negative disease or mutation, another extra mutation in epigenetic regulator as ASXL1 and therapy resistance specifically to hydroxycarbamide. This is a risk factor for the patient to transform to myelofibrosis post-ET. Also, if the patient is a high risk with the age of more than 60 with a history of thrombosis history, then the patient is high risk of AT. Very important, the age, history of thrombotic events, and JAK versus non-JAK mutated genotype as substantial for risk factor to develop thrombosis for those patients. For leukemic transformations, post-ET, again, the age, the leukocytosis, abnormal karyotype, thrombosis, if the platelet is more than 1,000, presence of reticulum fibrosis, and therapy resistance especially to hydroxycarbamide, and as we said, the mutation or high-risk mutation like TP53, RANOX, and ASLX1. For myelofibrosis, the diagnostic criteria is unchanged. For prefibrotic, fibrotic, grading system is the same for reticulofibrosis, collagen, and osteosclerosis. They mentioned a very interesting statement that recent studies showed that presence of what they call megakaryocytes activations. It's a triad that comprise megakaryocytes in periopoiesis, clustering of 3 or more megakaryocytes, and pre-megakaryocytes fibrosis. This is specific for predicting a fibrotic evolutions in any patients of ET, BV, or even early primary myelofibrosis. Also very interesting that a new immunohistochemical staining for megakaryocytes, it's CAL2. This can establish clonality, and it's correlate with the presence of a mutation of CAR reticulin in that patient. This is helpful as a rapid assessment screening and also in a low resource setting. It's very important to screen the patient for additional mutational positivity, especially as that some mutation carry a worse prognosis as SLX1, AZH2, IDH1, 2, and SRSF2. Mutation in TP53, of course, it's associated with leukemic transformation and unfavorable prognosis. They added this a nice table about the different prognostic score system. We know that IPSS can be used upfront at the time of diagnosis. However, others can be applied through the patient disease. The DIPSS plus include the karyotype abnormality, the MIPSS, the 2 version. We need the mutational analysis to use it, and it's very helpful to predict the disease prognosis. GML, as we said, now they include it under the MBN, and it's considered as a childhood MBN. We have an updated criteria. We have an updated criteria as the mandatory. We need to rule out presence of KMT2A rearrangement. They removed the monosomy 7 from cytogenetic criteria and emphasize more on the significance of diagnostic molecular study for RAS pathways. So for diagnosis of GMML, we have clinical, hematological, and laboratory criteria. We have 5 criteria that all required to be present. Persistent monocytosis, less than 20% blast or blast equivalent, presence of extramedullary infiltration like splenomegaly, no Philadelphia, no MLL gene rearrangement or KMT2A. And also, we need at least one of mutational component in RAS pathway or non-RAS pathway. In case that we could not meet the genetic criteria or the genetic testing is not available, then we need two of the other criteria as increased hemoglobin F, left shift in the peripheral blood, thrombocytopenia with bone marrow hypercellularity and dysplastic changes or no dysplastic changes in the bone marrow, and hypersensitivity to the GCSF. For chronic eosinophilic leukemia, now we have changed in the name. Before we call it chronic eosinophilic leukemia NOS, so we don't need to call it NOS anymore. Also, they removed the alternative criteria for absence of clonality. Before we say that if the blasts increase more than 2 in peripheral blood or up to 19% in the bone marrow, this is enough even if we don't have a clue to the clonality. And also one of the very important changes that they shortened the period for sustained eosinophilia. In the last edition it was 6 months and now it's 4 weeks. However, we need at least 2 reads of persistent eosinophilia more than 1.5. We need evidence of clonality, abnormal bone marrow morphology, and not meeting any other WHO criteria for other defined diseases. Diagnostic criteria for MPN-NOS is still retained in this edition of WHO. We required 3 major criteria and we need to rule out 2 other criteria. So we need a feature of MPN, either a clinical feature, patient presented with splenomegaly, laboratory criteria, peripheral leukocytosis, or increased proliferation of the cell of the blood elements, or morphological criteria in the bone marrow, hypercellularity, abnormal megakaryocyte, clustering, fibrosis. If this is available, and we could not, and the patient is not meeting a defined MPN criteria for other non-MPN, and we ruled out other criteria for MPN, MDS, MPN, MDS, or others. And if we have a presence of JAK, karyotypin, MPL, this is enough to call the patient MPN-NOS. However, we need to rule out that the patient don't have any history of cytotoxic or growth factor therapy, and also we need to evaluate the patient clinical data, and we need adequate bone marrow specimen correctly to evaluate. If we don't have enough data, if you are in a reference center that you cannot reach the clinical information, or if the bone marrow specimen is suboptimal, then we can put it under the NOS until we provided with a better sample for final diagnosis. However, everything needs to be documented in the bone marrow report. Nothing changed about the chronic neutrophilic leukemia. For myelodysplastic syndrome, of course, myelodysplastic syndromes is a presence of cytopenia in at least one of the hematobiotic lineage, and this is a requirement for the diagnosis. Also, it's recommended that the threshold is the same, which is 10% in all lineage. In this edition, they changed the name from myelodysplastic syndrome to be myelodysplastic neoplasm, but they kept the abbreviation as MDS. And also they defined the cytopenia to be similar in clonal cytopenia of undetermined significance, MDS and MDS-MPN. So hemoglobin of less than 13 and less than 12 for females, and platelet less than 150, absolute neutrophils count less than 1.8 is a definition for leukopenia. For classifications of MDS, now we have 2 major groups instead of the risk-based subgroups based on blast percentage, presence of ring-cell blast, and also cytogenetic and molecular abnormality, and lineage, number of lineage affected by morphological dysplastic changes in the bone marrow, which we've been used in the last edition. So now we have two major criteria, MDS with defined genetic abnormality and MDS that morphologically defined. So in the genetic abnormality, we have the 5q deletion with low blast and low blast with SF3B1 mutation. And both of them, the blast in the bone marrow is less than 5 and less than 2 in peripheral blood. Of course, we need to confirm the cytogenetic abnormality with 5q or absence of 5q deletions and monosomy 7 and the presence of SF3B1. So if the patient have, the 5q is superimposing the SF3B1 and both of them is superimposed by the presence of TP53, which is the third category, MDS with biallelic TP53 inactivations. Also, it's required less than 20% blast in the bone marrow and peripheral blood. Those patients are usually present with complex karyotypes, and we need to prove positivity of TP53 mutation either by karyotype or by molecular study. Until we receive the result of cytogenetic and molecular, we can define the patient based on morphological subcategory, MDS with low blasts and MDS hypoplastic or hypoplastic MDS, again with a low number of blasts in the bone marrow and peripheral blood. And we have MDS with increased blast, and now we call it MDS increased blast 1 and 2 instead of excess blast 1 or 2 in the last edition. They retained the same cutoff of blast percentage as last edition, and also presence of our rods in the peripheral blood for excess blast or increased blast 2. Under this category, which is increased blast, if we have a bone marrow fibrosis, then the patient can be diagnosed as MDS with fibrosis, and as you can see, with the same blast percentage. They defined a hypoplastic MDS as less than 25% bone marrow cellularity age adjusted. They retained that, they kept it as an option to call the subtypes of MDS with low blast and ring sideroblastosis instead of low blast with SF3B1 mutation, or we can use it in the beginning if the ring sideroblast is more than 15 or if the patient is negative for SF3B1 mutations. So it's an optional to use this diagnosis, especially in, if the genetic testing is not available. They stressed more that the published data suggests that MDS with biallelic TP53 may be regarded as AML equivalent and for therapeutic consideration and study. Distinction between single lineage or multi-lineage is optional now in the diagnosis, is not that of important. MDS unclassifiable now is removed from the category, from this classifications. They explain more about the boundaries between MDS and AML. It's softened now, however, they stress more on keeping the 20% cutoff for diagnosis of AML. They explain more in this as there is no gold standard now for the enumeration of MDS. Most of the centers, they don't have that well-trained pathologists for enumerations. We know that flow cytometry will give always a lesser percentage for blast in comparison to the morphology. A quality of the sample submitted for patients with MDS, especially if the bone marrow is packed and we have fibrosis, usually we receive a diluted bone marrow aspirate. So this will reduce or concentrate the percentage of blast. And also to avoid over-treating of patients, so they still need the 20% cutoff for blast to diagnose the patient as an AML, unlike the ICC classification.
5 minutes more, Dr. Nahla.
I'm almost closing. They mentioned that there is a broad agreement that MDS increased blast to may be regarded as AML for therapeutic and clinical trial classification. Childhood myelodysplastic syndrome, we have a change in the terminology, also subtypes. We have a childhood MDS with low blast, and we have also a hypocellular subtypes and NOS, and we have the childhood MDS with increased blast. The change in the name is stress more on the difference between the MDS in pediatric and adult as different disease entity. MDS MPN quickly. There is a major revision in the diagnostic criteria for CMML, and there is also renaming and change in the terminology of other MDS MPN. The diagnostic criteria for others, it's not that change broadly. However, they rename atypical CML as MDS MPN with neutrophilia to avoid misconceptions and confusion between CML and atypical CML. As we mentioned, that MDS MPN with ring sideroblastosis and thrombocytosis redefined based on the presence of S3B1. However, it is acceptable to call it like this until we receive the result of mutational analysis. And they removed the term unclassifiable and changed it with NOS. For the diagnosis of chronic myelomonocytic leukemia, now we have the prerequisite criteria, which is mandatory, that every patient sustained a high monocytosis and decreased blast percentage below or blast equivalent as a bromonocytes less than 20%, and not meeting any diagnostic criteria for other MDS, MPN, or MBN, not meeting diagnostic criteria for MPN, MDS with eosinophilia. We need a supporting criteria for this, either presence of dysplastic changes involving more than or at least one myeloid lineage in the bone marrow, presence of acquired clonal cytogenetic molecular abnormality, abnormal partitioning of peripheral blood monocytes. They included what we called before oligomonocytosis, which is list 0.5 increase in the peripheral monocytes above the 0.5, but less than 1 absolute count. And in that case, we need at least 2 supporting criteria to call the patient as CMML. So if the patient presents with sustained monocytosis more than 0.5 absolute count, then we need a clonal, approved for clonal cytogenetic and molecular abnormality and the dysplastic changes in the bone marrow. Still, we have the subgroup criteria for MDS CMML and MPN CMML, and they removed the CMML 0 before, which was peripheral blood less than 2% blast and less than 5% in the bone marrow. Now we have only the CMML 1 and CMML 2 with the same blast percentage as the previous edition. This is what they explain about the partitioning of the monocytosis. This test is done by flow cytometry, entertaining the monocytes with CD14 and CD16. And in case of CMML, we have increase in the classic monocytosis, which is 14 positive, 16 negative. However, in case of reactive monocytes, we will have a good percentage of intermediate stage monocytes and also non-classical monocytes with positivity of 16 and dim to negative CD14.
Excuse me, Dr. Nahla, 2 minutes more.
So in case of CMML, we do the flow cytometry analysis for partitioning. In the peripheral blood, we found that more than 94% of monocytes are falling within the classical monocyte. This is a very sensitive and specific testing for diagnosis of CMML. However, in case that the patient have other autoimmune, other inflammatory disease, this cannot be applicable. They mention some other alternative tests. They call it SLAN positive monocytes. In the SLAM-positive monocytes, usually the healthy donor will have some positivity in SLAN together with CD16. In case of CMML, we don't have a SLAM positivity, and also in case of inflammatory process for a patient have CMML together with autoimmune inflammatory, SLAN also can be negative. So this is other alternative if in case that we cannot apply the partitioning due to presence of autoimmune or inflammatory disorder. This is the end of my talk. I would like also to thank you for your attention, and there is more in the online version. We are still waiting the printout for the WHO 5th edition. We think that it's taking too long time, but it's a good alternative if you would like to visit the websites and explore more. Thank you.
Thank you very much, Dr. Nahla, for your enriching, comprehensive presentation. Thank you. We will keep the question till the end of the session.
It's my honor to present our next distinguished presenter. Dr. Arij Al-Mugheri is a fellow of Royal College of Physicians and Surgeons of Canada. She completed a residency training in hematopathology and transfusion medicine at University of Alberta, Canada, followed by 2 years of fellowship for flow at the University of British Columbia. She is currently the head of Hematopathology Division, Department of Pathology in King Abdulaziz Medical City, Riyadh. She is the first and the senior author of many publications. She has also an interest in expanding her knowledge in flow and molecular pathology. Please go ahead.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning, everybody. Thank you, Dr. Reem, for a nice introduction. Thank you for the invite. It's my pleasure today to talk about acute leukemia of ambiguous lineage. And during this talk, I'll be covering the diagnostic update, the genetic aspect, and a few challenging cases, diagnostic tips and pitfalls. So acute leukemia of ambiguous lineage are those leukemias that show evidence of commitment to more than one lineage, or fail to show the evidence of commitment to myeloid T or B myeloid lineage. It consists of mixed phenotype leukemia, or MBAL, and acute undifferentiated leukemia, or AUL. MBAL represent less than 3% of acute leukemia, and the outcome generally is poor based on few retrospective studies, and therefore it's considered high-risk disease. It can be B myeloid, which compose the vast majority of cases, or T myeloid, and rarely TB or trilineage leukemia. Acute undifferentiated leukemia is very rare, and the blasts usually co-express immaturity marker, and they lack the specific lineage antigen, but they may express a single myeloid or a lymphoid-associated antigen. And it is very important to exclude uncommon hematobiotic neoplasms such as BBDCN, megakaryoblast and basophilic leukemia. So the recent classification of WHO included two broad categories of MBAL. The first is MBAL with defining genetic abnormalities, including the previously known MBAL with BCR-ABL and KMT2 rearrangement. And they have newly added two new sub-entities, MBAL with ZNF384 rearrangement and BCL11B. The second category is MBAL immunophenotypically defined and includes B myeloid, T myeloid, rare, and not otherwise specified category. So as you are aware, the first diagnostic scoring system was proposed by European Group for Immunologic Classification of Leukemia, abbreviated as EAGLE classification, and it consists of a large list of markers, and each marker assigned weighted score depending on how strongly that marker associated with the lineage. For example, CD79A considered a strong marker, and that's why for B lineage, and that's why given score 2. So biphenotypic leukemia was diagnosed if the score is more than 2 for more than one lineage. And it's worth mentioning that the positivity for the antigen in that scoring system was defined as more than 10%. That was modified by the WHO classification, and as you can see, the scoring system was eliminated, and the long list of markers was shortened as well to include only the specific marker and the frequently associated marker. So for B lineage, assignment, we need strong CD19 and more than one B lineage associated marker. If the CD19 is weak, then you need more than 2 B lineage associated marker. For T-cell lineage, you need surface and cytoplasmic CD3. For myeloid lineage, you need MPO, or more than 2 monocytic differentiation marker, including NSA, CD11C, CD14, 64, and lysozyme. And there was no minimum positivity threshold for any of these markers, and also the antigen intensity expression was not objectively defined. So even with the WHO stringent criteria for diagnosis of ALAL, acute leukemia of ambiguous lineage still pose a diagnostic challenge for most of the pathologists, as we have no consensus yet about the minimum threshold for percent-positive antigen cells in biphenotypic leukemia, especially for the markers that show nonspecific and autofluorescence, such as MBO staining. Also, in the presence of minor cell population fulfilling the criteria of WHO for lineage assignment in the setting of BLL, also there was no objective definition of antigen intensity. Also, the discrepancy between the methods that used within a lab for assessing antigen expression, such as immunohistochemistry and flow cytometry, was not addressed in the previous classification. So the most updated WHO classification has addressed some of these issues related to antigen expression intensity as they define the strong expression as more than 50% or more than 1.5 log of the normal cell population above the background. So looking at the MBO dot plot here, the blast is in the dark green. So by plotting an imaginary line between the true negative population and the true positive population for MBO, you can see that the blast is reaching or exceeding the mid-half of that line and qualified for strong positive expression. So how about BLL with isolated MBO? We know that MBO is a specific marker for myeloid lineage. However, it has been reported to be positive in a small subset of BLL, and that terminology was used by WHO previous classification and defined as homogeneous blast population of typical BLL immunophenotype with weak expression of MBO. However, the expression of MBO was not properly defined, and the clinical significance was or is still controversial. So this is a recent abstract by Brentwood. They looked at 100 patients with MBAL. The majority are of B myeloid lineage. And they describe different pattern of MBO expression and he used the intensity of more than 50% of normal population and above background as sufficient criteria to assign lineage in MBAL. And using that threshold, interestingly, he found that more than half of the cases he reviewed that was classified in the previous classification as B myeloid MBAL are actually B myeloid MBAL with isolated MBO expression. And that was defined by him as a weak aberrant expression of MBO, which is less than 50% of the true positive population and above the background. Okay. So this is a recent study by Euroflow. They looked at more than 1,000 of acute leukemia, ALOT analysis, and they tried to assess the diagnostic performance of MBO using percent positive population compared to mean fluorescence intensity or median fluorescence intensity, which is representative of antigen intensity expression. And they find that MBO positivity of more than 20% of acute leukemia exceeding the lymphocyte threshold are actually performing greatly compared to the median fluorescence intensity or mean fluorescence intensity to differentiate the MBO positive versus MBO negative leukemias. As you can see here in that graph, we have here the MBO positive leukemia and MBO negative leukemia. The MBO percent positive cutoff of more than 60 able to distinguish these two groups compared to the median fluorescence intensity and mean fluorescence intensity. And actually by using that 20% positivity cutoff, they find that 98% of ALL are actually MBO negative. So how about the genetic aspect of the disease? And again, this is a nice work by Alexander et al. They looked at more than 100 childhood ALL, and they did a comprehensive genomic analysis, including whole genome sequencing, transcriptome, and WIS as well. And they find that most of MBAL cases harbor mutually exclusive mutation of WT1, ETV6, RUNX1, and CYP-A as well. And we know that these mutations are shared by ALL as well as AML. And interestingly, they find that ALL overlap with other defined leukemias, not only in the immunophenotype level, but also at the genetic level. So as you can see here, they find that B myeloid MBAL share ZNF384 rearrangement as well as KMT2A rearrangement with BLL, and also T myeloid MBAL share BCL11B and KMT2A and FLT3 mutation with ETB, ALL, and MLL, and AML, sorry. So how about MBAL with ZNF384 rearrangement? It represents about half of B myeloid MBAL and 10% of BLL. They have different fusion partner that dictate different disease phenotype. They have a characteristic immunophenotype similar to KMT2A gene rearrangement, which is weak or negative CD10 and aberrant expression of CD13 and 33. Interestingly, they have higher expression of FLT3 mutation, and this may play a role in the management of these patients. Also, ZNF384 rearranged BLL are prone to lineage switch post-chemotherapy. So how about lineage switch? It can occur at relapse or even during therapy. The most common is lymphoid to myeloid, or rarely the opposite or even to ambiguous lineage. It was reported frequently post-targeted therapy, CD19 CAR T cell or blinatumomab. And this is one of the largest study looking at more than 160 BLL treated with CAR T therapy. and 7% of them demonstrated lineage switch, and more than 2/3 of them harbor KMT2 rearrangement. Lineage switch can be due to clonal evolution, transcriptional factor reprogramming, or subclonal selection secondary to therapy. It has been frequently reported with KMT2 rearrangement and ZNF384 rearranged leukemia. And now we will go through a few challenging cases. The first case is for a 16-year-old male, KMT2 rearranged BLL, and he was transplanted. This is his day 170 post-allogenic stem cell transplant. And looking at the dot plot of forward side scatter versus side scatter, we know that forward side scatter gives an indication of cell size, while side scatter is for cellular granularity. So you can see that we have uniform homogeneous blast population with a small to medium size and low side scatter. They are CD45 dim. They co-express CD19, but they lack CD10, and they have partial expression of cytoplasmic 79A. They have dim TDT expression, 34 positivity, and they lack CD33 myeloid marker, monocytic markers such as 64 and 11C, and also MBO expression. And these blast population also, they show aberrant CD15 expression. The bone marrow morphology show medium-sized blast, and the flow was consistent with BLL with aberrant CD15. The FISH studies came back to be positive for KMT2A rearrangement. So the final diagnosis was BLL with KMT2 rearrangement in relapse. This patient received flag induction, and 2 weeks was flag induction. He had persistent blast, and that was his bone marrow was repeated. And as you can see here, in the flow, in forward side scatter and side scatter, we have two blast population. The first one has small forward side scatter and small side scatter. The second population has higher forward side scatter and lower side scatter, indicating small and large population. Forward side scatter, CD45 with side scatter also indicated presence of two population. The red population has lower side scatter. The green has higher side scatter. If we focus on the red, they co-express CD19, but they lack CD10, partial expression of cytoplasmic 79A. Also, they co-express CD22. And looking at that plot, we can see that the blast has bifurcation, and that pattern has been described frequently with BLL as that population, they co-express CD34, but they lack the myeloid marker, while the gray population here, they show CD33. And looking at the monocytic marker, 64 and 11C, it was also expressed. CD13 was positive as well. Also, if you pay attention to the MBO, we have about 18% of blasts co-expressing MBO. So the cytogenetic also came back to show translocation for 11 with an additional clone. So the final diagnosis was B-myeloid embal with a KMT2 rearrangement, secondary to lineage switch from BLL with KMT2 rearrangement during the second induction. And this is really important because the lineage switch happened within 2 weeks from previous relapse. And I think this has a huge implication because currently we are using Euroflow. Most of us use Euroflow, and we focus usually at the diagnostic panel. So if at that time we didn't use the Euroflow, so we run the whole panel including AML and BLL. So it's very important to do full panel for at least for KMT2 rearrangement to avoid missing lineage switch. Okay. So the second case, it was for 18-year-old male with history of TLL, relapsed, and he is now cytopenic, and the flow cytometry post-induction in another center showed query TB imbal or lineage switch. So we run the flow, and you can see again that we excluded the doublets, focusing on the singlet, looking at the forward side scatter and side scatter. We have the red population here representing the blast, homogeneous, uniform with variable forward side scatter from the small to large. They are dim in CD45. They co-express cytoplasmic CD3, and it's really strong compared to the normal control. In the blue here, we have T lymphocytes. Also, they co-express CD13, but also, interestingly, they show CD19 expression, similar to the referral center. Also, CD79A was partially expressed. However, this is a diagnostic pitfall. CD79A cannot be used in the setting of TLL as a diagnostic or a lineage assignment marker for TLL. And the caveat for that it is frequently seen with TLL. Also, these populations are bright positive for CD7. They lack CD10 and CD22 as a B associated marker. And they show weak CD5. They co-express myeloid antigen 13 and 33. They lack 117. And they are negative for 1A, TDT, and CD20. So what is the diagnosis? Also, we send for immunohistochemistry for BAX5, and it came back to be negative as another confirmatory test that there's no B lineage assignment criteria here. So the final diagnosis was early T cell precursor TLL or ATB with aberrant CD19. And this is really important as we know that this subtype of TLL, usually they have poor response to the induction or positive MRD.
You have 5 minutes, Doctor.
The last slide. So for the diagnostic tips and pitfall, in relation to the assay and in relation to the flow cytometry assay, it's very important to have the test optimized in relation to compensation, BMT voltage optimization. Also, the flow lab must follow a quality assurance system on daily basis. It's very important to have a good knowledge about the performance of antibody used, as we have different clone and different conjugate, and each clone react differently to and gives you different signal of the antibody. For the analysis, it's very important to use forward side scatter with side scatter to identify the different size population. Also, it's very important to show the normal counterpart population to be able to visualize the antigen expression, intensity. Also, the most important thing, as we demonstrated in the previous cases, that MBAL show antigen expression heterogeneity and coordinated antigen expression pattern compared to the already defined leukemia, such as ALL or AML. Also, it's very important to interpret the result cautiously with the cytogenetic and molecular results, knowing that some of well-defined entity of leukemia can show lineage infidelity, such as core-binding leukemia, AML with MRC, and CML in blast phase, or Philadelphia-like leukemia, and these are well-defined entity and should not be considered as MBAL. Lineage switch can be a diagnostic pitfall as well, as we show in our cases, and it can be missed if the focus is only on the diagnostic panel, especially with KMT2 rearrangement cases. Okay, thank you very much.
Thank you, Dr. Arij. Our next speaker is Dr. Ghalib Al-Yamani. Dr. Ghalib Al-Yamani had obtained his medical degree in 1993 from Cairo University, Egypt. After obtaining his PhD in hematology at the blood banking in 2005, Dr. Al-Yamani joined the Canadian Fellowship Training Program of Hematological Pathology at the University of Toronto, the Hospital for Sick Children, Division of Hematopathology. His clinical fellowship training was completed in hematological pathology between 2007 and 2009, leading to Fellowship of College of Physicians and Surgeons of Ontario in hematopathology. Dr. Al-Yamani is reviewer in many medical journals, including Annals of Hematology, Italian Journal of Pediatrics, Annals of Hematology and Oncology, and he has many publications, mashallah, more than 100 publications in peer-reviewed and high-impact journal as Neuro-Oncology, Modern Pathology, Hematologica, and others. Currently, he is a consultant of hematopathology at Prince Sultan Military Medical City, Riyadh. Dr. Al-Yamani will speak about plastic plasmacystoid dendritic cell neoplasm. Welcome, Dr. Ghalib.
Assalamu alaikum. Good morning, everyone. Thank you for scientific committee to inviting me for this lecture, and thank you, Dr. Amona, for nice introduction. So we will go today and overview plastic plasmacytoid dendritic cell neoplasm, PBDCN. So as we know, this entity is a new entity in the WHO and subjected to the many nomenclature and different classification. It is a malignancy of plasmacytoid dendritic cells, precursors. It is a clinically aggressive disease. Clinically aggressive. Let me use this one. Okay, it is one of the frequent association with the skin lesion and involve also in the bone marrow and the peripheral blood. As plasmacytoid dendritic cell is the most common dendritic cells in the peripheral blood. They produce in the bone marrow, circulate in the peripheral blood, and the trafficking in the skin, and accumulate in the lymph node during immune response to the viral infection. It is create different type of interferon 1, type 1, interferon alpha and beta. Okay, so if we go through the different nomenclature and the classification of PBDCN across the first case described 1995 as a granular CD4 NK cell leukemia based on the granular presence of granules in the cytoplasm and the expression of 56. In 2001, WHO excluded under the plastic NK cell lymphoma based on the immunophenotyping of CD56 and the plastic morphology in the majority of the cases. In 2005, it is renamed again under CD5, CD56 hematodermic neoplasm based on the frequent association with skin involvement. And in WHO 2008, it is classified under myeloid neoplasm and acute myeloid leukemia. And 2016, it is retained in the WHO under myeloid and acute leukemia without changes. However, in the upcoming version of 5th edition, there is some important changes happening for this type of neoplasm. The first change is it is moved to the histocytic and dendritic cell neoplasm, so it is regrouped and repositioned follow the myeloid neoplasm based on its origin from the common myeloid precursors, and it is moved to the standalone chapter in this as a single entity. and a new entity is added, mature plasmacytotic neoplasm proliferation associated with myeloid neoplasm, most commonly is CMML. So if this is a screenshot of WHO, if you look to the number 3 is histocytic dendritic cell neoplasm, and it is positioned under myeloid. And if we go to the plasmacytoid dendritic cell neoplasm, we see plasmacytoid dendritic cell neoplasm plastic type is a single entity with additional of a mature plasmacytoid dendritic cell proliferation, which is associated with myeloid neoplasm. So the epidemiology is not clearly clear, because as we mentioned in the first part, it is subjected to the different nomenclature, different classification. So the exact incidence is not clear. However, it is a rare disease. Sorry. Off. Can you please come? I need help. I don't know what's happened for this one. Okay, sorry. So as mentioned before, so it is represent less than 1% of the acute leukemia, and 0.7 of acute cutaneous leukemia, and this is half. The majority of cases are usually more than the age is usually more than 70. However, there is bimodal age distribution, as reported recently. There is some cases below 20 years in the pediatric age group. So it can affect race and geographical. One of the interesting is 75% of the cases are male, and the median age usually between 60 and 70. So in recent publication, it can be occur in most common in adult, but can be also occur in pediatric age group with some difference. There is no male difference between in pediatric age group. 55% only are male, whereas in the adult, as mentioned before, more than 70%. The CR rate is in the pediatric is better than the adult. Relapse rate also is less than in pediatric, 27 compared to 56 in the adult. And however, overall survival, there is no significant difference, 12 months in pediatric and around 7 months in adult. So the interesting issue in such a type, it is acute as malignancy. It is belong to the myeloid, as have origin from the myeloid common precursor. However, it responds well to the to the ALL-like protocol in both adult and the pediatric, but in pediatric is better. And even lymphoma-like protocol have good outcome for this type. And the third one is AML, which is some finding interesting. Okay, the clinical presentation as any leukemia presented by bone marrow or peripheral blood more than 60% up to 90%. One of the skin affection is more than 90%, which is characteristic for this type of tumor, and can be affect lymph node, spleen, or other CNS. CNS is affected at time of presentation around 8%. So as mentioned, it can be affected bone marrow more than 90% and also affects associated with the skin lesion, usually present by skin lesion more than 90%. However, CNS, as mentioned, at diagnosis maybe around 10, and at relapse more than 30% in patients with BPDCN. So this is why CNS prophylaxis is important at diagnosis and relapse in such a case. Okay, if we go to the dermatological presentation, it have multiple clinical manifestation and multiple clinical lesion. There is no specific lesion can be present by nodule, can be present by bruises-like, can be present by hyperpigmentation, can be present by hypopigmentation. There is no any specific lesion. Can be any patient maybe have mixed lesion, but the nodular type is the most common. As acute leukemia, there is overlapping with, as a leukemic presentation, as overlapping with all hematologic malignancy present by bone marrow involvement, blast in the peripheral blood, cytopenia, bleeding tendency, bruises, also can affect CNS. In the literature, there is interesting finding is there is 10 to the 20% of the patient have a history of hematologic malignancy during or before or after BDCN. So there is association with myeloid malignancy, but it is not clearly understood. So if we will go, what is the key point of the previous study? BPDCN is a rare disease with large male predominance. It is a systemic disease, can involve any organ, especially skin and bone marrow. A skin lesion more than 20% and usually precedes the bone marrow. It is the outcome, although it is sensitive to the chemotherapy, but the outcome is poor, and the ALL regime is best more than AML protocol. So as it is a rare disease, what is the diagnostic challenge of this type of malignancy? There is a delayed, and in the literature, more than 6 months delayed in the diagnosis of BPDCN was for different reasons. As a reality of the disease, clinical overlapping with other conditions. It is heterogeneous presentation from single indolent disease to the multisystemic broad differential diagnosis. Clinician unaware of the fullness of symptom. The common issue is incomplete requisition, sheet requisition for the clinical and the presentation, which is very important for pathologists, because if the pathologists deal with a case of acute leukemia and there is a skin lesion, the approach will be a little bit different from without skin lesion. So because we know with some leukemia associated and the malignancy associated with a skin disease, like this type of malignancy, maybe T-cell lymphoma, maybe. So the clinical, such if you a little information about there is a patient with a skin disease will very helpful for the pathologist to in the approach. So in addition for this one, there is diagnostic challenge for pathologists. So what is the diagnostic challenge for our colleague? The first is similarity. It looks like the morphology looks like any acute leukemia. There is variant immunotype, variant immunophenotyping similarity or overlapping. There is complete panel. It is not available in the majority of the institute, which is a major issue for pathologists. Usually, case is not integrated because there is no lack of clinical communication and history and so on. Also, high sign-out volume for the majority of the pathologists, limited contact with clinicians to discuss such cases. Fail to adding immunophenotyping is the proper for immunophenotyping. Also, this type of malignancy subjected to the post-transplant or post-treatment immunophenotyping shifting. Also, MRD assessment is very difficult, especially if we have mature plasmacytoid dendritic cell proliferation, which can overlapping. Also need expertise in dermatologists or hematopathologists. So why this type of malignancy, BPDCN, is subjected to delay? Because this is, as mentioned before, if you look to the literature, more than 6 months is delayed, because this is a common scenario for such a case. The patient first presented to the with the skin lesion, hyperpigmentation, nodule, whatever it is, and they go to the primary care. For the primary care will transfer it to the dermatologist. Dermatologist usually start by local medication for a couple of weeks, and after a couple of weeks, the patient come back to them with no improvement. So the dermatologist will think about skin biopsy. Skin biopsy will done, and will see the marker is order. And also, because this type, all specific marker will be negative, usually the hematopathologist, the dermatopathologist will consult a hematopathologist for consultation. And after, if the diagnosis is made, will be transferred to hematology oncology. Hematology oncology will do workup, and diagnosis will be final, and they discuss the treatment plan. All this journey usually take, if just 1 week from one to other, it will take more than 6 months. So this is the diagnostic criteria for WHA, because it is refined before. It is not clearly. Now it is WHO have clear criteria for diagnosis, which is this is expected positive marker to be positive, CD123, TC4, TCL1, CD303, 304, CD4. This is marker expected to be positive, and this marker expected to be negative, which is a specific lineage. You have to exclude, because also you have to exclude which is myeloid leukemia and lymphoid leukemia, and also mixed phenotype leukemia and other ambiguous leukemia. So this is the criteria will be discussed in the next slide. So the bone marrow commonly involved more than 90%, maybe interstitial, maybe nodular, maybe diffuse. Different pattern can be seen. Peripheral blood usually have blast. Skin lesion, more than 90% of the cases associated with a skin lesion. Lymph node be affected. If you have to, in your first panel of acute leukemia, you have to put 123 CD4. If this is 3 marker is positive, and the specific marker MBO 79A or 19, and surface CD3 and cytoplasmic CD3, which is a specific marker for trilineage, in such a case you have to include the other marker, which is available, TCL1, TCA4, and the CD303 or 304. So in such a case, you have to think about both your BPDCN and your differential diagnosis. This is how the lesion appear in the skin. Usually as acute leukemia, there is no specific character. Immature cells, blast undifferentiated with dermal infiltration. This is very important to say. Be careful about the skin biopsy. Should be deep and include dermis and epidermis, because this type of leukemia usually is bare epidermis. Okay, this is different morphological varieties of BPDCN. In a simple way, it is a heterogeneous, no specific morphology, maybe ALL, maybe ALL morphology, maybe monocytic morphology, maybe have pseudopodia, like different type of leukemia, maybe have vacuolation, maybe have central nucleus, maybe have eccentric. So in a simple way, it is a heterogeneous morphology. There is no specific. Also, maybe some microvacule in the cytoplasm under the cytoplasmic membrane, maybe against pseudopodia, maybe monoplastic, maybe, so it is a heterogeneous. There is no, the morphology, usually it is a blast-like morphology. Okay, this is the bone marrow biopsy, how it appear. Again, immature cells, variant nucleoli, small to medium size, heterogeneous, maybe rounded nuclear, maybe irregular nuclear contour. So there is no morphology, it is just acute, similar to the any morphology of the blast. So, as mentioned before, there is 3 important markers for BBDCN, and the F is the 3 markers CD1, 123, CD4, CD5. If they are positive, you have to put the BBDCN as one of the differential diagnoses, provided the other specific marker is negative. This is a diagram show the specific immunophenotyping for BBDCN, CD123, 56 for CO3, CO4, and the most important and the most new marker TCF4, which is a nuclear marker, and TCL1. So, what is the flow chart, or what is how to approach a case of BBDCN? As mentioned before, if you have this specific marker, which is T cell marker, B cell marker, myeloid marker, monocytic marker is negative, and we have 123, HLDR, CD4, 56 is positive, you have to include a specific marker for plasmacytoid dendritic cell, TCL1, CD03. If one of this marker positive with this marker, now we can make the diagnosis of BDCN.
Excuse me, 5 minutes more.
Okay, so 123, it is a plasmacytoid dendritic cell marker, however, can be expressed in the basophil, eosinophil, or monocytes. So we can detect it by flow cytometry or by immunophenotype. Is 138 is only plasmacytoid dendritic marker? Unfortunately, it can be expressed in different varieties of leukemia. Can be CML, myeloid, lymphoid, myelofibrosis, even hairy cell leukemia, non-Hodgkin. So it is not a specific marker, but usually in plasmacytoid dendritic cell marker, it is highly strong and with high expression. So this marker is published. This study published in recently. To diagnose BBCN, you have to have this marker as positive, and one of this marker should be negative, with the frequency almost, if you see, around 100%. This marker should be negative, but in a very rare cases, maybe this 79 ALX to the 20 can express. This marker should be negative. However, there is a very common expression, 43 TDT in 30%, more than 30%, 68 also is positive, and the myeloid marker 33. So be aware, so one of the top differential diagnosis, as Dr. Arij mentioned in the first, is ambiguous leukemia, also one of the differential diagnosis. So also be aware about there is maybe one case can present this study in 61 cases. There is 9 cases express myeloid, maybe lymphoid as a single lineage to be, maybe overlapping myeloid and lymphoid, and even in 4 cases express the trilineage. So apparent expression is very important. This is a case of how flow appear in the blast, low for 45 dem in the blast gate, strong expression for 1 to 23 HLDR, 56 is positive, variable expression of 38, 303 is positive with commonly expressed CD7, 4 is positive, myeloid, monocytic, 43 is negative, and CD2 and 43 is negative. So this is, as mentioned, this is a new marker, TCF, it is a nuclear one. Usually around 100% is specific and sensitive, and can be, if it is combined with 123 as a double stain, usually it is 100% positivity in BBDCN. This is how double stain appear. TCF will appear as a brown, and CD13 is usually red in the surface, and this is 100% specific for BBDCN. So the top differential diagnosis I mentioned is ambiguous leukemia, acute myeloid leukemia, 56, especially if 56 is positive and the MBO is negative. This is a very difficult challenge. ALL and myeloid sarcoma, leukemia, cutaneous T-cell lymphoma, any malignancy with T-cell is as the differential diagnosis, but if we are integrate clinical with immunophenotyping with the full panel of plasmacytoid dendritic cell, usually we can reach the diagnosis.
1 minute more.
Okay, so the diagnostic channel with what's called the mature plasmacytic dendritic cell proliferation, which can be associated with myeloid leukemia, or can be present after recovery during remission, which is because BBDCN and the mature plasmacytoid dendritic cells share the same immunophenotyping. However, LUCA-I7 and the positivity of CD03 favor mature plasma cell. However, 56 positivity and the loss of CO3 and the high KX7 favor plasmacytoid. Also, MRD assessment is a very difficult challenge with in case of proliferation of mature plasmacytoid. If we go to this table, it's very helpful to differentiate between BBDCN and the reactive plasmacytoid dendritic cells. 100% is CD2 positive in reactive one, and also CO3. However, this is variable in BBDCN. Also, be careful about post-treatment shifting after treatment. And genetic mechanism is a complex. We can find myeloid and the lymphoid, and all are, there is no specific genetic, can be lymphoid, can be myeloid, or as you see, maybe there is no specific for any myeloid or lymphoid. And this is the common chromosomal abnormality are affected, and usually the loss is the most common abnormality, and this is the treatment, anti-CD 1, 2, 3, and this is my summary, and thank you.
Thank you, Dr.
Thank you, Dr. Al-Yamani. It is my honor to present my colleague, Professor Heba Raslan, is a respected faculty member of the NCI, National Cancer Institute, Cairo University, where she has been a full professor since 2010. She is currently serving as a consultant and hematopathologist at KFSH Dammam, where she actually started the flow cytometry service. She also was the section head of both flow and hematopathology. She holds a medical doctorate degree in hematology and oncological hematology, as well as extensive experience in hematological malignancies flow cytometry. She is a skilled leader and maintains high quality standard and expert in accreditation with JCI, CAP, and CBAHI. She has published over 30 research papers in international and national journals and presented numerous abstracts. She is a speaker of many conferences, workshops, and advisory boards. She has also attended more than 50 conferences and workshops. She is an accomplished and respected professional in her field. Dr. Raslan will be presenting challenging cases in myeloid neoplasms. Please go ahead.
Good morning, all. Thank you very much, Dr. Reem and Dr. Mohammed Al-Muhammadi and the organizing committee for giving me the opportunity to share this lecture here. And I can see a lot of people which from my hospital and other hospital knowing them. So in this case, Dr. Nahla have covered a lot from my lecture. We will be covering today lectures or cases, covering the cases of MPN and MPN-MDS overlap on the highlight of the new WHO edition. So my objectives here is to see understanding the key dilemmas and pitfalls encountered in diagnosis of myeloproliferative and MDS, including related accurate classification and differentiation from other hematological disorder and interpretation of the bone marrow morphology, discuss the updated diagnostic criteria and changes in the MPN and MDS in the 5th edition, and emphasizing in the incorporation of the molecular and the genetic marker for the precise diagnosis, and develop with each other a strategy, so how to skip any dilemmas or pitfalls that we can found in the MPN-MPS diagnosis by incorporation the multidisciplinary collaboration between different utilization of different ancillary techniques like flow cytometry, cytogenetics, molecular testing especially have a very big role in this 5th edition. The most important is that in the 5th edition, as seen by Dr. Nahla earlier, that they put each classification with an essential criteria and together with a desirable criteria. They put every case, every diagnosis with a specific molecular and cytogenetic features, not meeting any other type criteria, and having a different pathological and clinical features, which is approved by at least 2 peer review publications. The most important is the inclusion of the clonal hematopoiesis, which is very important as a precursor lesion for myeloid malignancies. The clonal hematopoiesis is referred to the presence of population of cell derived from the hematopoietic stem cell, harboring somatic mutation and leading to enhanced cellular proliferation under positive clonal selection pressure. Most frequently, including the epigenetic regulator gene that we can see now most commonly by the NGS, and in the absence of unexplained cytopenia, hematological cancer, or other clonal disorder. Under clonal hematopoiesis, we found the intermediate undetermined potential, which specifically to the genetic mutation with myeloid malignancies, and the clonal cytopenia, which included, again, with cytopenia, both with no previous or underlying malignancy, myeloid malignancies, or other hematological or non-hematological cases. Here is the WHO cover, and we can see some of the removed, some are changes, some is added. Our first case, and I want to share with people, if you have comment, kindly do. We received the patient with CML as a referral hospital, already diagnosed as a CML case with positive PCR ABR, and he started to this therapy. His bone marrow was done for complete CML workup. As you can see, the peripheral blood shows the left shifted with the 2 peaks of neutrophils on the myelocyte and with no blast seen. But on checking on the aspirate, we can see almost 8 to 10% blast cell with eosinophilia, basophilia, and the characteristic dwarf MIG. Kindly note that cases of MPN HU1 has a specific megakaryocytic picture or morphology. For the CML, the cells are always smaller in size than the normal, and they have hypolipated nucleus, so we call it a dwarf MIG. In this case, 8 to 10, and upon the acute leukemia orientation tube, we found that these 8% are lymphoid blasts. So by now, each case, one of the pitfalls that by now, not as before, each case of CML upon introducing to the hospitals, an acute leukemia orientation tube has to be done so that exclusion of lymphoid blastic crisis on top of CML as a presence of real confirmed lymphoblast in the peripheral blood or bone marrow, even less than 10 will be considered as lymphoid-blastic crisis on top of CML. The second case is again CML case, again presented to our hospital with a PCR-able positive for complete workup. You can see there is almost 11% blast, and again with the shifted maturation, eosinophilia and basophilia. On doing the bone marrow biopsy, the aspirate almost was low cellular. As you can see here, the bone marrow biopsy is completely hypocellular with streaming. There is diffuse and dense increase in reticulin deposition, almost streaming of the marrow and the obscuring the cellular morphology of the cell. As you can see here, there's clusters of small megakaryocyte, the characteristic of the CML. Upon doing the reticulin, it is an MF3, the CD61 confirmed the small nature of the CML, and the CD34 didn't show increase in blast cell even with the presence of this fibrosis. So for these cases, as Dr. Nahla said, they omitted the case of accelerated phase, but putting instead the addition of features with increased risk of disease progression. These are the ELIT score, the increase of the blast up to 1019, increase in basophil, additional chromosomal abnormality, and cluster of megakaryocyte. So for here, we find in this case, we find the two أنا بعمل حاجة غلط. أنا كده ماشية صح. Can you help me please? This is forward or backward. أنا راجع كده ورا. راجع كده راجع خلاص. Okay. Okay. Sorry. Sorry for the interruption. Now, for our case, for this case, we find that we have two of the accelerated phase of this disease. The third is a case of, we have this patient at our hospital. The patient was diagnosed as a case of MPN at 2012-2013 because she has sequentially DVT and ischemic stroke, followed by requesting JAK and definitely PNH. The JAK2 was positive and PNH released negative. On checking on the report received, it was normal bone marrow. So her clinician by now, after 12 years of taking apixaban and following her as a case of MPN, he wanted from us to evaluate her bone marrow. On checking on the peripheral blood, she was normalized, almost normalized of the peripheral blood, and her bone marrow aspirate was also normal with tri-lineage hematopoiesis, no increase in blast cell, no fibrosis, and nothing. The age-adjusted cellularity is very good and nothing changed. For this cases are that the patient has a normal cellular marrow showing tri-lineage hematopoiesis with no evidence of dysplasia or infiltration. Correlation with other major criteria is mandatory for establishing a diagnosis of MPN. For follow-up until sufficient evidence of more precise diagnosis. Kindly, whenever you have a case of JAK2 positive, you cannot mark the patient as MPN. Patient is currently marked as MPN with a major and a minor criteria. Otherwise, this criteria is fulfilled, don't mark him as an MPN. JAK2 mutation can be seen in the general healthy population with a prevalence of 0.2. Yes, it is associated with increased morbidity and mortality, and also with more to be develop an MPN in another situation later on in life, but unless you find the criteria, kindly don't match the patient as an MPN. For this patient, the genetic risk for clotting factor as factor V, homocysteine, folic acid deficiency, and proper history for hormone as birth control pills, hormonal replacement therapy, or inflammatory bowel disease would be much appropriate than putting the patient as an M2. Here, another patient is a case of 57 years, came to our hospital again with JAK2 JAK2 positive, but this was diagnosed as essential thrombocythemia with treatment hydroxyurea and apixaban due to DVT. This patient developed over time increase in the hematocrit level, reaching from 49 to 51, and each time there's increase in hematocrit. They do phlebotomy and so on. He put it in a bone marrow with no change, so he came to our hospital to check. The last phlebotomy was on the 23rd of August 2023, and this is his peripheral blood. His peripheral blood, definitely you can see the hemoglobin is 13, but because of the phlebotomy, the bone marrow aspirate show high normocellular or hypercellular marrow with active tri-lineage hematopoiesis, megakaryocytic hyperplasia with a background of platelet sheets. Again, the megs are variable with frequent large hyperlobated nuclear lobes. Again, ET have a specific morphological features in cases of ET. It has to be large, variable, hyperlobated, cloud-like, as if it is an onion. So this is the characteristic picture of megakaryocyte. As you can see here, a lot of a lot of megakaryocyte can be seen. Okay, I'm here. اوكي انت شفتوا الميجاكاريوسايت؟ خلاص انا مش عارفه اعمل ايه بصراحه. A lot, we can see it here. A lot of megakaryocyte here proved by 61 and no increase in blood cell. So his serum erythropoietin level was tested of 7.6. Currently, his bone marrow shows increased age-adjusted cellularity with megakaryocytic, granulocytic hyperplasia, no fibrosis, positive JAK2. So the three criteria of polycythemia vera is already fulfilled. So this patient will be put as a case of progression of essential thrombocythemia to polycythemia vera. This progression has been reported, and as a polycythemia vera is a more serious disease than cases of essential thrombocytosis. And here, the most important is the JAK2 allele burden. Most of our hospitals have the positive negative, but JAK2 allele burden is very important to differentiate between different cases of MPN. Our fifth case is a case of 47 years old, referred to our hospital with low-grade fever, weight loss, fatigue, cough, edema of his eyelids, angioedema. And upon his investigation, he was suffering marked eosinophilia with increase in vitamin B12 and mild hepatosplenomegaly. His PCR-ABL was negative, and he was given to us for bone marrow evaluation. As you can see, his peripheral blood shows marked eosinophilia with an absolute count of more than 5,000, with abnormal morphology and 2% blood circulating in the peripheral blood and mild thrombocytopenia. If you check the bone marrow aspirate and biopsy, giving the same picture with increased eosinophilic precursor showing abnormal granulation, hypogranulation, cytoplasmic vacuoles, and abnormal nuclear lobation. Okay, there's also a megakaryocytic dysplasia, and the blood cell was almost 45%. We added this patient as a case of chronic eosinophilia, chronic eosinophilic leukemia. His AML panel was negative, JAK2 negative, but upon doing the mutation, clonal hematopoiesis again, the driver mutation XSL1 was positive, confirming our diagnosis of chronic eosinophilic leukemia. As Dr. Nahla saw, so this case, chronic eosinophilic leukemia has much changes. Eosinophil with an interval less than only 4 weeks, evidence of clonality which cannot be replaced by increasing the blood cell at the earlier one, and abnormal bone marrow morphology and exclusion of other cases. By this way, we can definitely differentiate between chronic eosinophilic leukemia and other incidents of eosinophilia. And by this, there is no need for chronic eosinophilia if we will not otherwise specify, so we omitted this. I added here a diagnostic scheme for all of you to be used for in all hospitals, how to reach a diagnosis of eosinophilia, differentiating eosinophilia due to reactive, myeloid, and at the end, the clonality and abnormal bone marrow morphology, if it is present, chronic eosinophilic leukemia, if it is not present. So if it is an organ damage, it will be hypereosinophilic syndrome. Without organ damage, it will be hypereosinophilia of uncertain significance. Case 6, it's a 57 years old female patient. It's our patient long time ago from when we started the transplantation in multiple myeloma. She, from the first, which have second autostem cell in 2016, by time she developed severe cytopenia, pancytopenia. I think the referrals here will be remembered this case for, and a little bit the MBAC increased with repeated the bone marrow and the PET scan. There is no negative relapse. So suggestion of the bone marrow. The bone marrow show marked neutropenia of 0.03, and again up-articulated and hemodiluted aspirate with left-shifted maturation, as the patient was GCSF for day after day with no response for a year. So when we check the bone marrow biopsy, what we can see in the bone marrow biopsy is marked fibrosis, osteosclerosis, and you can see we find okay, marked fibrosis, there's marked fibrosis and new bone formation, osteosclerosis. Almost the bone marrow spaces is blocked due to the fibrosis. Here there is the few areas which show cells showing serous degeneration and stromal edema. The CD138, you have to exclude relapse, was almost 8 to 10% with polyclonal pattern predominance of kappa. Marked fibrosis. Trichromastrain is grade of 3, interconnecting new bone formation, blocking of the intertrabecular spaces. So there's extensive interconnecting measure of bone. So the patient for me was an stage of myeloproliferative PMF. What about the dysplasia and this, what we can see? What we can see in a dysplasia at some time cases with PMF, at the end with the transformation and the progression, dysplastic features is accepted to be seen. Again, we have done the multiplex PCR and the sequential JAK2 calreticulin. The patient was negative, but it was positive for TET2, and again, the driver mutation. Dr. Nahla covered the myelodysplastic syndrome, the new criteria. So, and this is a new article coming from Blood, which have a comparative study between 2006 to 2022 and the International Consortium for the MDS to see the different the difference between them. The most important, as we said before, the softening between the MDS and acute myeloid leukemia. It's about case by case rather than and tailored treatment rather than to put it as a standard. This patient, we received him as a long-standing history of thrombocytopenia, not responding to steroid. His peripheral blood show mild left shift with mild leukopenia and neutropenia. His neutrophils show nuclear hypo and hypersegmentation, as you can see here. Okay. His bone marrow showed dry tap. As you can see here, the biopsy consists of single core. It is markedly hypercellular bone marrow, increased age-adjusted cellularity, marked megakaryocytic hyperplasia with atipia and large megakaryocyte with hyperlobation and megakaryocyte cluster seen. There is paratrabecular localization. As you can remember, cases of MBF, the real presence of the megakaryocyte must be seen in the middle of the intertrabecular area, but in cases of PMF, we can see the megakaryocyte in clusters and near the trabeculae, which is not the care, which is endosteal translocation of the megakaryocyte with tight clusters and loose clusters. So as you can see here, the CD61, the CD34 is not increased, and also increase in the myelofibrosis. So in these cases, definitely we have to exclude the nutritional profile and any the other cases which included like Philadelphia, BDGFR, and whatever. But this case, she has fibrosis and she have an MDS, okay? But again, as a new criteria, if we have a MDS with fibrosis, it must have an increased blast percentage. So I added the patient as MDS with low blast, and I put it associated with fibrosis. When I returned back, I found it was in the literature. Some cases of MDS with low blast can be with mild fibrosis, but my concern more was, or my heart was with myelodysplastic, myeloproliferative neoplasm, not otherwise specified. Why? Because in the peripheral blood, I can see the two things. I can see neutropenicytopenia and left shift. This is not a combination that we can see it in MDS. MDS, I can see pancytopenia, but I cannot see left shift, okay? So we have a dysplastic features and cluster and endosteal translocation. This combination, again, cannot be seen in cases of MDS. MDS have a dysplastic micromegakaryocyte, but it doesn't have clustering, endosteal translocation. This is a myeloproliferative morphology. For this case, again, my heart was with the MDS, MPN, not otherwise specified. So mutation, as I've said, the mutation, especially the NXL1, DMT3, I know most of us doesn't have it, but I believe it is really important nowadays. So we added the patient as hypercellular bone marrow with triheinous hematopoiesis, megakaryocytic proliferation. This megakaryopoiesis and fibrosis, the patient is mostly MDS with low blast associated with fibrosis versus myelodysplastic myeloproliferative neoplasm, which we prefer at that time. The eighth case is a 58 years old female patient was again referred to us for an MDS. As you can see, she has moderate leukopenia and neutropenia and 2% circulating blast. Hemodiluted aspirate with only 4% blast. This is the blast cells. So when we do the bone marrow biopsy, again, you can, the bone marrow biopsy, this is the same, the bone marrow biopsy again show, as you can see here, there is a lot of clustering of the megakaryocyte, and there is this plastic megakaryocyte. So the 34 is not increased, it's almost 5%. And the megakaryocyte here was positive to CD61. The fibrosis was an MF1, so I added this patient as an MDS with increased blast type 1, as there is a category 2 to 4% or 2 to 4% blast in the peripheral blood. Because of the or 2 to 4%, I added as an MPS with increased blast type 1. Unfortunately, after 1 year, this patient came to us with blast count of 33 in the aspirate. Transformed it to acute myeloid leukemia, confirmed by flow cytometry. And again, the hypercellular bone marrow, but you can see here the diffuse infiltration with blast cell, and the atypic megakaryocyte is hardly seen. But the strange with the CD61, the strange that we found it if we send it to Mayo Clinic and we found it as MECOM. So this patient from the start could be less than 20% could be treated as an AML because of the MECOM abnormality rearrangement that we said. And again, the beautiful thing about the new WHO putting an essential criteria and desirable criteria for each. The case number 9, you have 67
Doctora,
years old male,
3
MDS.
minutes.
2 minutes?
3
Oh,
minutes.
3 minutes, okay. So this is an interesting case. A lot of blast seen, and there is a neutrophil, show defective segmentation, and on flow cytometry, this patient show right shifted with increased neutrophil, increased fibrosis. So this patient added as a primary myelofibrosis fibrotic state. Again, after a few years, 8 months, he developed to blast. The 10th is a case of neutrophil increase in the peripheral blood, persistent by cytopenia, with mild shifted. This patient, we added it as MDS MPN with neutrophil due to the overlapping of pancytopenia and megakaryocytic dysplasia. Again, we added the cytopenia, the definition that I added before. So this patient was MDS MPN with neutrophil. Thank God it come up with a setup confirming our diagnosis of MDS MPN neutrophil rather than MDS MPN, not otherwise specified. And this is my last. It is a case of mixed phenotype acute leukemia. Kindly, whenever you have a case of mixed phenotype acute leukemia, don't depend on only one ancillary test. You have to do 2 ways. Anything, flow cytometry, immunohistochemistry, cytochemistry. A single thing, it is not appropriate. This patient referred to us as a mixed phenotype acute leukemia, positive MBO and positive 13, 33, and 1117. On doing the flow cytometry, the patient, here's the patient, infiltration was blast. So I do respect every lab. So because the flow cytometry was straightforward, but rather than it was straightforward for me, no MPO, as I told you that I have to do in each case 2 things to confirm if it is positive or not. So we added an MBO on the section, and as you can see, it was showing interstitial positivity, yet you see the infiltration of the blast. It is fully infiltrated, and the CD3 is fully infiltrated. So for me, interstitial positivity of MBO is against that it is positivity, because this is a residual myeloid. The blasts tend to adhere together and coalesce together rather than to be separated away from each other. So as you can see here, the blast, this patient was an ATP, ALL. We released it as an ATP ALL, and again, I'm asking from everyone to do 2 types of MBO, and the most important, what we have been added with the WHO, that each of the marker that we use, it has to reach 50% positivity from the normal counterpart. As a 19, have to reach 50% of the normal B. As a MBO, we have to reach 50% of the neutrophil, residual neutrophil. Or we have to do like a validation for the cutoff positivity of the MBO. Rather than to put the patient, if has non-specific binding because of the cytoplasmic nature of MBO, and there's a lot and a huge number that we're entering at the diagnostic. So a lot of non-specific binding you can see at that time. So please do a cutoff value by validation, or if you do even spike their case with a neutrophil, to check the level of the neutrophil. The blast cell has to reach 50% of the MBO. Earlier, also for the B, for the T, each of them have to be 50% of the normal counterpart. You can find a little bit of MBO and you say it's positive. And never do it with only one thing. You have to do it with 2 ancillary testing, either flow cytometry, immunohistochemistry, cytochemistry, together with the molecular and cytogenetic can lead you. But for us morphologists, we have to do that as a pitfall from putting the patient as mixed phenotype acute leukemia, which has a completely different treatment than ETP. Thank you all audience for taking from your time to listen, and thank you Dr. Reem, Dr. Mona, Dr. Muhammad, and all the attendees. Thank you very much.
I'd like to invite Dr. Nahla, Dr. Ghalib, Dr. Arij, and sure, Dr. Hiba to come over the stage to answer the questions of the audience.
And a small announcement, we would like to have the speakers and the moderators to have a group photo once we are done with this session and before starting the new session.
Thank you. Dr. Hiba, Dr. Nahla, Dr. Ghalib, Dr. Arij. Any question? Okay. There is a question here. I'd like to ask about MDS in case of genetic abnormalities. If we have combined genetic abnormality of 5q deletion and SF3B1 mutation, how we would classify such case, and is there any threshold for SF3B1 mutation to classify it as MDS of such entity?
I think someone will have to answer this, Dr.
As per the new WHO, 5q is superimposing SF3B1 mutation. And if the mutation TB53 is present, also this is superimposed. So you will diagnose the patient as a case of 5q. Yes.
5q minus is a separate entity.
Yeah.
It's a separate entity.
Saying that the patient don't have the increased ring sideroblastosis.
Yes, absolutely. Thank you. Any question for our audience? دكتور.
يعني just announcement or just comment for BBDCN. As we pathologists, we was challenging for lack of the complete panel for BBDCN to confirm the diagnosis. But currently there is a pharmaceutical company over us the specific plasma cytoid dendritic cell marker in the major hospital, I think in Dammam, in National Guard, in my institute, Prince Sultan Medical City, and the King Faisal. So now the panel is available, and if someone work in a periphery or have some cases like that, so we are willing to help to run the panel. Just send a couple of unstained slides to us or the case as a second opinion. So it is now available by sponsor now.
Yeah, it's supplied actually by the company covering the plasma cytoid. It is a targeted therapy company. And this targeted therapy company gave us earlier we attended a lecture about this plasma cytoid from the company, and the company actually gave three of the hospitals the opportunity that will be center of excellence to start diagnosis a case of plastic plasma cytoid. Kindly note, for these cases, you have to edit the undifferentiated leukemias. Your undifferentiated leukemias is our target, not any other leukemia. Undifferentiated leukemia that you have it now or you have it earlier This is the target for blastic plasmacytoid dendritic neoplasm, not other things. Because these cases which have no specific lineage-specific markers, for this, these cases which we have, you must have from the diagnostic bone marrow 123, 4, and 56, and you put it as an undifferentiated leukemia, kindly send according to the geographical place. So in Riyadh, 2 areas, and in the MEM and King Fahd Specialist Hospital, actually it was received last week.
Thank you.
Yes, but with this entity, undifferentiated leukemia, low lineage-specific marker, from your side you have done CD123, 4, and 56. If the 3 of them are positive over the blood cells and is undifferentiated leukemia, you refer it to us, because this will be our target. Okay?
I think we have a question there.
Thank you so much for presentation, Dr. Ghalib. I want to ask about the frequency of plasmacytic dendritic neoplasm here in Saudi Arabia, if you have any, prevalence data or incidents.
Thank you for the question. Unfortunately, the prevalence in worldwide is not clearly clear, but it is a rare disease. But the issue, we don't have a statistic about this disease. I know a couple of cases, 1 or 2 cases only in King Faisal, Riyadh, and I don't know if we have in the map. Yeah, exactly. Yeah.
It's underdiagnosis for this disease. It is a new disease. It's a new entity. You cannot put it if you don't know it.
Yeah, exactly.
It's a new entity. Actually, the WHO didn't. It's not released to the public.
The issue is usually it is underdiagnosis or misdiagnosis, because we don't have the full panel, because CD123 and CD4 and 56 can be expressed in different type of leukemia, myeloid, even lymphoid. So it may be underestimated, maybe misdiagnosed as undifferentiated or ambiguous leukemia, or maybe also one of the challenges is acute myeloid leukemia with monocytic differentiation can express CD123, CD4, CD56, in addition to CD303, which is plasmacytoid dendritic marker, which is a big challenge for pathologists. So hopefully after supplying this complete panel, we can now run it by flow or by immunohistochemistry. I think it will be very helpful. But now there is no, I know only couple of cases in Saudi Arabia.
Thank you.
I think Dr. Ghalib, as Dr. Hiba mentioned, the issue is related to how to put it over the top of differential diagnosis rather than also how to approach it. Any other question?
For Dr. Nahla, regarding mixed phenotype or ambiguous, for aberrancy versus mixed phenotyping, the phenotype, and standard for a stepwise approach to differentiate, is it really ambiguous or only aberrancy? To judge the phenotype that's appearing, is it ambiguous or aberrancy?
Okay, if I understand your question correctly, you're asking about what is the diagnostic approach for acute leukemia with ambiguous lineage, is it?
Yeah.
Okay, so currently we do bone marrow biopsy and aspirate, we do flow cytometry, we do immunohistochemistry as well on the tissue biopsy. Some of the labs, I'm not sure, our lab, we are not doing cytochemistry anymore, but there are few rare labs that do cytochemistry. So usually the flow cytometry is the very important tool for the diagnosis of ambiguous lineage. Currently, most of the lab, as I'm aware, they are using Euroflow panel. Euroflow panel, it has a kind of a stepwise approach where you have the screening panel using lineage-specific markers such as CD19 for B-cell marker 79A, MBO for myeloid lineage. We have cytoplasmic CD3 and surface marker as well. So if you have any marker of these are positive, then you can extend to lineage-specific panel, either AML, BLL, or TLL. The problem with that stepwise approach, as I illustrated in the cases, that sometimes you can miss a lineage switch, especially if you are running the Euroflow panel focusing on BLL panel. So I think at least for KMT2 rearrangement, because they frequently have, and ZNF384, they have lineage switch, so you should at least run full panel to cover, or monocytic tube at least, because these kind of leukemia have monocytic commitment with the BLL. But again, taking that backward, we don't have optimal therapeutic or therapy for lineage switch currently, but at least we have to run it upfront.
So you mean this, to look for a switch by clinical indication or clinical data indication like KMT2A? In such cases, selectively we'll run full panel, not all cases, and to be selected based on the basic clinical data or...
Yes, at least for KMT2 rearrangement and ZNF alpha, and this information usually we have it at the diagnosis.
Okay, thanks.
Welcome.
Any last question? Just we have a few seconds. So we will conclude the end of this session. Thank you for your attention, and you have a break now. Thank you to our speakers.
After this challenging and hot morning with challenging cases and difficult concepts, new things in the WHO, I hope you enjoyed your coffee break, and I apologize for being late for more than 5 minutes. It's all to give you enough time to socialize and relax after this marathon in the morning session. This is the session number 2, and we will be talking about myeloma and lymphoma subjects. It gives me a great pleasure to be able to introduce the distinguished speakers in this session. And first of all, I would like to introduce my fellow moderator in this session, Dr. Ali Al-Faraidi. Dr. Alia is the head of Hematology Laboratory and Flow Cytometry Unit and a consultant hematopathologist at King Saud University Medical City. And she is the former program director of King Saud Fellowship Program, graduated from King Saud University and completed the fellowship, King Saud Fellowship in 2008. And a lot of the trainee in this room and the graduates have been honored to be her students. I didn't introduce myself from the beginning because I was rushed this morning. Muhammad Al-Muhammadi, I'm just one of the hematopathologists in the kingdom. Dr. Ali, تفضلي.
So Dr. Ahmed is around? So, Assalamu alaikum for the second session. Now we are shifting from the myeloid to lymphoma and myeloma. So, as you know that plasma cell neoplasm and the related entities are all share the stepwise evolution from pre-neoplastic precursor lesion, which is associated with multiple genetic abnormalities, and it's also reflected on the disease progression as well. So this update, I think it's essential for a more precise disease definition and the diagnostic criteria, which will be addressed by Dr. Ahmed Al-Rajal. So Dr. Ahmed is currently a hematopathologist at King Faisal Specialist Hospital and Research Center in Medina. He has worked in several oncology centers, including Princess Noura National Guard Hospital in Jeddah and Imam Abdul Rahman University, King Fahad University at Dammam. Dr. Rajal completed his residency and fellowship training in 2020, where he got American Board Certified Anatomic Pathology, Cytopathology, and Hematopathology. He has been involved in various publications and acknowledged in some book chapters as well. He is also one of the members of the International Several Professional Scientific committees such as College of American Pathologists, ASCP, and USCIP. So, Dr. Ahmed, well, welcome.
Yes, thank you, Doctora, for such a nice introduction. Thank you all for coming today. As we all know, plasma cell myeloma is such a complex disease. And within the next 25 minutes, I'll try to cover 3 main key points. We'll go over some rationale for the update criteria. There is not much update from the International Myeloma Working Group since 2014. So this session will be mostly a review on the previous diagnostic criteria. Also, we'll touch on risk stratification for myeloma and its precursor lesions, and then we move to MRD testing and its application in multiple myeloma. So to start with a timeline, the most recent update was issued by the International Myeloma Working Group, which is almost the largest group of researchers interested in multiple myeloma, to include more than about 300 myeloma experts actually from 40 different countries. So they issued their diagnostic criteria in 2014, and the WHO actually take their diagnostic criteria exactly as is and list it as the WHO diagnostic criteria. This was followed by a 2015 revision in the international staging system, and they issued the revised international staging system in 2015, where they added the LDH and some cytogenetics marker to the original staging system. Also, some slide in this presentation would include some information from the most recent WHO 5th edition 2022. So without further ado, just to review plasma cell myeloma, it's kind of unique in its presentation where it presents with bone marrow plasmacytosis, ocellulic bone lesions, and monoclonal gammopathy or M protein. It's not a very common disease. It accounts for 1% of all cancers. And this is actually coming from the Saudi Cancer Registry in 2015, where it accounts for 5% of hematolymphoid malignancies in the kingdom. It has a rate of about 10 to 20%, depending on the reference you read, for the international or the global rate of myeloma compared to hematolymphoid malignancies. So the traditional way of diagnosing multiple myeloma, as we all know, it has two parts, a laboratory finding and some clinical findings. So the lab part, we need to provide evidence of clonal plasma cells, more than 10% in the bone marrow. And the clinical part or finding of the clinical findings, usually shortened in a mnemonic called CRAB or CRAB, the famous CRAB criterion. But this was changed by the 2014 addition of a slim CRAB criteria. And the International Myeloma Foundation added 3 more points, or what is so-called biomarkers of malignancy. As we are all familiar with the end organ damage or the evidence of end organ damage by the CRAB criteria, the hypercalcemia, the renal impairment, the anemia, and the bone lesions, the 3 more criteria do not fit necessarily as an end organ damage or evidence of end organ damage. So they are called biomarkers of malignancy. But both the evidence of end organ damage and the biomarkers of malignancy combined together are called myeloma defining events. And what they did basically in 2014 to come up with this criteria is they actually looked back at a large group of patients, asymptomatic patients, to identify who is going into multiple myeloma earlier or faster. And here I show you an excerpt coming directly from the WHO classification of hematolymphoid malignancies. And notice the first 3 points are actually the biomarkers of malignancy added in 2014, and the bottom 4 are the regular myeloma defining events or the evidence of end organ damage, the anemia, hypercalcemia, and lytic bone lesions. As we are all familiar, those criteria are well defined by specific cutoff points for calcium, creatinine, and hemoglobin, for example. And just like we have corrected serum calcium for patients with renal failure, now since they added the free light chain as one of the criteria of over 100, some of those patients actually would present with an underlying kidney disease. And the iStop multiple myeloma study group or prospective study, actually they came up with a reference range for serum free light chain to adjust for the renal disease or the underlying renal disease. So they came up with 3 different reference ranges for serum free light chain based on the estimated GFR in 3 different categories. iStop multiple myeloma is one of the largest prospective studies in asymptomatic multiple myeloma. It's a screening study where they included many patients, about 80,000 people actually in the screening program, trying to identify the rate of UMGUS and the value of doing a screening program for UMGUS in terms of myeloma. So here I provide you with a visual. If you look at the top triangle, let's consider that as a bone marrow cellularity. The red triangle is the portion of plasma cells within that bone marrow. And then we have set of couple of points, cutoff points. So we have 10% plasma cells and 60% plasma cells. And at the bottom, the different disease categories. This actually helps us in identifying multiple myeloma as it sits on a disease spectrum. It's usually preceded, or it's always actually preceded by an asymptomatic stage of M protein called MGUS, or monoclonal gammopathy of undetermined significance, and asymptomatic multiple myeloma, or smoldering multiple myeloma. So if we consider a patient with less than 3 gram M protein, and this patient who is asymptomatic, doesn't have any of the CRAB or the slim CRAB criteria, he or she would need a bone marrow examination to complete the workup. And if we find less than 10% clonal plasma cell within that bone marrow, this patient will be termed MGUS, or monoclonal gammopathy of undetermined significance. Those patients have a well-defined risk of progression into multiple myeloma, and it's estimated at 1% per year. If the same patient has more than 10% plasma cells, those would be termed smoldering multiple myeloma, and they have a higher risk of progression to multiple myeloma of 10%. So you see, basically we're trying to identify who is going into multiple myeloma, who's going to show symptoms earlier. And the whole idea of adding the myeloma defining events or the biomarkers of malignancy, the finding of more than 60% plasma cells in the bone marrow, more than 100 serum-free light chain, and more than 1 bone lesion on MRI, or a very high sensitive radiology technique. What they found is basically patients or individuals with any of these features, they have a greater risk of going into multiple myeloma within the next 2 years. The risk is estimated at about 80%, and this is coming from multiple studies that are actually independent. So basically, why wait for those patients to call them myeloma and to have them eligible for treatment until they actually have evidence of end organ damage? So probably treating them earlier, being more proactive in the diagnostic criteria, would provide them with a longer overall survival and progression-free survival. So what happens is basically we kind of extending from one disease to something like this, where we have multiple myeloma with 3 different risk categories, and then the precursors with also different risk categories. I'd like to mention that myeloma risk grouping or risk stratification is based on who the patient is going to relapse faster, or who are those patients who are at greater risk of relapse. While the precursor lesion, we're trying to identify who is the patient going to show symptoms or showing full-blown disease or multiple myeloma. This is currently based on many clinical and some laboratory and genetic findings, but hopefully this would change in the future, where we'd have a more solid and hopefully molecular-based classification system. So here I show you a table from the WHO hematolymphoid malignancy, and for risk stratification, we can see the ISS, or the International Staging System. It is the most reliable risk stratification system that we have, and it's based on beta-2 microglobulin and albumin. But at the bottom, as you can see, the revised International Staging System was issued in 2015. It's basically the same, but they have added 2 more independent prognostic factors, the LDH and the cytogenetic findings. There are multiple cytogenetic findings or translocations are well defined to be associated with high-risk multiple myeloma. Those are defined by the International Myeloma Working Group, and they are included in the risk stratification of the International Staging System, which made the staging system actually much better in discerning those patients who are at higher risk of relapse. In the middle, we have the International Myeloma Working Group staging system, which is basically the same, and they share so many of those translocations. In fact, the 414 is shared, chromosome 17, which carries the P53, is also shared, but they are different in one finding. So the Myeloma Foundation is interested more in chromosome 1 aberrations. They want to exclude that for patients to be called low risk. And the revised International Staging System, they are interested in 1416 to be excluded for patients to be called low risk. And the means of testing, it is recommended to do FISH. FISH is the gold standard for those patients as it shows more abnormalities. Conventional cytogenetics kind of is disappointing, where it shows only about 30% of those plasma cell myeloma would actually show abnormality based on cytogenetics, or conventional cytogenetics alone. So as a result of those, there are baseline genetic information that should be acquired on each and every newly diagnosed multiple myeloma. The minimum FISH panel include deletion 17, 414, and 1416. This is by the International Myeloma Working Group, but they also advise for a more comprehensive panel to include chromosome 1 and diploidy analysis, or diploidy category. So aside from the conventional cytogenetics or the translocations, the well-known translocations, the MSMART staging system, based in Mayo Clinic myeloma interested group of researchers, they actually came up with the MSMART, a new concept that has been added to their staging system, is the presence of double hit. A double hit lymphoma is a well-known concept where we have aberration in BCL2 and c-MYC, for example, and diffuse large B-cell lymphoma kind of infers a more aggressive behavior. The same concept, or a similar concept here in multiple myeloma, where they found the presence of double hit, meaning having two of the high-risk, well-defined high-risk cytogenetics abnormalities, having two of them in the same patient actually confers, or it's considered as an independent prognostic factor on its own. And they found the overall survival of patients with double hit to have about 6 months, while with no risk is about 57 months of overall survival. So the risk stratification for multiple myeloma comes into play as for the disease, the treatment choice basically. Once we diagnose those patients with multiple myeloma, those patients would be for a lifelong treatment. It's well known that multiple myeloma is not a curable disease, and they need follow-up and disease monitoring very effectively. But the risk stratification for multiple myeloma as a patient would kind of allow or dictate the type of treatment they are getting. Basically, multiple myeloma would be treated initially at least at the same, basically based on their age and other criteria. But for high-risk patients, they would show more benefits if they go with the high-dose chemotherapy with tandem auto transplant or stem cell rescue. So risk stratification plays a major role in treatment for multiple myeloma, but risk stratification for precursor lesions plays a major role in the frequency of follow-up and trying to identify those patients and have a good follow-up plan for those patients. So this is a table from the WHO also showing the risk stratification of AMGAS patients. Those are the asymptomatic patients with hanging M protein in their serum. The risk stratification is based on a few laboratory tests. Basically, the value of M protein, the Ig subtype, and the serum free light chain as well. And notice the absolute risk of progression at 20 years can go from 5% all the way up to 60%. Oops.
3 minutes, Dr.
Yeah, 5% all the way to 60% if it is the highest risk. Thank you. Also, for predicting the need for bone marrow, this is something I found while actually reading on the topic of risk stratification for AMGAS. In the same group of iStop-MM based in Iceland, they came up with this experimental, or still it's actually under review, but you plug in some numbers and it kind of tells you the likelihood of finding more than 10% plasma cells in the marrow. Basically, if you have a patient with an hanging M protein I believe once this is actually reviewed and published, I believe this would be a good tool to estimate the risk of smoldering multiple myeloma in UMGUS patients. So UMGUS is also subtyped based on the IG subtype. Non-IgM UMGUS is the most common one, and the risk of progression is usually 1 per year across different studies from different on the globe. The risk of progression going into multiple myeloma, amyloidosis, and plasmacytoma. Light chain UMGUS has a lower risk of 0.3%, and IgM UMGUS, which is associated with lymphoplasmacytic lymphoma and Waldenström microglobulinemia, has the highest risk of 1.5. So accordingly, disease monitoring for those patients based on the risk stratification and their type, they usually have different follow-up plan, either biannual every 2 years or every year, once a year, basically, for high risk. For smoldering multiple myeloma, as we know, it's very similar to UMGUS, but you have a higher portion of M protein and higher percentage of plasma cells, but it's a must that you don't have any evidence of end organ damage or none of the myeloma defining events. The risk of progression to plasma cell myeloma kind of goes down with time. The first 5 years is 10%. The following 5 years is about 3%, and then goes back to UMGUS rate, where it's only 1% per year risk of developing multiple myeloma. So they are called high risk, also classified into high risk if they have high protein, more than 30 grams, and then they have higher percentage of plasma cells also, 50 to 60% plasma cells. They are approaching to the multiple myeloma level. If they have any circulating plasma cells, if they have the serum free light chain more than 8, and if there is evidence of progressive M protein. And here is the monitoring of this patient. Actually, they would need a follow-up M protein level 2 to 3 months right after the diagnosis. And this is how you identify the presence of progressive increase in the M protein. While the risk stratification for precursor lesion, UMGUS, and smoldering was based on clinical findings and laboratory findings, Dana-Farber in 2020 tried to incorporate NGS findings into risk stratification for smoldering multiple myeloma. They basically studied the DNA repair pathway, the MAPK pathway, and the MYC aberrations. And based on those, they classified patients into higher risk of progression to myeloma within 2 years or low risk. Also, I would like to mention, once we treat those patients, and we need to monitor those patients very closely for relapse. For minimal residual disease testing, there are basically 2 common methodologies. Both are FDA approved. There is the NGS, or the next generation sequencing, and the NGF, or next generation flow cytometry. Both are based on a bone marrow biopsy, which is invasive. Both are excellent in identifying very low percentage of malignant plasma cells. But the application of those testing are still limited to clinical trials, as clinical guidelines are not available as for well-established for like BALL or other minimal residual disease testing. So the flow cytometry part, basically the FDA approved one is developed by Euroflow, and it's actually a global standard for MRD, where they compare your patient sample to a large set of data stored within the Euroflow database. But other group of researchers actually try to imitate the same panel devised by Euroflow, to trying to decrease the cost basically. And they showed promising results. So more of this, I guess, is coming in the market. Also, something new in terms of minimal residual disease, especially in multiple myeloma, as we just mentioned, the NGS and NGF are based on a bone marrow invasive technique, a bone marrow biopsy, but a newer methodology, which is the mass spectrophotometry use for the immunoglobulin, actually based off serum protein, trying to identify minimal residual disease. And it's actually a very basic methodology where they actually study the mass of the peptide change, very specific, on diagnosed initially and then followed up by mass spectrophotometry. Just 2 words on plasma cell leukemia. They have decreased the diagnosis or diagnostic criteria for plasma cell leukemia from 20% to 5%. And I just like to mention that this diagnosis is, you can make this diagnosis only in patients who had established symptomatic plasma cell myeloma. The identification plasma cells in the peripheral blood is very difficult by morphology and also by flow cytometry, as we know with plasma cell inherited problem in flow cytometry. Last but not least, this is the newest addition in WHO. So just like we have AMGAS, monoclonal gammopathy of indeterminate significance, we have MIGRAS, which is monoclonal gammopathy of renal significance. And for those patients, you need evidence that you need actually to exclude any evidence of end organ damage. You need a biopsy-proven kidney biopsy proving that you have a monoclonal immunoglobulin deposition and kidney damage. But you don't have any evidence of that monoclonal antibody causing damage anywhere else in the body. And this is how you make a diagnosis of MIGRAS. It's a clinical pathologic diagnosis. With that, I conclude, and thank you so much for listening.
Thank you, Dr. Ahmed. And our next speaker, it's actually a great pleasure to present to you Dr. Khalid Al-Aid. Dr. Khalid Al-Aid is a certified consultant in hematopathology based at King Saud University Medical City. In addition to his role as a consultant, he is also the supervisor at the Royal College of Pathologists of Australia, overseeing the hematology lab at King Saud University Medical City. He holds a master's degree in science and system biology and bioinformatics from Case Western Reserve University in United States. He's also the fellow of the College of American Pathologists, fellow of the Royal College of Pathologists in Australia, as well as a CAP team leader for the purpose of accreditation at several occasions. So please welcome Dr. Al-Aid, and he will be talking about splenic B-cell lymphomas / leukemias.
Bismillahirrahmanirrahim. Thank you very much for the organizing committee for the invitation. I'm really happy to be here. So today I'm going to speak about splenic B-cell lymphomas and leukemias. This is the outline of my talk. And I will start with just highlighting that in this talk, I'm going to talk about only B-cell lymphomas. So we will not cover T-cell lymphomas. And also, splenic B-cell lymphomas can be divided into 2 subgroups. Lymphoma that arise or the primary disease started from the spleen and go out. Or the second group is, as you know, lymphoma elsewhere and invading the spleen during the progress of the disease. So today we will talk about the primary splenic B-cell lymphomas, and the term splenic B-cell lymphoma covers this group of cases that started from the spleen. Okay, so the current classification, as you know, the WHO 4th edition subclassify the splenic B-cell lymphomas and leukemias into 4 subgroups: the splenic marginal zone lymphoma, the hairy cell leukemia, and then splenic B-cell lymphoma, leukemia unclassifiable, that includes 2 subcategories: the splenic diffuse red bulb small B-cell lymphoma and the hairy cell leukemia variant. As everybody know, the classification is a hot topic these days. So the 5th edition of the WHO classification did some, or like a minor changes. So they subclassify splenic B-cell lymphomas into, I would say, 5 subgroups. The same one, the splenic marginal zone lymphoma, and the second one, hairy cell leukemia. And they put as a specific entity or a subtype, splenic diffuse red bulb small B-cell lymphoma as a category, and then splenic B-cell lymphoma leukemia with prominent nucleoli that includes hairy cell leukemia variant and B-cell pro-lymphocytic leukemia cases. The ICC classification subtypes the splenic B-cell lymphoma exactly similar to the 4th edition of the WHO. As you know, the authors of the 4th edition WHO are the same one who did the ICC classification, so they follow the same subclassifying system. So I will start with splenic marginal zone lymphoma. So it's a B-cell neoplasm comprising small lymphocytes that surround and replace the splenic white bulb germinal centers, efface the follicle mantle, and merge with a peripheral marginal zone of large cells. It accounts for about 2% of all lymphomas, and patients usually presented with a median age of 65 years old, ranging from 30 to 90 years old. Men affected more than women, and typically patients presented with fever, weight loss, night sweats in 50% of the cases. Splenomegaly is seen in more than 70% of the cases, mostly presented with anemia, thrombocytopenia, or leukocytosis. Autoimmune hemolytic anemia and infections in 10%, and there is some association with hepatitis Z virus, especially in southern of Europe. Splenic marginal zone lymphoma, from the name, tend or prefer to start from the spleen and invade the marrow, the peripheral blood, to a lesser extent the liver, and rarely involve peripheral lymph nodes. How does it look? So in the spleen, it has a very characteristic morphology features. It has a micronodular pattern and what is called the biphasic cytology, where the marginal zone is expanded and composed of like medium-sized, widely spaced cells, and inner zone or the darker zone, and it has or show mostly follicular replacement and the red bulb sometimes, or mostly it is partially involved. In the peripheral blood, mostly splenic marginal zone lymphoma are small lymphocytes and mixed with villous cells. If you are lucky, you can see the typical bipolar or polar villous lymphocytes. Sometimes it is only from one side. In the marrow, it shows a characteristic intrasinusoidal involvement mixed with intratrabecular and interstitial pattern. And we can see here a low power of a bone marrow showing like numerous of small nodules mixed with some interstitial pattern, and the higher power with CD20 highlights the characteristic intrasinusoidal pattern where the lymphoma cells follow the exact shape and size of the sinuses and like shows some sort of a single line pattern. The immunophenotypic features of splenic marginal zone lymphoma, it is a it's a B-cell lymphoma and show the pan B-cell markers like CD20, BCL2, DBA44, IgM more than IgD. Ki67 show like a very characteristic pattern. It's called targetoid pattern, where the outer layer is showing a higher like in positivity inside. Typically, they are CD10 negative, CD23 negative, CD43 negative, CD123 negative, annexin A1 negative, cyclin D1 negative, BCL6 negative, and SOX11 negative. There are some cases that show co-expression of some markers that can be seen in other subtypes, like CD5 in 20% of cases, CD11C in 50% of cases, CD25 in 30% of cases, and small percentage of CD103. Genetic features, 40% of cases show a common finding, which is the deletion 7q, but it's not very characteristic for splenic marginal zone lymphoma, as we can see it in other subtypes. There is ongoing evidence and future of the mutational analysis. As we can see here, CLIF2 and Notch pathway genes, specifically Notch1 and Notch2, are showing increased evidence. They are very commonly associated with splenic marginal zone lymphoma, as well as other genes that are related to the NF-kappa B pathway. Splenic marginal zone lymphoma is often indolent disease with good prognosis, and the overall survival is at least 10 years, and they usually respond to rituximab or splenectomy. Next, I'm going to talk briefly about the other entity, the splenic diffuse red bulb small B-cell lymphoma. Actually, it is a very rare entity. It is less than 1% of non-Hodgkin lymphomas, and it is accounted for 10% of splenectomy B-cell lymphomas. From the name, it is diffusely involved the splenic red bulb, but otherwise, it is very similar to the splenic marginal zone lymphoma in clinical, morphologic, immunophenotypic features. It shows pan B-cell markers, CD20 positive, CD79B positive, PAX5 positive, DBA44, and IgG. It is negative to the other specific markers for other lymphomas, and it is very characteristically negative for what is known the hairy cell markers, the CD11C, CD25, and CD103, and CD123, annexin A1. Similar to splenic marginal zone lymphoma, there is an increased evidence and information from the literature regarding cyclin D3 and cyclin D3 mutation. It is shown that in 70% of cases, there is an increase in positivity of cyclin D3 by immunohistochemistry, and also 26% of cases showing mutations in the cyclin D3 gene. But it is not very characteristic and seen in other subtypes. So this is the recommendation, or the main point from the ICC classification. The differentiation between splenic marginal zone lymphoma and splenic diffuse red bulb small B-cell lymphoma needs a spleen histology. Even with the immunophenotype, even with the gene mutational analysis and the findings, it still requires a spleen histology. As mentioned, splenic marginal zone lymphoma is a white bulb disease. Splenic diffuse red bulb B-cell lymphoma is a red bulb disease. Next, I'm moving to the hairy cell leukemia. Hairy cell leukemia is a cytologic and immunophenotypic distinct indolent neoplasm of small mature B lymphoid cells with oval nuclei and abundant cytoplasm with so-called hairy cell or hairy projection involving the peripheral blood and diffusely infiltrate the bone marrow and the red bulb of the spleen. So it is very, as I mentioned, distinct in the matter of the presentation, clinical features, morphology, and immunophenotypic features. It is rare and accounts for 2% of lymphoid leukemias, and patient presented with a median age of 54, ranging from 23 to 85. Men is way affected more than women, and mostly patients present with fatigue, weakness, or weight loss, left upper quadrant pain because of the huge splenomegaly is seen in 90% of cases, hepatomegaly in 70%, pancytopenia in 75% of the cases, and a very characteristic finding is the monocytopenia, where monocytes are less than 500 per microliter. They tend to be seen in bone marrow and heavily infiltrate the spleen, and you can see occasionally and few number of abnormal lymphoid cells in the peripheral blood, but usually in small numbers. Liver is affected or involved in 50 to 70% of the cases. lymph nodes are rare. The morphologic features of hairy cell leukemia, I believe it's very known to most of you. It is commonly a small to medium-sized lymphoid cells with oval or indented, what is called kidney-shaped nucleus. It is less clumped compared to other types of B-cell lymphoma, and nucleoli are absent. Cytoplasm is prominent and abundant and showing clearly the hairy projection. And the projections here are different. If you look carefully, they are very different from the splenic marginal zone lymphoma, or what is called the villus lymphocytes. The projections are seen all over all the sides and around the cell, instead of polar or one-sided villus projection in the splenic marginal zone lymphoma. So in the bone marrow, it range from interstitial, patchy to diffuse solid infiltration, and it is very characteristically widely spaced lymphoid cells with oval or indented nuclei with abundant cytoplasm, making very clear and prominent cell borders, making what is very known as the fried egg appearance, as you can notice here. Mitotic figures are absent, and it is very commonly show increased bone marrow fibrosis. In the spleen, hairy cell leukemia is involving the red bulb, and it making what is commonly known as red blood cell lakes, where you can see spots or areas of hemorrhage and RBCs surrounded clearly and nicely by the hairy cell leukemia cells, very clearly abundant cytoplasm cells surrounding these blood lakes. The immunophenotypic features of hairy cell leukemia, as the definition, it's very distinct, type of B-cell lymphoma. Although it is a B-cell neoplasm, but it is typically express CD11C, CD25, CD103, CD123, and annexin A1, and cyclin D1 is reported to be positive weekly, mostly weekly positive in hairy cell leukemia. It is known to be negative for CD5, CD10, CD23, CD43, and BCL6. Similarly, it is a very distinct subtype. It has a very characteristic BRAF V600E mutation, and it is believed that this is, the driving mutation and abnormality that showing the disease, and the main pathogenesis of the disease is because of that. There is increased number of cases specifically that are negative for BRAF V600E mutation. They show preference for the IGHV4-34 family of the immunoglobulin heavy chain, as well as MAP2 kinase 1 mutations. It is very, benign disease, I would say indolent. They respond very good to purine analogs and interferon alpha, and they achieve complete and durable remissions. On the other hand, the hairy cell leukemia variant, it is very rare. It accounts for less than 0.2% of lymphoid leukemias. It is actually resemble the classic hairy cell leukemia, but exhibit very distinct and variant features. So summarize them here. It shows leukocytosis at presentation, and the monocytopenia is absent. Also, by morphology, they typically show very prominent nucleoli. And in some literature, the old literature, it was called the pro-lymphocytic hairy cell leukemia. It is typically and commonly negative for CD25. I cannot think about hairy cell leukemia with CD25 positive. And negative for CD123 and annexin A1. They lack the BRAF V600E mutation, and similarly to hairy cell leukemia, they show more usage for the IGHV4-34 gene family, and high frequency for TP53 and MAP2 kinase mutations. And they do not respond nicely and goodly to purine analogs. So this is a brief review about the splenic B-cell lymphomas. So I was thinking just to, go with you about like a suggested diagnostic algorithm for such cases. So I will think about the splenic B-cell lymphomas when I have a splenomegaly, patient presented with a splenomegaly, and there is a lymphocytosis, whether absolute or relative. So first thing I will do, I will look at the morphology of the peripheral blood. So if I have a large cells, this makes life easy. I will think about the high-grade B-cell lymphomas, DLBCL, Burkitt lymphoma, double hits, and the other things, like high-grade follicular, the polymorphic mantle. So I won't think about the splenic B-cell lymphomas. If I have a small or like moderate with abundant cytoplasm cells, I definitely will need flow cytometry. So if flow cytometry show a distinct and a very characteristic findings for other B-cell lymphomas, like CD10 positive, I will think about follicular lymphoma. If CD5, CD23, CD43, CD200 are positive with DIM or negative CD20, this is clearly a classic CLL. If CD5 positive with cyclin D1, whether by flow or IHC, I will definitely think of a mantle cell lymphoma. If not, I will go think about the hairy cell leukemia. It has to have at least these three markers. The CD11C, very bright, CD25, and CD103. If not the three are present, we will go to the challenge of the what is like commonly called as CD5 negative, CD10 negative, B lymphoproliferative disorder, or to lesser extent the CD5 positive B-cell lymphoproliferative disorder with splenomegaly. So the differential diagnosis is the same entities that I described earlier, hairy cell leukemia variant, and the more common, the splenic marginal zone with, like included into this category, the splenic diffuse red bulb small B-cell lymphoma, and LPL, lymphoplasmacytic lymphoma.
2 minutes.
So this area was a very, like interest to our group. So we were thinking about, checking a diagnostic utility using flow cytometry and targeted NGS. So we have checked and studied 2 cohorts, 34 cases for flow cytometry and 39 cases for targeted NGS in a group of low-grade B-cell lymphoma. So I looked like, before I start, looking for other markers, I looked, to like get an idea about how overlapping we can see among these cases. So this is CD5. We can see here, splenic marginal zone lymphoma tend to show like good expression of CD5, as well as LPL. Maybe hairy cell leukemia variant is very low. This is CD11C, very characteristic strong positivity in the hairy cell leukemia group, whether the classic or the variant, but still we can see some positivity in the splenic marginal zone lymphoma. So this is CD25. You can see here the difference. See the end of the columns. So hairy cell leukemia is and the strongest entity that shows CD25 expression, where hairy cell leukemia variant is, in the bottom showing dead negativity for CD25. But still, LPL, marginal zone, and splenic marginal zone lymphoma, some cases tend to show some positivity. So our group study, like this new marker, the CD1C, in the immunology literature, they mentioned some like subtypes of activated and immune responded B cells in the peripheral blood show some variability in CD1C. So we studied CD1C in this, cohort of low-grade B-cell lymphoma. Actually, it is very, useful for discriminating CLL from the others, but the other subgroups show like very and pretty similar, expression. The other marker is CD180. I think we have some, potential use here. As we can see, splenic marginal zone lymphoma is showing more expression compared to LPL, and it can help in the differentiating between the 2 subgroups. My colleagues, covered the next generation sequencing using like a group, like a good panel of genes that like cover Notch1, Notch pathway, NF-kappa B, and some, tumor oncogenesis, the genes, and it is very, very helpful. You can see here, LPL tends to show very strong and like uniform, mutation in the MYD88 gene, to a lesser extent the CXCR4. Whereas marginal zone lymphoma, including splenic marginal zone lymphoma, show like a good percentage of mutations in the NF-kappa pathway. Hairy cell leukemia is very characteristic, showing mutations in the BRAF as well as the MAP2 kinase 1. So I believe the targeted NGS is very important tool in the low-grade B-cell lymphomas in general. So I will conclude with these two challenging cases. So we have the first case is a 41 years old female presented with leukocytosis, mainly absolute lymphocytosis with a bone marrow involvement, and the lymphoma cells are very strongly positive for CD11C and negative for CD25. There is no lymphadenopathy. There is like very spleen enlargement in the spleen. Genetics was normal, SPEP was normal. The initial diagnosis was, splenic marginal zone versus hairy cell leukemia variant, and the NGS was very helpful to, determine the hairy cell leukemia variant. The next case is 66 years old male, similar scenario with splenomegaly, bone marrow is involved by CD11C positive lymphoma cells, negative for CD25, and this one, there is a small, amount of IgM kappa, restricted protein. Genetics show deletion 17p. It is, seen in the splenic marginal zone lymphoma. So the NGS confirm the splenic marginal zone lymphoma by the presence of POT1 and TRAF mutation. And by this, I conclude my presentation, and I'll be happy to answer questions at the end.
Thank you very much, Dr. Khalid, for this comprehensive presentation. We'll move to the third talk for this session. It will be handled by Dr. Reem Al-Rabih. Dr. Reem Al-Rabih will talk about some of the challenging cases of myeloma and lymphoma. Dr. Reem Al-Rabih is a US board-certified pathology consultant. She specializes in hematopathology, lymphoma pathology, transfusion medicine, coagulation, and stem cell apheresis. She's currently the director of hematology and flow cytometry laboratories, King Fahd Specialist Hospital in Dammam.
Okay, so I removed the word challenging because some of these cases they might not be challenging for you, but challenging for others. We'll start with our first case, a 66 years old female, known case of hypertension, dyslipidemia, and old stroke, who presented with jaundice, dry mouth, and B symptoms. She was found to have hepatosplenomegaly, enlarged salivary glands, cholestasis, and lymphocytosis. Her CBC was significant for leukocytosis with predominantly lymphocytes. She had a normal hemoglobin and platelet counts. This is her peripheral blood. As you can see, small to intermediate sized lymphocytes with dark basophilic cytoplasm, irregular nuclei, and clumped chromatin. She had flower-like, cleaved, and cerebriform nuclei. You can see over here. Over here you have the more cerebriform. But the predominant ones were the flower cells. Bone marrow aspirate showed similar morphology with infiltration by lymphocytes. You can see over here in the yellow arrow. This is her flow cytometry. It showed a T cell population expressing CD3, CD5, predominantly CD4, CD2 positive with partial loss of CD7. It was also expressing CD25, CD27, and majority were TCR alpha beta. So final diagnosis was bone marrow infiltration by CD4 positive T-cell lymphoma. She did not have any skin rash. It's most suggestive of adult T-cell leukemia lymphoma. We ruled out Sézary. It was helpful that she didn't have a skin rash. And we asked to correlate with HTLV1 serology and PCR. So this is a Saudi citizen. So when the clinicians heard about this, they were surprised. As you know, this disease is seen majority in Japan and the Caribbean, and why would we have one patient with this virus? So her test came back positive for antibody as well as DNA PCR for HTLV1. EBV and CMV were negative. She had high LDH calcium levels. Autoimmune workup was negative. Going back to the pathogenesis of adult T-cell leukemia lymphoma, the infection is usually by vertical transmission from the mother to infant or during breastfeeding. During that time, the first hit happens. The second step in the sequence is proliferation and high proviral load. After that, there will be natural selection, so only the clones with the proliferative advantage will expand, and this will eventually impair the cytotoxic T-cell response. By the age of 30s to 70s, you'll develop a clonal tumor that is positive for CD3, 4, as well as chemokine receptor 4, and negative for CD26. So our patient actually came to us in the acute phase, which is fatal. So unfortunately, she passed away. She couldn't tolerate chemotherapy because of her very elevated liver enzymes. There are also some targeted therapies directed towards CCR4, but it wasn't available at our hospital. As you know, adult T-cell leukemia lymphoma is a T-cell marker that expresses CD2, 3, and 5, and usually lacks CD7. Most of them are CD4 positive, but you can have CD8 or double positive or double negative subtypes. CD25 is expressed in most cases, and CD30 might be variable, but it's almost always negative for cytotoxic molecules. As I said, they frequently express chemokine receptor 4, which could be a therapeutic target. Some studies showed that downregulation of CD7 and upregulation of chemokine receptor 7 and CAD-M1 are more frequently observed in aggressive ATLL compared to indolent ATLL. So the differential diagnosis, of course, you have to take the entire clinical presentation and see if she has, the skin rash. But Sézary syndrome, if it had a lot of nucleoli, you will think about TPLL. If it was mainly lymphadenopathy, you'll think about peripheral T-cell lymphoma, T follicular helper lymphoma, angioneoplastic, and systemic ALCL. The diagnosis is confirmed by viral serology or detection of DNA. So we're going back to the incidence of HTLV1 and 2 in Saudi Arabia. This is a study by our own Dr. Al-Bahrani. The overall incidence was 0.002%, and they were debating whether to cancel the screening of donors because of the low prevalence. So going back to our patient, she's a Saudi citizen, but she was actually born in Kurdistan in Iraq. So this is actually an area known to be endemic for HTLV1. So northern Iraq and Iran are known to have HTLV1, so that explained why she had it. Case number 2, a 38-year-old Saudi male who presented with fatigue, abdominal distension with massive splenomegaly and pancytopenia. As you can see, he's showing leukopenia, anemia, low platelet count. The cells were predominantly lymphocytes, with atypical lymphocytes accounting to 14%. His peripheral blood, as you can see, showed marked neutropenia and monocytopenia, 12% atypical lymphocytes, some showing cytoplasmic projections. His bone marrow was surprisingly very good, with multiple cellular particles. It wasn't a dry tap, and you can see the lymphocyte had pale cytoplasm. A lot of them had circumferential cytoplasmic projections. Some of them had indented nuclei, and occasionally prominent nucleoli. There was reduced trilineage hematopoiesis. This is the flow, and as you can see, we have a B-cell population that shows bright CD20 expression. You also have CD10 positivity, CD200, negative for 23 and 43, and negative for 79B. It was also positive for cytoplasmic lambda, and negative for CD5 and CD38. So the morphology was pointing towards something, but now we have CD10 positivity. We went ahead and did the additional markers. So CD25, 95, 103, and 11C were all positive. Bone marrow morphology is classical fried egg appearance. So this is a hairy cell leukemia with CD10 expression. It has been reported rarely. It doesn't have any significance as for now. The differential diagnosis is, of course, splenic B-cell lymphomas with prominent nucleoli. So I know that Dr. Khalid explained in detail, but in the new WHO, they wanted to steer away from calling hairy cell leukemia variant and B prolymphocytic leukemias. They lumped them all into this category, splenic B-cell leukemia lymphoma with prominent nucleoli. If you exclude hairy cell, if you exclude mantle cell, and if you exclude prolymphocytic progression of CLL, you're left with this category. As you can see, a lot of these splenic lymphomas have overlapping features. We would like to see the classical features that Dr. Khalid showed to us, but in reality, a lot of this morphology overlaps. A lot of them will have projections. If we're lucky, we'll see polarized, but a lot of them might have circumferential projections. So morphology alone is not, it's not diagnostic, but you have to make sure that the cells are not completely showing prominent nucleoli. To see the difference between splenic B-cell lymphoma with prominent nucleoli and hairy cell, you see the hairy cell markers are there, as well as annexin-1, which is probably most specific. Going down to the mutations, you'll see less than 10% BRAF in this category, which is the splenic B-cell lymphoma with prominent nucleoli. So there is some overlap, but always look at the annexin-1 and the expression by flow cytometry of these classical markers. So what we need to diagnose a hairy cell leukemia is characteristic morphology in the peripheral blood or in the bone marrow, strong positivity for CD20 and annexin-1A, or co-expression of CD20, 11C, 103, 25. If you have this, you don't need to do the molecular for BRAF. And you can see here there is significant overlap by features and immunophenotype. But as I said, you have to rule out CLL, mantle, and hairy cell before you diagnose this entity. Case number 3, 14-year-old female, previously healthy, no significant medical issues, who presented with fever, generalized lymphadenopathy, hepatosplenomegaly, and blastoid cells in the peripheral blood. She had low hemoglobin of 7.8. She had a platelet count of 30, low, and atypical lymphocytes, 17%. This is her bone marrow aspirate. On the left side, you see infiltration by these 18% blastoid cells. They're mediate to large, hyperchromatic, with irregular nuclei, prominent nucleoli, and vacuolated cytoplasm. So they kind of look like lymphoma cells. On the right panel, you'll see more proliferation of granulocytic and monocytic cells. So there is a left shift in monocytes and granulocytes, but no significant increase in blasts. But as you can see, the morphology was overlapping. So is it a leukemia or is it a lymphoma? Flow was not that great because, as you can see, a lot of these cells were monocytic cells, sorry. So there was a population that was high on side scatter and the lymphocyte gate. This population was CD3 positive, as well as CD8 positive, with loss of CD5 and loss of CD7, without expression of CD56. So you have a predominantly CD8 positive T lymphocytes with aberrant loss of expression. This is to summarize, 15% positive for CD3, 2, 8 bright, and negative for 4, 5, and 7. So suggestive of clonal population, clonal T-cell lymphoma population. Leukemia screen showed no blasts. Bone marrow showed infiltration by these hyperchromatic cells, look like lymphoma cells, large lymphoma cells, as well as lots of hemophagocytosis. This is the lymph node biopsy, similar morphology as the bone marrow. Immunohistochemistry, it's positive for CD3, negative for 20. As you can see, because of the increased monocytic precursor, you'll have a lot of CD4. But if you compare the CD8, all the cells are positive for CD8. So this is definitely a CD8 T-cell lymphoma. EBV positive, CD30, and ALK negative. So this is EBV positive T-cell lymphoproliferative disorder, also known as systemic EBV positive T-cell lymphoma of childhood. EBV DNA detected 46 million. This is the highest EBV copies I've seen in my life. And she had a fulminant course, of course, and she passed away. So she has fever, hepatosplenomegaly, lymphadenopathy, anemia, thrombocytopenia, low fibrinogen, high LDH, high ferritin, 50,000, going with hemophagocytosis, HLH. So she had both lymphoma and HLH. Systemic EBV positive T cell lymphoma of childhood is a clonal proliferation of EBV infected cytotoxic T cells that occurs in immunocompetent children and young adults, and it's associated with HLH, multi-organ involvement, and rapidly fatal course. This is the spectrum of EBV positive T cell natural killer lymphoproliferative disorders, and the main things here are EBV associated HLH, chronic active EBV infection, which can progress to systemic EBV positive T cell lymphoma. The neoplastic cells are usually CD2 positive, 3 positive, 56 negative, and TIA positive with aberrant loss of CD5 and CD7. If it was an acute primary EBV infection, most of the cells will be CD8 positive, but if it was a progression from chronic active EBV disease, it will be CD4 positive. Rare cases may be double positive, and EBER is always positive. The differential diagnosis, as you may know, in acute EBV infections, you might have clonality by T cell rearrangement, and you might have loss of CD5 and CD7. So these features are overlapping between both. If you find clonal cytogenetic abnormalities, this will point you towards this entity, the systemic EBV infection or T cell lymphoma of childhood. And for our bone marrow, our bone marrow showed a complex hyperdiploid karyotype, including several markers and ring chromosomes, and this confirmed our diagnosis. Case 4, 65 years old female with history of chronic ITP, presented with left arm pain, which prompted the physician to order a CT scan. CT scan showed multiple lytic lesions. SPEP shows an M protein spike in the beta gamma region, 47 grams, elevated IgA and high kappa lambda ratio. Immunofixation consistent with IgA kappa. Her CBC was significant for anemia, and platelet count that was low. Lymphocytes were 69%. So she has relative or absolute lymphocytosis. Her peripheral blood showed rouleau formation and lymphocytosis with plasmacytoid lymphs, no circulating plasma cells. Her bone aspirate was cellular, again showed a similar morphology. However, you start seeing these very small lymphocytes, almost resembling a plasmacytoid lymphocyte, but they're actually lymphoid plasma cells. I know I'm confusing you right now, but they are very small plasma cells. There are no significant increase in lymphocytes. Flow cytometry showed in the plasma cell gate, which was CD45 negative, showed 10% population that is positive for CD45 dim to negative, 38, 138, 20, 81, 27 cytoplasmic kappa and beta-2 microglobulin. It was also negative for 19, 117, 28, and 56. So we have a plasma cell population that is aberrantly expressing CD20. So this is plasma cell myeloma, lymphoplasmacytic variant. It was mentioned in the previous WHO. I see no mention of it right now. It has, there was infiltration by 80 to 90% by kappa light chain restricted plasma cells. And this entity is known to be cyclin D1 positive by immunohistochemistry, but is not necessarily show the translocation. It's reported to have a better prognosis than other subtypes of myeloma, but more studies need to be conducted. Our differential diagnosis in such cases is lymphoplasmacytic lymphoma. Even though it's an IgA, as you may know, there are reported non-IgM lymphoplasmacytic lymphomas. It accounts for about 5% of LPLs, and they could also be non-secretory. It typically involves the bone marrow, just in our case, less frequently lymph node and spleen, and usually expresses B-cell markers. So you'll find CD19, CD20, 22, 79, and 38, as well as light chain restriction. The plasma cells may predominate post-treatment, and you have to look for MYD88 or CXCR for somatic mutation. And we have seen cases where the features are so overlapping that the molecular will do the diagnosis. Case 5, 43-year-old male referred with left adrenal mass for workup. He underwent a left laparoscopic adrenalectomy. As you can see, this mass was mostly composed of sheets of plasma cells with plasmaplastic and anaplastic features. CD20 negative, CD138 positive, lambda restricted by ISH, EBV is diffusely positive. Other findings, cyclin D1, 30%, Ki, 30%, so it did not show a very high proliferative index. Negative for PAX5, 56, c-KIT, HHV8, CD30, and ALK. This patient was immunocompetent, no immunodeficiency known. So this was most compatible with extramedullary EBV positive plasmacytoma, also known as EPIC. He did not have any lymphadenopathy or bone lytic lesion detected on CT scan. He did have a small M protein by SPEP 1.8, so below the cutoff for myeloma. Bone marrow evaluation repeated multiple times as negative for plasma cell dyscrasia, and he had EBV DNA detected in the peripheral blood at around 128,000 copies. So this patient actually had a very progressive course. He had repeated plasmacytomas coming out in the abdomen and different parts of the body, required aggressive chemotherapy and even an auto stem cell transplant. So it wasn't a smooth course, even though it's an isolated plasmacytoma. So in general, plasmacytomas are almost always negative for EBV. You can see rare EBV positive or epics, as we call them. They involve the nasal cavity, head and neck, and GI, which has significant overlap with plasmablastic lymphoma. Histologic and immunophenotypic features are similar to other plasmacytomas, except EPIC can contain CD8 positive T cells. Usually it's extramedullary, but there are rare reports of medullary involvement. So plasmablastic lymphoma is the main differential. It arises in patients with immunodeficiency or dysregulation. However, in the elderly, some people claim they have immunosenescence, and that might make them immunodeficient. So they might have plasmablastic lymphoma, so it's not just restricted to HIV. They express plasma cell antigen, negative for 20, PAX5, ALK, and HHV8, and positive for EBV in 60%. Compared to EPIC, they have a very high Ki67 proliferation index, and more commonly, you will find MYC rearrangements. But there are significant overlap between plasmablastic lymphoma and plasmablastic plasmacytoma or myeloma in general. Always look for light chain restriction and look for monoclonal proteins in the serum for a diagnosis of plasmacytoma or myeloma. This is all I have for today. Maybe I went too fast for the time. Thank you.
Thank you very much for the great presentation and the great challenge that we all felt. I was sweating during this presentation profusely, and I think these cases are really kind of, in the scary side of things. Our next speaker, and I'm really privileged to introduce him, my colleague, my former colleague in National Guard, and one of the superstars of the oncology, molecular studies, and genomics, Dr. Saeed al-Turki, who's a medical school, who earned a medical school degree from King Saud University, followed by a PhD in bioinformatics from University of Cambridge, and then an American board in clinical genetics and genomics from Harvard University. He established the molecular oncology laboratory at National Guard Hospital in Riyadh in 2016. Recently, he joined CAXT as a general manager of Applied Genomics Technology Institute to be part of the Saudi Human Genome Project in collaboration with governmental and private stakeholders. So without further ado, I would like to introduce Dr. Saeed, and the mic is his.
Thank you so much, Dr. Mohammed. Assalamu alaikum wa rahmatullah. Good morning, everyone. It's great to be here today. And the topic has advanced molecular technology in the title. And I think my task was to look at this figure, the cornerstone of how we do the initial workup in hematology patients and see what are the advances, especially in the right side of the figure, in molecular study and cytogenetics. I wanted to bring some new technologies. I wanted to see if the current technology are being pushed so much that it will be very comprehensive or extremely fast or very cheap. And there is some interesting scenarios and findings that I want to share, 5 of them in fact, that's worth knowing today. So before I start, let me first of all understand with you what is the current situation today around the world. We wanted to see some of the leading oncology centers. This is a study published as a survey in 18 different institutes in the US, including the big ones, Mass General Hospital, Brigham, MD Anderson, and others. What they wanted to know is, what is the practice today? What is the challenges? And to give you an idea of how big is the load in each of these institutions, you will see the first 2 of them have 400 or more cases per month. Most of them, however, have 100 to 200 cases per month, and almost half have less than 100. So this is a diverse from small to very big institution. And this is an important figure because it will educate us how the high throughput affect our choices in the molecular labs and what technologies we can use efficiently. So the first question in that survey is, how big is your panel? Is it 50 genes? Is it more? You see that 22% have more than 300 genes in their panel. But the majority are under 150. And it's in 3 colors. Green color means it's a small panel that is focused on myeloid only or lymphoid only. The orange color is a combined bigger panel between myeloid and lymphoid. The red one is interesting. It's all cancer, solid tumor, hematology, everything in one large panel. And the thinking here is, maybe if we have only one panel, it would be much easier in the lab to do the work, which makes sense. But it also means bigger panels means more mutation that we don't know what to do with it, longer reports, more expensive. So understandably, it's only in 22%, while everyone else, or at least 2/3, have more focused panels. Another interesting question was how fast we can do, the NGS. There is superstars who can do it in less than a week, from 2 days to 7 days, from receiving the sample to reporting. However, more than half are actually between 1 week to under 2 weeks. And the final smaller group is within 3 weeks. And another question, they said, okay, so if you have acute stat case, what do you do? 50% of them says, 46% of them says we will use single gene assays. It's very quick, single PCR to do the results. And 40% before the last one say we'll use our NGS, the current one, but we will push it fast. A smaller group that is interesting, they say we have a smaller panel, the focused, very focused, but we will do it very fast. And I want to show you what does that mean, because it's very impressive if someone can do this in less than 5 days. One of those institutions is MD Anderson, where they developed a protocol, they call it ultra-rapid reporting of genomic targets, or shortly urgent-seq. And impressively, they have preliminary reports within 48 hours. It's very impressive. Look at the final report of the conventional protocol. It's within 4 to 5 days. So the conventional is already amazing, but they are pushing it to 48 hours in the preliminary report, and in the final report, it's less than 4 days. So what do they do? It's a multiple small adjustment in the whole workflow. It's not just the lab. In day 0, any case that have blood received, it will be extracted. No question asked. It will be extracted and will be put ready for decision. Then they have a notification system that goes to oncologist, molecular pathologist, or hematopathologist. Any one of them flag it as a stat, it will go immediately into urgent-seq protocol. That's day 0. The second thing that they do is they have NGS run every day. So it's not patched to the end of the week or in 2 weeks. Every day there is a run at 5 p.m. If the samples come early enough, it will be pushed in the protocol. And if it is coming in the early morning, it may go into day 1 NGS, which is very impressive. If it came late in the day, it will go on the next day. So they are ensured that within 24 hours, the samples has been extracted, flagged, and NGS has started. But there is more than just this. This is the workflow for the NGS from sample collection to reporting. And you will see that in the middle part is the sequencing, which is the longest part. It takes usually 30 hours to 36 hours. And they did something to reduce it to half. Basically, they went and said, let's look at how sequencing is being done. And normally, when we have DNA, we want to read from the end of it. We call it read 1, and the other end, which is read 2. So the red box is read 1, and the green box is read 2. And they say they hacked the system, basically. They really hacked it. They say, we will not wait until it's finished the sequencing. We want it to do only the first read, then we extract all the information, run the pipelines, and if there is mutation, it will be reported. With this, they were able to shove almost 15 hours from the protocol. And they let the whole sequencing finish. That's fine, but that will go for the final report. They wanted to get as fast as possible to the raw data. And the result was very impressive. They only did 10 genes, NRAS, NPM1, JAK2, and IDH1, and you see the mutation and how fast was the turnaround time. Most of them was in 2 days. And when they compared it to the conventional work that takes 4 or 5 days, the concordance was 100%. So whatever they picked up in the urgent protocol was the same as the full report. And this is a figure that I use to summarize what is the technology in different factors. How comprehensive is the list of biomarker content? How fast? Turnaround time? And is it cost effective? And do we need a lot of capital expenditure, instruments, and hardware? And is it very sensitive for MRD? So this scores very high on the comprehensive biomarker content because we can go and cover almost everything. It can go very fast like what we saw, but I did not give it 5 points. The reason is this is really in 1 or 2 institutes in the world. You have to have a very good bioinformatics team. You have to have people who understand the technology itself. Usually it's not as fast. I think the average is 7 days, 14 days at best, given there is failures, there is different experience levels, etc. So my subjective, this is just my opinion, if I would give it out of 5, it's 3.1 on average. But in the good hands, it can reach to 4 points plus, like we saw in the MD Anderson experience. The scariest things to us in the molecular lab when there is an update. And we heard today about WHO and Ellen recently. There is so many changes that how fast we can get this into practice. As you saw, there is different panels, and validating a panel takes up to 12 months or 18 months. So it's not a cheap or fast process. And back to those 18 institutions, they asked them how good or excellent your panel compared to the guidelines. And the answer was interesting. In the myeloid, 83% of them said we have an excellent coverage. What does excellent mean? Excellent means either we cover all the genes or we need only 5 genes to be added and to be perfect, which is great. 83% said we are at that level. 11% said we have a good coverage, meaning not everything is covered. Up to 20 genes can be missed and needed to be reflexed to something else. And 5% said we are poor coverage, meaning we are using a very generic panel that may or may not have the genes that we want. The story is different in the lymphoid. It's much less as excellent coverage in most of hospitals. Only 40% says they are confident with having a good panel, while it's much better in the myeloid. So one institution says, to solve this, I don't want to keep changing my panels. I don't want to change every year when there is a new gene, I have to do something else. So they wanted to see if they can combine the molecular and cytogenetics together. And there is two approaches so far for this. The first one is deep whole genome sequencing at 60x coverage, which basically means they wanted to sequence every base in the whole genome from end to end, whether it's genes or junk DNA or introns, everything. And this is, as you can imagine, is very expensive exercise. It can reach up to 8,000, 10,000 riyal per one patient, and a huge amount of data, almost 300 gigabytes for every patient, which means you need a big computational infrastructure. But they have done it, and this is a picture of showing a deletion at 13% cellularity, which is great. That means it is sensitive enough for low abundance biomarkers. In fact, it was so good that compared to cytogenetics and karyotype, they picked in the retrospective study all the recurrent translocation and copy number variants, all of it, 100%. Plus, they added the new findings in 17%, completely new, not picked by karyotype or FISH. And on top of that, they were able to optimize it to be finished within 5 days. And they changed the risk category for 16% of the patient. So this is extremely impressive. In fact, this is the largest, I think, technology that we have today in terms of how comprehensive it is. It takes 5 out of 5. But you can see it's not that great for MRD, so it cannot be used for that because it's only 60 coverage. And it is fast in Washington University, but I know for a fact that this is almost impossible for 99% of institutions because it requires so much bioinformatics and infrastructure to do it in 5 days. And it's not cost effective, of course, and require a lot of instrument. So it's very academic so far. Hopefully in the future we will see this more and more, but as of now, my subjective 5-star rating is 2.4 for us. So panels is way more practical, in my opinion, as of now. Another group have a different approach to this. They say, it's too expensive, let's do something different. We'll use a new technology. And the technology they used is called optical mapping. In theory, it's very simple. If you have a very long DNA as a spaghetti, can you move it in a small nano wells where you make it very long and strand, and then you take a picture? You are not sequencing, you're just taking a picture. And what you end up is having a very long DNA segments with these markers. You can think of this as karyotyping bands, basically, but at a very low resolution. And they map it, and the idea is very simple. If the space between this one and this one is expanding, then that means there is an insertion. If it's shrinking, that means it's deleted. If it is multiplied, that means there is copy number variant. So the technology is able to detect gain loss, deletion, and insertions, copy number changes, and impressively the balanced and the inversion as well. And the resolution is very impressive. At 500 base pairs, it has 95 sensitivity for heterozygous insertion and deletions, and even the larger one, balanced and unbalanced translocation, 50,000. For comparison, karyotype resolution is 5 million. Anything below 5 million cannot see. FISH is 100,000 base pairs. So this can go as low as 500. Very high resolution structure variant detection method. To simplify what does this technology means, you can think of it as combining karyotype, FISH, and microarrays in one protocol, which is beautiful because sometimes when you see something in the karyotype, you need to confirm by FISH, or sometimes you want to see it by microarrays. If you do it once, that's amazing. You have the 3 answers that you want from all the technologies. Early studies showed that in pediatric AML, that in comparison with karyotyping, they agreed on 6, which is this in the middle. The new technology detected 9 new structure variation, which is to be expected. It's very high resolution. It will see things karyotyping doesn't see. But the interesting thing that karyotype have picked 3 things missed by the optical mapping technology. So that is what I was interested to see. Was it a shortcoming of the OGM or not? These are the 3 cases. It says in the karyotype there is chromosome 11 monosomy. So they did FISH and they did the optical mapping. It was confirmed by FISH that it does not exist. So karyotyping was wrong in that case. Actually, it was wrong in 2 cases where it's confirmed by the FISH and was a false positive. So in theory, this is an extremely promising technology for the molecular cytogenetics and may enhance our resolution and novel discoveries of new biomarkers. My subjective evaluation for this is 2.8 as of today. I think in the next 5 years with more studies, this can go to 3.5, replacing a lot of tests in FISH and cytogenetics. The only issue is it's only structure variation. It does not detect DNA mutation. So you'll always need NGS or single gene testing with it. The last 2 methods that I will go very quickly on is combination of FISH and the flow cytometry. It's been around for 10 years, but recently it shows early studies or some stronger evidence for its value in the MRD. So it's a simple FISH, the one that we know all, but done with the flow cytometry. The impressive thing is it's increased the MRD detection level 10-fold compared to FISH, to the minus of 5, which is very impressive. And it is one of the most sensitive methods that we have today for MRD. But everything else is the same as flow cytometry, the shortcoming and the advantages. I think one of the major limitations is it is targeted. So you cannot do a lot of biomarkers at once. It needs to be selected, or at best 5 or 6 combination at one time. The last technology that I want to discuss is this. If you have seen some of these sequencers, it's a USB connected to a laptop. It does NGS for you very cheaply. And a group have used this in combination with the CRISPR, which we know all for gene editing. They use CRISPR to pick fusions and then sequence it. And the idea here is you don't need a PCR. And they were able to detect very important fusion in RUNX, BCR-ABL, BMR-RARA, at a very low cost, almost $80. That is very unheard of. This is the level of BCR. And the result, impressively, was done in less than 8 hours. In fact, some of the cases was finished in 3 hours. And I did not see any technology before that actually so fast, so cheap, with almost no requirements for a sophisticated molecular lab. The only disadvantage is it will not be used for MRD. It's not that sensitive. And you need only few biomarkers. You cannot sequence larger number. So this is very promising. Today, my subjective analysis is 3.6, which is amazing for a new technology. I think with the advancement, it can go for 4 or more stars. So 5 technologies, you see none of them is actually solving everything, different patterns. Some are very good for MRD, some are very comprehensive, some are very cheap, but none of them is actually the perfect method today. But the incremental advances in these technologies is impressive. And this talk, I have to mention AI. It's a hype word. We really need to acknowledge that it is coming our way. I did not and will not discuss the impressive work that is being done in image analysis and combination with the genetics data, into improving and automated reporting, including the karyotype banding. There is a lot of strong evidence that it will take the karyotype images, it will do the banding for us. Sorry?
2 minutes.
Yes, it's the last slide. And I believe it's going to be the future, as we all have that hunch. It's not going to replace the practitioner, but it's an incremental addition. And it's coming our way, and we should embrace it slowly, because there is so much will change in our practice on a daily basis. And the final thing I want to bring your attention to is I'm humbled and privileged to lead recently a new institute called Applied Genomics Technology at KAXT with 2 goals. This institution is a national genomic lab, meaning it will be open for providing its infrastructure for researchers around the country. And we, as in Applied Genome Technology, going to be leading some of the translational of these cutting-edge technologies from basic science to clinical. So if you are interested in any of what I just described, please scan this barcode. It will take you to a registration form to have your interest. We have a lot of funded programs, and definitely would love to hear from you and collaborate together, whether you are a consultant, resident, a fellow, or have an interest in these studies. It's very promising and exciting, and I would love to start working with all of you on this. And thank you so much for listening.
Okay, thank you very much, Dr. Saeed. We will conclude our session today with Dr. Abdullah Al-Swaidan. Abdullah Al-Swaidan is a consultant, molecular genetics and hematopathology at King Faisal Specialist Hospital Research Center in Riyadh. And Dr. Abdullah will present some challenging cases from molecular hematology aspect.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you so much for this opportunity. I would like to start by thanking the organizing committee and thank you all for attending this session. Again, maybe similar to the previous excellent talkers before me, these are some challenging cases, maybe not that challenging, but more like interesting cases that I see in molecular hematology during signing out molecular NGS and other testing. As you know, molecular techniques has been changing over the last few years, and we just saw how Dr. Saeed presented excellently how these advances in molecular technique is expanding, the advances in technology also is expanding, the IT is expanding. So if you go back 10 years ago or 15 years ago, molecular used to be think as an ancillary test. So no one is interested to do, let's say, FLT3 or MBM1 or other interesting genes. All of these genes have become more and more important, and we are expanding our testing in the last few years because of the targeted therapy. Now, we should use always a comprehensive approach. So it's not just the morphology. Morphology still it's a critical, still morphology is the gold standard, but we need to have a more comprehensive approach, including morphology, clinical presentation, immunophenotyping, flow cytometry, karyotyping, FISH, and molecular technique. So we should think of all of the neoplasm and myeloid neoplasm, lymphomas, and others as a comprehensive, integrated approach for these cases, looking for the clinical aspect, looking for the morphology, and adding the molecular as supporting in these cases. With time, the role of molecular testing is increasing, so we are seeing more and more cases that can be diagnosed based on molecular from peripheral blood, for examples. The ultimate goal is to understand the tumor, you understand the biological concept and behavior of this tumor, and provide most accurate diagnosis and the best targeted therapy for our patient. Now, why we do molecular testing? What's our target? When we think about molecular tests, all of the molecular testing targeting either DNA or RNA. So we are looking for DNA or RNA changes. When it's one of the reasons why we do it is for rearrangement. So if you think about rearrangement, either rearrangement, physiologic rearrangement, like in somatic hypermutation, for example. We do it to see any changes in the B cell, how to fight the organisms. So we do this and we see physiologic changes like in IGH variable chain mutations or rearrangement on these genes, or pathological fusions like in sarcomas or even leukemias where we have several fusions. We're also interested in SMVs and small indels, so these are point mutation, either missense or nonsense mutation or small insertion deletion, so we can detect this in the DNA or RNA. We also do copy number changes, so we can do it for duplication, amplification, or deletion and silencing. All of these will affect the function of the gene. So we are looking for these at the level of DNA or RNA, and we see the ultimate effect on the function of the DNA. What's the major indication for molecular testing? If you are a pathologist, why you send the test for molecular lab? So either you send it for diagnosis because there are some diagnostic entities that require specific mutations. So you need to send this sample to get the diagnosis based on molecular. Sometimes it's not the diagnosis. Sometimes you know this is acute leukemia, acute myeloid leukemia, but you send it for classification. So if you have seen the classification of acute leukemia this morning, most of the classification is now based on genomic alteration or based on fish finding or cytogenetics. Sometimes it has a prognostic significance, so some mutation associated with more adverse reactions, and sometimes there is a targeted therapy, and in some occasions we use the molecular for monitoring, so MRD testing and similar testing, so you can, if a patient in complete remission, you can do the test and see exactly how frequent is this mutation, and you can detect something at very low level. Targeted therapy or cryptic abnormalities, like in some cases that cannot be detected by karyotyping, molecular will help with that, with these cases. Dr. Saeed did a great job explaining several of these methodologies. If you want to summarize Dr. Saeed's presentation, there is no perfect test. So every test answers different question, and every test has a limitation. That's very important. So you hear always about new technologies, a new test adding to the menu, but none of these tests will replace. Every test here has significance. So conventional cytogenetics, very important. FISH is very important. Chromosomal microarray, optical genome mapping, targeted exome, whole genome, and RNA sequencing. All of them, they have values for MDS, MBN, AML, either as diagnostic, as follow-up, some of them used in relapse, and some of them used in MRD testing. All of these tests collaboratively provide most accurate diagnosis for patients. They are different in terms of resolution. So you may get one test positive, the other test is negative because they answer different questions. That's the most important concept. Every test has different use in the molecular lab. They have different turnaround time, cost is differently, sensitivity is differently, the coverage, some of them more comprehensive and some of them more targeted. Some of them include copy numbers, some of them only SMVs, especially with NGS. All of these are NGS targeted, exome, whole genome, all of this is NGS based, even RNA sequencing are NGS based. But NGS is a technology that can design the way you want, so you can get different information based on NGS analysis. Genes involved in myeloid neoplasm, they shared between acute leukemia, MBN, MDS, xenophilia. You can see most of these genes are shared, but there are some specific genes more common like JAK2 or CALR or MBL1, MBL. Some genes are more common in some entities, but in general we call them myeloid neoplasm because these genes shared between most of them. Some of myeloid lesions has also fusions like BCR-ABLs and others, and we have seen this during the acute leukemias talk today. This is a very important slide. This is the most important slide in my talk. This is the updated 2022 ELN guidelines risk stratification, and this is what the clinician use to decide therapy. So, and this is updated from the 2017 risk classification. So if you remember, we used to think of FLT3 ITD, we used to do the allelic ratio. And our oncologists always ask, we need the allelic ratio because allelic ratio can differentiate between favorable and intermediate risk. Now allelic ratio is no longer considered. So we don't have allelic ratio in FLT3 ITD. The reason, because it's difficult to standardize between laboratory, and because we have the FLT3 inhibitors now. You remember previously we have the bioallelic CEBBA mutations. Now it's not biallelic anymore. Now we are interested in frame BZIP mutations. So it has to be in this domain, the BZIP domain. One of the other changes also, so now we think of MBM1 as favorable prognosis, but if you have MBM1 without FLT3, this is favorable. MBM1 with FLT3, then it will be in the intermediate category. If you have any of these cytogenetics abnormalities with MBM1, then it will be in the adverse. So cytogenetics adverse will always trump the MBM1 mutation. There are some other changes. Now you can see these genes that has adverse effects. So all of these are genes detected by NGS, and these are usually seen with AML, with myelodysplasia related changes. A complex karyotype now does not include cases with hyperdiploidy. So hyperdiploidy is no longer considered complex karyotype and no longer part of the adverse reaction. So why we do all of this molecular testing? Because it's informed therapy. Therapy is based on molecular. We do molecular testing and NGS not because we are just want to know the finding, want to know what's the mutation. That's good, but not the main reason. We would like to provide the targeted therapy, the most accurate therapy for patients. And this is an old slide, but you can see that based on the molecular finding, the patient will receive different therapy based on what we decide present in this patient as pathogenic mutations. When you interpret the NGS, there are several caveats for interpreting the NGS before we go through the cases. So one of them is very important to understand the panel, how the panel is designed, what's the gene covered, because every NGS panel is different, and I think Dr. Saeed also shows the difference between different institutions. It's all of them, they test for NGS myeloid, but different panel, different genes included, different coverage, different quality metrics, sensitivity, specificity, lower limit of detection, all of these are different. So you need to understand the limitation for every test. Quality of sample is very important. If you have a bad biopsy, you cannot give a diagnosis under the microscope because the aspirate is limited or the biopsy is limited. The same thing with NGS. If you have a bad sample, you can get a false negative or you get a failed result. Very important to understand the difference between somatic and germline mutation with the NGS analysis. Variant allele frequency is very important to know if this is a dominant clone or subclonal process. Variant classification, so not every mutation are the same. Some of them pathogenic, some of them variant unknown significant. It's very important to understand the concept, and you need to know if your panel is single gene versus multiplex testing. This is our panel at King Faisal Specialist Hospital. It's basically the Oncomine myeloid panel from Thermo Fisher with around 69 genes, some of them hotspot, and including also the fusions analysis. So let's go through the cases. This is the first case. So this is a 63-year-old patient with anasarca, fatigue, anemia, thrombocytopenia for 6 months. Now the patient has splenomegaly. So clinically, he has a lot of abnormalities. This is the CBC. Definitely, there is some anemia and thrombocytopenia. There is no circulating blast. The aspirate was limited, so the aspirate was not that helpful. Dry tab, no good aspirate. This is the biopsy showing normal cellular, no evidence, no clear evidence of dysplasia. We always like to assess dysplasia on aspirate. There is no increase in blast, no aberrant blast population. FISH is positive for 20 deletion and 5 deletion. So basically, the morphology was within normal limit. There is abnormalities in the FISH result. When we receive the myeloid NGS, there is multiple mutations. So there is IDH2 mutation, SRS2 mutation, CBL, and KRAS, and all of them at good allelic frequency, 46, 51, and this is the IDH2. This is what we call the integrated genome viewer. So this is the reference sequence and the reference amino acid, and you can see there is a mutation here in IDH2 changing the amino acid structure. So in this case, the IDH2 associated with the clonal hematopoiesis of undetermined potential only if the patient is healthy. So if the patient is symptomatic, then you cannot call it CHIP mutation. It's an early event in leukogenesis, frequently increased with age, associated with MBM1. IDH2 is considered a favorable outcome, and because we have the IDH2 inhibitors. On the other hand, SRSF2 is associated with poor outcome. It's part of the spliceosome structure. So basically having a multiplex mutation or multiple mutation like this case will make you think this is definitely not normal. Even if the bone marrow morphology is normal, this is very high. This patient definitely has something like MDS or others. And repeat biopsy in 3 months shows full bone dysplasia, and aspirate was full of dysplasia. So it's just a matter of early diagnosis, so, or sometimes limitation of the samples. If you have limited bone marrow biopsy, then maybe the NGS will help you, as in this case. Next, this is a 59-year-old female presented with pancytopenia. As you can see, there is leukopenia, anemia, and thrombocytopenia. White blood cells, there is no blast. The bone marrow aspirates, there is decrease in myeloid erythroid cells with full maturation, occasional dysplastic megakaryocyte, but it's not at the level to call it MDS. So there is slight touch of dysplasia. Biopsy hypocellular, which we don't see usually with MDS, hypocellular bone marrow with decreased myeloid and erythroid cells, full maturation, occasional dysplastic megakaryocyte, again, not at the level of full dysplasia, no dysplasia in erythroid or myeloid, flow cytometry, no aberrancy, FISH was completely normal. When we did the myeloid NGS, it's only positive for DNMT3A at 10%. So this is a pathogenic, not the most common mutation that we see, but again at 10%, not that high. DNMT3A is associated with CHIP, so it's one of the very famous genes. There are 3 genes that are well known to be associated with CHIPs. There are many genes associated, but 3 common genes, the DNMT3A, and the TIT2 and DNMT3A and ASXL1. So ASXL1, DNMT3A, and TIT2, they are associated with CHIP. Frequency increase with age. If you see it with MBM1, with FLT3, with IDH1, then you start thinking of MDS. Prognostic significance is not consistent. Poor prognosis only if you see it with other mutation like MBM1 mutated or FLT3 mutation. There is no value in MRD testing, and that's very critical. If you see DNMT3A later, after the patient in remission, this could be something clonal but not related to the leukemia. So in this case, what do you think? We have DNMT3A mutation at 10%, and otherwise almost negative bone marrow, a touch of dysplasia. So this could be a CHIP, especially that the allelic frequency is 10, and could be a real mutation. Again, CHIP, we see it in healthy individual, but with time, this patient may develop MDS later. So I don't think the physician will act on this mutation alone. Next, this is a 56-year-old with refractory anemia. CBC shows clearly there is anemia, platelet count and white blood cells are within normal range, no increase in blasts. The bone marrow shows hypercellular bone marrow with prominent myeloid proliferation, monocytosis, mild dysgranulopoiesis, and dyserythropoiesis. So the suggestion of the diagnostic morphology is CMML, chronic myelomonocytic leukemia, and FISH was normal. So we did the myeloid NGS. We found TIT2 mutation, truncating loss of function at 63%, SRSF2 mutation, very common. This is P95L. MBM1, this is type 1, type A duplication, and KRAS, also a hotspot. All of these are hotspot mutation, and the patient, based on this, receive chemotherapy, because this is not a regular CMML, this is an advanced CMML, especially with MBM1. So once you see MBM1, in fact, now it's become a diagnostic entity within WHO, so AML with MBM1 mutation, according to WHO, you don't need even a blast, but I don't think it will be difficult to call something acute myeloid leukemia with zero blast. That's difficult. So the ICC would require at least 10% blast. But even if there is no blast, wait for a few months, it will become acute myeloid leukemia, because the MBM1 is diagnostic for acute myeloid leukemia. So even though the morphology shows no blast, CMML, but finding this mutation, and again 6 months later, you can see that especially the leukemic clone respond the most. So the MBM1 and KRAS, they are very close in terms of allelic frequency, and they become to 1%. That responds the most to the chemotherapy. This is the leukemic clone compared to the other clone, which used to be CMML. So the 63% and 48%. So the lesson from this case that some mutations like MBM1 showing you that this patient is transforming very fast to acute myeloid leukemia. This is some information about MBM1 mutation. It's very common. It's the largest entity in AML. If you have MBM1 with FLT3, it's a good prognosis. Without FLT3 mutation, it's a good prognosis. With the FLT3, to become intermediate prognosis. The good thing about MBM1 that we can use it for MRD testing, and this is also available at our institution. So you can do MBM1, especially type A, B, and D, the most common type. So 95% you can detect up to 1 in 10,000. So you can follow these patients with MBM1 mutation. Case for a 55-year-old male, known case of hypertension, hyperlipidemia, ischemic heart disease, and all of the diseases seen in elderly individuals, heavy smoker. Now the patient has thrombocytosis since 2020, and also there is hepatosplenomegaly. White blood cells, or CBC, shows increase in everything. So pancytosis, there is leukocytosis, erythrocytosis, and platelet is 1.5 million, so very high. Interestingly, the patient also has 11% eosinophils, so almost 2,500 cells eosinophils. Patient refused bone marrow biopsy. We followed him several times. He doesn't want to do bone marrow biopsy, so they send blood samples for myeloid NGS. And this is what we found. We found JAK2 mutation. JAK2 is well known, associated with MBN, and can be seen in other myeloid neoplasm. But also we found the FIB1 like 1 BDGFR alpha fusions. So this is the fusions commonly seen with hypereosinophilic syndromes, basically due to deletion of CHEK. So CHEK, all of this is a chromosome 4. So it's for deletion within chromosome 4. If there is a fusion by FIB1 like 1 and BDGFR alpha, the CHEK2 will be deleted, so you don't see it here. You see this is the normal, you see CHEK2 between them, and here deletion, that means there is a fusions. So this fusion is characteristic for hypereosinophilic syndrome. It's well known and associated with the response to TKI. This patient also had JAK2 at very high allelic frequency. Interestingly, JAK2 and BDGFR alpha work in the same pathway, so that means this patient has a different hit at the same pathway. And now the new WHO, they changed the name of this disease. It became myeloid and lymphoid neoplasm with eosinophilia and tyrosine kinase gene fusion. So this is the new name. The good thing for BDGFR alpha, they respond to TKI like imatinib. This patient also had JAK2, so he's also will be eligible for JAK2 inhibitor. So this is one of the usefulness for molecular test. Even without a bone marrow, we found the diagnosis, and the patient is eligible for 2 medications.
3 minutes more, doctor.
Okay. This case, this patient has, well-known patient has myelofibrosis, so we know that. Now he come to us with 5% blast. So there is fibrosis, now there is a blast. We would like to see how is the molecular finding. So there is JAK2, which is associated with myelofibrosis, we know that. But there is also IDH2 at 36%, DNMT3A at 44%, and MBL. So with JAK2, so we always think of MBN had either JAK2, CALR, or MBL. This is not the common MBL, but it's also reported to be pathogenic loss of function. So this patient has 2 mutations associated with MBN, but also has IDH2, and IDH2 is one of the more aggressive mutation. If you see it in myelofibrosis, it's associated with fast progression. So IDH2 and other genes, there are genes, if you see it in BV, associated with worse prognosis, gene with ET associated with worse prognosis, and all of these genes, if you see it with myelofibrosis, associated with faster progression for acute leukemia. And this is exactly what we see in this patient, because the blast is around 5%. This case, just quickly, this is a patient, 6-year-old boy, T-cell lymphoblastic lymphoma. His younger brother, so he's 6 years, younger brother also died from T lymphoblastic lymphoma, so there is something in the family germline. The patient, after completing therapy for T-cell lymphoma, he developed acute myeloid leukemia. So there is something in this patient. You think about something germline. So testing by whole exome sequencing, we found Lynch syndrome mutation in MSH2, one of the mismatch repair protein, and also the amyloid shows RUNX1 mutation at 47%. The lesson from this case is to do germline testing. So there are a lot of germline predisposition mutation that's seen. If you do germline testing in our institution, we expose all of these patients to whole exome sequencing. So any patient with cancer, we prefer to do whole exome sequencing if there is suspicion for germline mutation. And ideally, every patient with cancer should receive whole exome sequencing to rule out germline, because you can prevent this in the families. RUNX1 mutation, also one of the common germline mutation that can be seen in some cases. Also, there is a trend now to do whole exome sequencing for donors. So if you are going for bone marrow transplant, it's good to make sure that the donor don't have any mutation for late onset genetic diseases. So this is what we do right now. We expect the result to be negative, but we would like to screen this donor with whole exome sequencing. In summary, myeloid neoplasm are heterogeneous. We know that. If they are heterogeneous in morphology, heterogeneous in the prognosis, in morphology, in clinical, that means they are also heterogeneous in terms of genetics. Morphology is the gold standard. Myeloid NGS is become a standard of care. So every patient with leukemia that come to us will receive myeloid NGS, including full DNA and RNA sequencing for mutations and fusions. Whole exome sequencing should be offered for every patient where germline mutation is suspected. Similar to morphology, NGS depend on the quality of the samples. Knowledge of biological information about tumor is very critical in understanding how the tumor behavior and deciding the targeted therapy. And thank you so much.
Okay, this was a very hot session, and I would like to have the speakers please to come to the stage to receive your firing questions. Questions from the audience, please. Okay, can you pass the microphone?
We as hematologists, when we do bone marrow, we don't get sometimes a sufficient aspirate. Sometimes, as bone marrow is dry, sometimes we enter the sinus and we get blood, not the bone marrow aspirate. So as hematopathologist, what do you expect from us? What type of sample and how should it be for each? I mean, for morphology, for flow, for cytogenetics, and so on.
think this should go to Dr. Suwaidan.
And I think this is a good question, especially that we are needing more and more samples and adding more and more tests. The standard of care that we receive samples for flow cytometry, for fish analysis, karyotyping, and for molecular, and definitely for morphology. So these are the 4 labs. They are, by the way, different labs in most institutions where they do this testing for molecular, for leukemias and MDS. We prioritize the morphology and flow cytometry because that will give you the exact diagnosis. Then it comes the cytogenetics and molecular as a second line. I don't know if I answer your question or.
Yeah. Any more questions? So I have a question actually for Dr. Said Turki. You mentioned the University of Washington, or Washington University. So I was brainwashed actually in May. I attended the ISLH, and it was in New Orleans. And I think the person who was behind this project was doing really intensive brainwash for us to say that whole genome is the way to go. It's more sensitive. There are a lot of myths behind, and the cost will go down with time and that sort of thing. But if you can elaborate on that, I mean, you mentioned nicely you analyzed the thing nicely, but I think there will be a lot of people around talking about the whole, the whole genome as the holy grail.
Sure, absolutely. This reminds me of the rich people problem. Sometimes they think they have it easy for everyone, and I really like him, and I think this is true for his institute. Illumina is the one that's produced these data is in the US, so the prices is much better for large institution. So the cost really in America is at least 50% of what we have today here in Saudi Arabia. That's one. 2.
He gave figures actually. I have the figures.
Please.
It's $1,711 for the whole genome, and for the panel of 40 genes, $584. And he said we can, we can bridge this gap easily with more work.
I was just discussing with one of the colleagues for the whole genome sequencing in Saudi Arabia now. It's reached 4,000 riyal. That's hereditary.
How much?
4,000 riyal. That's almost $1,000 for hereditary. What we are discussing here is somatic, so you need to double that because you need larger sequencing. So it's 8,000 riyal. So the bare minimum now is 8,000 riyal. And that's assuming if you send it out. If you bring it here, the machine cost is 1.3 million $, without the storage, without the salaries of bioinformaticians. So my point is, if there is a large institute with high throughput, it will make sense over time. For most of us with small to medium-sized labs, I'm not seeing that yet. It will come, but not at least for.
But as a national project, or high throughput center, or centralization, or all of that, do you see this is feasible for us in Saudi Arabia?
Absolutely. I think it will come as large national programs, and I think King Faisal, Al-Haras, Al-Askari, I think there is a new initiative coming from the Saudi Genome Project Phase 2 for this kind of collaboration.
Simply because my experience with even requesting the equipment, as Department of Pathology, every time you participate and you tender something, by the time the delivery, the thing becomes obsolete actually. So why, if the whole genome is coming and the only thing is the cost, probably if we plan early and we centralize the service where, have big centers where they receive the volume, that will be great for our patients and for our country.
I think we don't lack infrastructure in Saudi Arabia, or money, or the will. I think it's just organizing the efforts in the one direction. That's it. We have in the country at least 10 NovaSeqs, the big machines, more than enough to cover all the patients. but it just needs to be organized in a certain way. So I completely agree with you, and I hope this will happen soon.
I just want to add that the figures that Dr. Saeed mentioned is correct. So it will cost around 8,000 riyals to run whole genome for somatic right now. But within a couple of years, it will drop down to almost 1,000 riyals. So the price within just 2 years, expected by 2026, the prices will be around 1,000 to 2,000 riyals. And for us at King Faisal, by 2025, we are planning to stop all whole exome. So all of our hereditary will be whole genome sequencing. The cost will be very lower if you run high volumes, because the cost associated with volume. The other thing, hematologic malignancies are very lucky because your tumor in the blood, so the cancer, some MDS or leukemias, they are already in the blood. We face difficulties, let's say, with the brain tumor. We face difficulties with lung cancer or colon cancer. You do whole exome, whole genome, you find nothing. But for you in hematology, it's in the blood. So collecting a blood sample, whole genome, you will find the abnormalities very easy. You will detect also structural changes and copy number variants, and all of these can be easily detected from whole genome. So I expect in the future, whole genome will become the mainstream of testing and it will become cheaper. But again, it will not answer every question. So there is a limitation for every test.
More questions? Dr. Nala, and then Dr. Ghalib.
Thank you very much for your talk, all of you. It was an amazing session. My question is for Dr. Swaydan about the NGS MRD, about King Faisal experience. How frequent, what's the protocol? I noticed one of the cases, it's been done after a 6 month. So are you doing it in which time plan?
Excellent. MRD is very critical test. And if you do comprehensive MRD testing, the cost will be very high. Like you can run MRD testing on the same kit, but the cost is very high because to run MRD testing, you need to do deep sequencing up to 10,000, sometimes up to 30,000 we reach with something like liquid biopsy. Because we do liquid biopsy for solid tumors, we do very deep sequencing. The cost is very high. So this is why we cannot do it for every case. We do MRD testing based on cases like BCR-ABL, MBM1, Inversion 16, 821. So these are real-time BCR that qualified as MRD because they detect 1 in 10,000. MRD by NGS is available, but costly. So the best approach, if you know exactly what's the mutation at time of diagnosis, is to do a digital droplet BCR. And we are lucky to have our oligosynthesis unit. So we synthesize our own primers and probes in-house within our department. So we can design, knowing what's the mutation, we can design the primer and the probe and run digital droplet BCR that can detect even 1 in 100,000, like if you design it in the right way. That's the way to go for MRD. The more comprehensive to run the entire panel at MRD, the cost will be very high.
Dr. Ghalib.
Thank you all speakers for excellent presentation. That's my comment and the question from hematopathology and the molecular branch as well. As we know, low-grade small B-cell lymphoma is challenging, especially if we don't have lymphadenopathy or mass for biopsy. And we know spleen difficult to take biopsy from the spleen. And also we have overlapping between all this follicular marginal zone lymphoma, hairy leukemia, and there is some apparent expression, and sometimes we lose some expression like atypical CLL or atypical mantle cell lymphoma. And the issue is how to convince the clinician, how to report it in your report if you don't have clear definitive diagnosis as due to overlapping and loss of some marker, and any of also how to report it, how to convince the clinician, because the clinician usually asks for definitive diagnosis. He need to treat the patient either marginal zone lymphoma or hairy cell leukemia or hairy cell leukemia variant or mantle cell lymphoma or CLL. So how to convince, how to report the cases, to be in the safe side and for the patient safety, and any help from molecular
How
side
can we
as well.
convince you to finish the question, Dr. Ghalib? This is a long question.
Okay,
I
that's
think
it.
it
That's
goes to
it.
Dr.
Yeah.
Khalid Al-Ayed to answer this question.
Well, actually, I don't know. It depends on you how to convince him. So what I'm saying, the cohort that I just presented, so the NGS cohort was 39 cases, only the LPL versus marginal zone lymphomas. But it was a bigger cohort, it was around 150 cases. So I would say we came across around 15 cases where, you know, general diagnosis was made, like CD5 positive, you know, LPD, or CD5 negative, CD10 negative LPD. You know, with after, you know, receiving the NGS results, we were able to, like, you know, definitely reclassify 15 cases to like a proper diagnosis. But we left with maybe like around 3 to 5 cases still undefined. So this is our limitations. Sometimes we cannot like proceed with accurate diagnosis. You may discuss it with the clinician. This is what we have. This is what we favor. But you know, keep a back door open in case, you know, the patient will show something else like later. Just, you know, as a differential diagnosis. No answer I think I can provide more than that.
So for splenic B-cell lymphomas, you have to rule out mantle easily, cytogenetics on the peripheral blood, FISH for translocation. Hairy cell by flow, I mentioned the markers. If you don't have flow, you can easily send for BRAF in Saudi Arabia or outside. So, and CLL, you send for FISH for CLL. So you rule out these 3 entities. Other than that, the clinician doesn't care. Dr. Darwish is here, our lymphoma consultant. You write it as splenic B-cell lymphoma, and you put in your differential, and you explain why you still have a differential and you don't have a definitive diagnosis. The management is the same.
Okay, thank you very much. One more question to Dr. Reem, and we will finish because it won't give us enough time for lunch and all. The plasma cells, the plasmacytoma versus plasmablastic lymphoma, it's very tough.
Yes.
The case you presented was very tough, especially I personally have to confess I did not know about the EBER, because when I was studying for my exams not long ago, it was, we have a table for the things to differentiate. Cyclin D1, CD56, and EBER was one of them to favor plasmablastic rather than plasmacytoma. So can you elaborate more on that?
So since the discovery of this entity, everything has been harder because we used to, as you said, check for CD117, check for CD56, check for cyclin D1, and if you find them, you would favor myeloma versus lymphoma. But even the plasmablastic lymphoma is now reported to be CD56 positive occasionally. MYC rearrangement can be seen also in myeloma and lymphoma. I think I had another challenge.
So the role of molecular here now, like this is really a dilemma.
MYC, you've seen it, MYC rearrangement can be seen in myeloma as well. So for me, this is my second challenging case. The other challenging case was purely lymphadenopathy in an elderly patient. And after a while, the monoclonal protein started coming out. So that led us to think it's a plasmablastic myeloma. So if it's an elderly patient, it's hard, as I said.
HIV also can.
Yeah, HIV, it's straightforward, but it's plasmablastic lymphoma most of the time.
Small clone also would not help,
yeah,
because
would not
you
help.
can have small
but,
clone either one.
What we face is with the elderly, with the immunosenescence, and some of them consider them as immunocompromised, and they could develop these lesions. As I said, look always for monoclonal protein. In this case, it's a pure plasmacytoma. So the monoclonal protein did not elevate above 3. So it was just low, but we kept on monitoring, and the kappa-lambda ratio was okay the entire time. So it is a plasmacytoma.
Okay, great. Thank you very much for all the speakers and all the audience. Very heated discussion, and we will see you again, inshallah, after prayer and lunch.
and I think it's going to be a very nice and light session. The focus is on coagulation. Our first speaker is Dr. Rahaf Al-Tahan. Dr. Rahaf is a consultant hematopathologist at King Fahd Medical City in Riyadh, and she's also the program director at King Saud University Fellowship in Hematopathology and Transfusion Medicine. Dr. Al-Tahan obtained her motherboard from King Saud University, and then she went on to have subspecialization in coagulation in McMaster, Canada. She participated in many academic activities, and she participated in writing many chapters in different books, and she was awarded the research travel for ISLH in 2022. So today she's going to talk to us about a very common disease, and it is actually something that all of us meet in our career. So welcome, Dr. Tahan.
Thank you so much, Dr. Afra. I'd like to thank the organizing committee for this great event, and I would like to thank them for letting me part of it. So today I'll talk about von Willebrand disease. Objectives are to go over introduction of von Willebrand antigen and disease, to discuss classification of the congenital and acquired forms, and to discuss some laboratory testing. So von Willebrand antigen is a large multimeric glycoprotein that is synthesized in the endothelial cells and megakaryocytes, and then it's stored in the Weber-Palade bodies and alpha granules of the platelets and endothelial cells. Now, this process is really complex. That starts with the synthesis of the protein, transportation, multimerization, and dimerization, and ends by release of an ultra-large molecular weight von Willebrand factor that is the most hemostatistically potent form of the protein. ADAMTS13 is a very important cleavage protein that is responsible for cleaving those very potent components. Now, looking at a monomer, von Willebrand monomer, it has many domains that interact with different proteins, including D-D3 that interacts with factor VIII, a one domain that interacts with glycoprotein 1b alpha of the platelets, ristocetin, and collagen. Collagen also has another binding site at A3 domain, and alpha 2b beta 3 integrin of the platelets bind at C4 domain. So it has multiple binding proteins. Now, the functions of von Willebrand include that at sites of injury, VWF bridges platelets to the vascular subendothelium, and this is the platelet adhesion. And at high shear stress, activated platelets express alpha 2b beta 3, which binds VWF and fibrinogen, and this is the platelet aggregation. And finally, it's the chaperone or a carrier for factor VIII that extensively extends the half-life of factor VIII and maintains normal plasma level. So as you can see, von Willebrand factor has important roles in both primary and secondary hemostasis. Now, von Willebrand disease was first described by Dr. Eric von Willebrand in 1926 on a Scandinavian family, and the index case died of menorrhagia during her fourth menstrual cycle. It is by far the most common inherited bleeding disorder, accounting for 1 in 100 to 1 in 10,000. And this is, although a relatively old study, but it's a local one that retrospectively collected patients over 8 years and analyzed patients with hereditary bleeding disorders. So it shed light on the proportion of von Willebrand disease in our population, which comprise around 15% of them. So patients usually present with mucocutaneous bleeding, as in extensive bruises, epistaxis, gum bleeds, and menorrhagia. They also can present with prolonged bleeding from minor wounds, bleeding after dental work, childbirth, and surgery. And in the most severe form, we get musculoskeletal bleeding, especially when factor VIII is really severely affected. This is another local study that looked at bleeding patterns in patients with von Willebrand disease that showed the most common bleeding pattern was combined bleeding followed by joints and muscle bleeding, suggesting a more severe form of the disease. Now, classification of von Willebrand, it's classified into 3 types, 1 and 3 being the quantitative deficiency of a normal protein, type 2 being the qualitative or a defective protein. Now, type 1 is a quantitative deficiency of von Willebrand factor, where there is concordant reduction of both the activity and the antigen. It is caused by missense or null allele mutation, in this case, a heterozygous or carrier state, and it's an autosomal dominant disease. It is the most common form of von Willebrand disease and is defined as VWF below 0.30, regardless of bleeding pattern, or below 50 with abnormal bleeding. Factor VIII usually fall in parallel with von Willebrand, so usually you find factor VIII at about 1.5 that of von Willebrand. And type 1C is an interesting subentity of type 1 that shows significantly increased clearance, that's why it's called C. It comprises around 15% of cases, and treatment may be impacted due to the short half-life of von Willebrand disease, as patients are not really good candidates for desmopressin therapy. Type 1 Vicenza, some patients with type 1C, they show ultra-large molecular weight multimers, and this is explained by high turnover of VWF, which does not give enough time for ADAMTS13 cleavage, resulting in the presence of recently secreted ultra-large molecular weight multimers. So both 1C and 1 Vicenza indicate really increased clearance of the protein. Now, type 2 is the qualitative defects in von Willebrand factor, where there is discordant decreases between the activity and antigen. Type 2A is the most common form of type 2, and it's autosomal dominant disease that results in loss of intermediate and high molecular weight multimers. And again, these are the most potent, hemostatistically potent factor. And this results in diminished platelet binding. Type 2B is another interesting entity in type 2. It's autosomal dominant, and it is caused by by a gain of function mutation of the A1 domain, resulting in significantly increased binding to glycoprotein 1B alpha on the platelets. This significantly increases the interaction and causes accelerated clearance of patients and the high molecular weight multimers. Now, patients are not infrequently misdiagnosed as ITP in this entity. And however, I want to point out that thrombocytopenia, although is seen in the majority of patients, is not necessarily present in all of them. When we talk about 2B, the other entity that mimics it clinically is the platelet type pseudo von Willebrand disease. It's caused by a mutation in the glycoprotein 1BA gene of the platelet rather than a mutation in the von Willebrand disease. And there is rationale to differentiate between these two entities. In terms of the therapy, if the patient needs replacement, will you give platelets or VWF concentrates? Now, although I'll be talking about laboratory at the end, I thought it's best to discuss ristocetin-induced platelet aggregation, or RIPA here, because it has characteristic findings in type 2B. So it measures the affinity of VWF binding to glycoprotein 1B in the presence of different concentrations of ristocetin, and then the platelet aggregation is recorded. So this is a normal result from a normal donor, and as you can see, a high-dose ristocetin should produce this normal aggregation response. However, the low-dose ristocetin should not cause any response in a normal individual. In the contrary, this is a patient with either type 2B von Willebrand or the pseudo von Willebrand, where the patient is showing abnormal aggregation to low-dose ristocetin that's usually 0.5 milligram per ml. Now, other abnormalities that can be seen in RIPA is reduced responses to the higher concentration of ristocetin, including type 1, 3, 2A, 2M von Willebrand disease. Now, what we do next is just to separate or differentiate between type 2B and the pseudo von Willebrand, is that we mix patient plasma with control platelets and or patient platelets with control plasma. So which one is type 2B and which one is platelet type von Willebrand disease? The left panel shows a type 2B where the defect is in the patient plasma containing the von Willebrand disease, whereas on the right side, the platelets are really the defected component. So as for the recommendations that we have, the upper side is the BSH guideline, although relatively old now. They specify that it should be, or they recommended RIPA for all patients with reduced VWF activity to antigen or with patients who have thrombocytopenia. The more recent consensus guideline published in 2021 suggests targeted genetic testing for these patients over RIPA. Now, this is a suggested, so it's a conditional recommendation with low certainty in the evidence. So it depends really on what you have in the lab to confirm these patients. Next is type 2N, is a rare subgroup. It's an autosomal recessive disease. It's caused by missense mutation in D-D3 domain that causes reduced binding to factor VIII. And you will see disproportionately lower levels of factor VIII compared to von Willebrand. Remember, I told you in type 1, usually it's about 1.5 that of the antigen. And the clinical manifestations can mimic hemophilia with critical therapeutic implications. Next is type 2M, where it's caused by mutations in the, again, A1 domain, so like type 2B. However, here there is defected binding rather than a gain-of-function mutation. It causes decreased interaction with the platelet, and this is by far more common than a collagen binding defect. Now, 2M has the most challenging in terms of really allocating patients in this right group. So think about it in patients who don't fulfill criteria for type 1 or other entities of type 2. Now, finally, type 3 is homozygous or compound heterozygous of a null VWF allele. Usually, it's an autosomal recessive disease and causes severe deficiency or virtual loss of the protein. Severe bleeding, patients present with severe bleeding patterns that can mimic hemophilia, again with significantly reduced factor VIII. So that was the congenital von Willebrand. I thought about discussing acquired von Willebrand syndrome today because it's a really underestimated bleeding disorder. It was first recognized 50 years ago, and the laboratory findings are similar to what we see in the congenital forms. And we should suspect it in adults or pediatric patients with no personal or family history of bleeding. Now, what causes acquired von Willebrand syndrome are really many reasons that include antibody-mediated, as in monoclonal gammopathy, lymphomas, and autoimmune diseases. High shear stress, as in any valvular stenosis, obstructive cardiomyopathy, or extracorporeal devices like ECMO and left ventricular assist devices. It can also, von Willebrand can absorb onto cells or proteins like what we see in Wilms tumor, lymphomas, essential thrombocythemia, and multiple myeloma. Less commonly is that there is decreased production, as in hypothyroidism, which is a general state that causes reduced protein synthesis. So the most common form is really increased clearance of the protein. So in some patients with valvular defect, particularly aortic stenosis or severe mitral regurg, This high shear stress activates von Willebrand and causes its premature clearance from the circulation, so these patients acquire von Willebrand syndrome. Now, von Willebrand was linked to the suppression of angiogenesis via many mechanisms, including changes in the vascular endothelial growth factor. So these patients might develop submucosal angiodysplasia and lower GI bleeding. Now, this is what we know as Hyde syndrome, although causality hasn't been really confirmed, but many reports showed that the correction of these valvular defects results in dramatic improvement in their bleeding pattern. As for the laboratory testing, VWF panels should include at a minimum factor VIII activity, VWF antigen, and activity level. And what we do is that we derive the activity to antigen ratio. This could be 0.6 to 0.7. If you have a laboratory-derived reference in your lab, you should refer to that. However, most guidelines recommend 0.6 to 0.7. Recent guideline recommended that 0.5 is too low for that. And as for APTT is often normal unless factor VIII is reduced to below the level of the assay sensitivity, that's usually 30 units. Now, as for factor VIII activity, it's a one-stage APTT-based assay that is usually measured by a clot-based or an optical assay, depending on the analyzer you have in the lab. VWF antigen level is done by immunological assays that historically were ELISA, the famous 96-well plastic tubes. And then now it has been replaced, I would say, in the majority of places by the latex immunoassays, or what we call LEA testing. So briefly, latex beads coated with anti-VWF antibodies are added to patient plasma, and agglutination of the beads that is proportional to the level of the antigen is read by a spectrophotometer. It's widely available and readily automated. However, we should be careful with patients who have rheumatoid factor or heterophil antibodies. This can cause erroneous results and erroneously higher results of the antigen. Now, both ELISA and LEA have really good characteristic performance. Next, we do have the newer assays, or what we call chemiluminescence assays, CLIA. Briefly, magnetic particles that are coated with anti-VWF antibodies are added to the patient plasma, and binding causes light emission that is directly proportional to the concentration of the antigen. So far, it shows really the best low level of sensitivity. Now, this is critical when we deal with patients with a level below our detection, for example, below 10% of the von Willebrand. So to differentiate between severe type 1 and type 3 disease, this will have a really added role. And however, it's not really widely available. Finally, we want to test different aspects of VWF activity. So first, we measure the glycoprotein binding, which occurs by binding at the A1 domain. So we have different assays for that, starting with VWF ristocetin cofactor. So what is ristocetin? It is an antibiotic, originally an antibiotic that binds to the patient's VWF in plasma and causes unfolding to permit binding to glycoprotein 1b. And then we add control platelets and platelet aggregation that is proportional now to the function or activity of VWF are recorded. Now we have fully automated assays, and this is what we're currently doing at King Fahd Medical City. Now, newer assays, immunological assays that measure the protein, the function, are a VWF glycoprotein 1BR and 1BM. We call them platelet-free because we don't need control platelets. So glycoprotein 1BR assays that are based on the ristocetin-induced binding of VWF to a recombinant wild-type glycoprotein 1B fragments, and VWF glycoprotein 1BM assays that are based on the spontaneous binding of VWF to a gain-of-function mutant fragment. So in this case, we don't use ristocetin. This is important because some patients have polymorphism in the antigen that can affect the binding of ristocetin. Now, they generate comparable results to the VWF ristocetin cofactor assay. And the most recent consensus guidelines suggests newer assays over the ristocetin cofactor. Again, this is suggests, so it's a conditional recommendation. Moving on to the binding of von Willebrand to the collagen, what we call VWF collagen binding, is to assess adhesion to the subendothelium. It's usually done by ELISA testing, and we have newer CLIA testing coming. And finally, we measure VWF binding to factor 8 by ELISA testing. Now, the multimer analysis, another modality that we use, is really nice in separating subtypes of type 2 disease. So it's a qualitative visual assessment of the size or band pattern of VWF multimers, where separation is based on the size or molecular weight of the protein. However, it's really complex and time-consuming. So this is an example of a normal pool plasma where you see a spectrum of bands starting from high molecular weight to smaller forms. And as we move type 1, although they're not really indicated in type 1, but they will show like all forms of the band, but with a less intense pattern compared to the normal. Type 2 and B show loss of high molecular weight multimers, and type 3 shows like virtual loss of the protein. Now, it's really important to remember that type 2M does not show loss of high molecular weight multimers. To summarize what we just discussed, type 1 disease shows a normal activity to antigen ratio with normal pattern but reduced intensity of the multimers. Type 2A and 2B show low activity, glycoprotein 1B, and collagen binding to antigen ratio with loss of high molecular weight. Type 2M, the common form of the platelet binding defect, shows low glycoprotein 1B binding with no loss of the high molecular weight multimers. And this is the opposite in the less common form. Type 2 Normandy shows just a low factor 8 to VWF ratio with normal pattern, and the virtual loss in type 3 is noted. Now, just briefly, PFA, since we're still doing it at King Fahd Medical City, is really a good screening tool for primary hemostasis. It shows 90% sensitivity for von Willebrand disease and up to 100% in type 2, excluding 2N, and really good sensitivity for type 3. It shows lower sensitivity in type 1 and maybe normal when VWF is just mildly reduced. It shows limited specificity. However, a normal PFA can exclude a severe von Willebrand disease. Finally, genetic testing is not indicated in type 1 and 3 because it's a really, VWF gene is a really large one with many polymorphism noted, and is recommended for confirmation of type 2 subtype cases and the platelet type 1 Willebrand disease. With that, I conclude my talk. Thank you so much for your attention.
Thank you very much, Dr. Rahaf. I think if we have time at the end, we may take questions. Now, I'd like to recall Dr. Reem Al-Rabih to the podium. Dr. Reem was introduced this morning. I have the pleasure to reintroduce her as my colleague in King Fahd Specialist Hospital. Dr. Reem obtained her motherboard in APCP from the US and followed that by 2 subspecializations, one in hematopathology and the other in transfusion medicine. Today, she's going to present to us some of the challenging cases in coagulation.
Thank you, Dr. Afra, for the introduction. These are some cases that I encountered during my practice, and it's mostly about the approach rather than the diagnosis. Case 1, this is actually when I first arrived to Saudi Arabia. Remember Dr. Afra? You'll remember this case. A previously healthy 8-year-old girl presents with sudden, frequent nosebleeds. She was in Hafr al-Batin and they couldn't even control her nosebleeds. She had a lot of FFP transfused for her, but unfortunately she still continued to have these bleeds. Otherwise, no easy bruisability, bleeding from other sites, no bleeding after tooth extraction. Family history was negative for bleeding disorders, and medication history is negative. So when she arrived in our ER, after multiple transfusions, her hemoglobin was 10. Her platelet count was normal. She always had normal platelet counts. Her PT was high, 26.9, and they couldn't, as I said, correct it with FFP. High INR, as well as high PTT, 72. Thrombin time was low to normal. Fibrinogen level was normal. Mixing studies for PT, PTT showed continued prolongation immediately and after incubation. So just briefly, a mixing study, you mix 1 part of patient plasma with 1 part of normal plasma. This is usually standardized and given to you by the company, or you can actually pool it from your donors. And after a mixing, they measure the PT and PTT immediately and see if there's correction, and that usually points towards factor deficiency. If it does not correct immediately, this is an inhibitor pattern. And then after that, they incubate 1 or 2 hours according to your lab specification at 37 degrees, and then measure PTT. We don't usually do incubation for PT. Some labs do, because factor 7 inhibitor is very rare. So inhibitors in general, they show up in immediate. Factor 8 inhibitor can correct in immediate mixing and later prolong with incubation. So it has a slower kind of activity. So now to summarize our patient, she has prolonged PT, prolonged PTT with an inhibitor pattern. Could be a very strong lupus anticoagulant giving non-specific inhibitor pattern, so it's reacting against multiple factors. Could it be an inhibitor of a common pathway factor, factor 2, 5, and 10? And again, that's extremely rare, especially in pediatrics. Or could it be a strong inhibitor that crossed over and inhibited factors in the intrinsic and extrinsic pathway? This is the factor assays. At that point, we decided to do the common and intrinsic pathway. Factor 2 was repeated twice, very low. Factor 5, 7, and 10 within normal limits. Factor 8, 9, and 11. First, I was contacted by the lab and told they were extremely low, but on multiple dilutions, they started to increase. So they were displaying a non-specific inhibitor pattern. This is an example of inhibitor pattern. An inhibitor pattern is defined as more than 15 absolute increase in factor activity from the lowest dilution to the highest dilution. Higher dilutions should be ordered until the factor activity plateaus within 5 absolute, or until all dilutions defined in the analyzers have been performed. So you basically see in factor 8, 9, and 11, every time you dilute, there are big jumps in factor activity. So this should point you towards this non-specific inhibitor pattern. So how do you report the factor activity? You can either report it as percentage of factor activity of the highest dilution within the calibration curve, or you can use the plateau of 5 obsolete, and as long as it's within the calibration curve. So we did the lupus anticoagulant. We have the screening at the moment, DRVVT, which was positive, and the lupus anticoagulant, which is detected. A lot of recommendations do ask for confirmation by hexagonal phase. Not all hospitals do it. Another thing which is very hard to measure is prothrombin antibodies. Why am I thinking of prothrombin? Because lupus anticoagulant usually prolongs PTT and causes thrombosis. We have a bleeding patient with prolonged PTT in the presence of lupus anticoagulant, so that should lead us towards this diagnosis. Lupus anticoagulant hypoprothrombemia syndrome. As we summarize, we have a markedly low factor 2 level, a positive lupus anticoagulant. It was actually strongly positive. All other factors within normal. Non-specific inhibitor pattern was noted in the testing of 8, 9, and 11. Follow-up, she did have a family history of SLE. Her mother had multiple unexplained miscarriages. She had 6 miscarriages. So she has a history of probably some lupus anticoagulant or antiphospholipid. The patient is now at increased risk of thrombosis and bleeding. She was eventually diagnosed with SLE and after developing other SLE manifestations. So lupus anticoagulant is a misnomer because it actually causes thrombosis rather than anticoagulation. It is one of the anti-phospholipid antibodies. The main ones are anti-cardiolipin and anti-beta-2 glycoprotein, but you can see in the figure there's a lot of other weaker antibodies. It's heterogeneous autoantibodies, predominantly IgG, and with some IgM isotypes that specifically target the phospholipid protein component of the cell membrane. And patients who have lupus anticoagulant are at a risk of both arterial and venous thrombosis as well as pregnancy loss. Review of literature, these were reported only less than 100 cases, I remember, because we had a case during fellowship. The disease most commonly occurs in young adults, sometimes children, more in female, associated with autoimmune diseases. The bleeding is a frequent feature as well. Thrombosis is less common. Factor II is usually very low at diagnosis. Thrombotic risk will increase after treatment because you will be improving the factor II level. And approximately 50% present with bleeding, and it's also, as I said, associated with autoimmune diseases and can cause severe hemorrhagic complications. So do not rely on mixing studies alone, because inactivation of factor VIII by autoantibodies is time and temperature dependent. Also, this method may not detect inhibitor with complex or slow time-dependent kinetics, or very low titer inhibitors present in amounts below the sensitivity limit of the method. So you can miss an inhibitor because on immediate mixing it will correct. Take home points, as I said, do not use mixing studies as standalone method to rule in or out the presence of an inhibitor. It is important to identify the inhibitor pattern while performing factor assays to avoid reporting falsely low levels in the presence of inhibitors. We have had difficulty getting to reference ranges. When do you say this PT-PTT corrects versus not correct? We looked at multiple references. I couldn't find any. I've asked the company to provide us with their recommendation. I'm still waiting for that, but this is what we use during fellowship. Prolonged PT, we do only immediate mixing, and it should correct within 2 seconds of normal range. For prolonged PTT, we do immediate and 1 hour incubation, and PTT must correct to the normal range. So this is, if you have any other thoughts, I would be happy to share or to sit with you for your experience. Case 2, 35-year-old male with chest pain and hypotension. Workup revealed a massive myocardial infarction. He reported a similar episode 1 year ago. No evidence of atherosclerotic changes. No risk factor except for occasional smoking. Not diabetic, not hypertensive. Lipid profile is normal. Family history showed several family members with thrombosis in general at different sites. No significant bleeding or thrombosis history other than the things mentioned. Medication and drugs is negative. So usually in young age with this massive MI, you would think about drug abuse, especially cocaine, but no, there was no indication of that. His CBC, totally normal, normal platelet count. Coagulation, his PT and PTT INR were all elevated. His thrombin time was elevated. His fibrinogen was below detection limit and was repeated multiple times. D-dimer is low. So mixing studies for PT and PTT showed correction immediately and after incubation. He also had a prolonged reptilase time. Thrombophilia workup, normal protein C, S, and antithrombin levels. Lupus anticoagulant was not detected. Negative autoimmune screen. Repeat fibrinogen, as I said, always below detection limit. So the diagnosis is a congenital afibrinogenemia. It is 1 in a million diagnosis, very rare. You also have to rule out, when you're suspecting this kind of case, you'll have to rule out acquired deficiency or fibrinogen consumption, like DIC, bleeding, and hyperfibrinolysis. So rule out secondary causes of low fibrinogen, such as liver disease, chemotherapy, especially with L-asparginase, as well as other causes, especially hyperfibrinolysis. And I will mention now why hyperfibrinolysis is very important to detect, because we don't have the means to detect it in the laboratory. Liver cirrhosis, again, may have high levels of fibrinogen. However, it's kind of an acquired dysfibrinogenemia because of abnormal synthesis. So this fibrinogen does not function properly. So when do you check for fibrinogen as a cause of thrombophilia? It's actually level 2 testing. You have to, but for me, any cases of thrombosis or bleeding, add fibrinogen. It's an essential part of the coagulation cascade. So how do you work up a fibrinogen abnormality? You'll have prolongation of PT, PTT, and thrombin time, fibrinogen concentration, which is available in most labs, as well as prolonged ruptilase time. And this is an enzymatic it's based on enzymatic activity of the snake venom. And what it does, it cleaves fibrinogen A from fibrinogen and leads to the formation of a stable fibrin clot by bypassing thrombin. It is a qualitative assay. Normal ruptilase time can suggest the presence of heparin or direct thrombin inhibitor. So to rule out heparin contamination, ruptilase time is quite helpful. Klaus assay is most commonly used to measure fibrinogen function. We don't have it here in our institute. I'm not sure if they have it in Saudi. It requires mixing of dilute patient platelet-poor plasma with a high concentration of exogenous thrombin and measures the time to clot formation using photo-optical system. Using a standard curve, the time is converted to fibrinogen concentration and reported in grams per liter. But you have to be aware that factors that reduce fibrin formation, such as heparin and DTIs, or factors that decrease light transmission, like increased bilirubin, can lead to inaccurate results. This is a functional measurement of fibrinogen. Immunological assays can measure antigenic fibrinogen concentration. It's usually through ELISA method. The clinical utility is you have to use it in conjunction with the Klaus method, and it's to differentiate between quantitative and qualitative fibrinogen disorders. So these disorders are actually rare. Only 8% of all rare bleeding disorders. It's usually mutation in fibrinogen A or B gene that result in qualitative or quantitative defects. And these defects, as I said, can be diagnosed with the Klaus assay and antigenic fibrinogen level. The clinical presentation is heterogeneous. They can present bleeding, asymptomatic, or with thrombosis like our patient. They can have, as in lupus anticoagulant, both arterial and venous thrombosis. So this is how you diagnose. If you have prolonged PT, PTT, thrombin time, and ruptilase time, and they're infinitely prolonged, and fibrinogen is not detected, this is how you diagnose a fibrogenemia. If the PT, PTT, thrombin time, and ruptilase are variably prolonged, so they're not going together, and there's a proportional decrease in the function or immunoreactive fibrinogen, you can diagnose hypofibrogenemia. The last one is PT, PTT, thrombin time, and ruptilase time are variably or infinitely prolonged, and you have a normal antigen with lower functional level by Klaus method. This is a diagnostic of dysfibrogenemia. So our patient is the first category, which is quite rare. Take-home points. Fibrinogen is crucial for hemostasis. Check your fibrinogen during bleeding or thrombosis. Suspect hyperfibrinolysis, especially in patients with liver cirrhosis or trauma, and bleeding that's not responsive to supportive measures. Most laboratories do not offer thromboelastograms or ROTEM. This is a point-of-care test, usually used by anesthesiologists or maybe trauma surgeons. But if you have a patient like that, you might coordinate with the department that are responsible for the ROTEM to perform it. And you'll see an increase in maximum lysis, which is this part, of more than 15%. So always look for hyperfibrinolysis. This is our last case, and this I encountered during my fellowship. 7-month-old female presenting with an abdominal mass, hematuria, anemia. Diagnostic imaging revealed an extremely large and highly vascular tumor arising from the left kidney. Biopsy is consistent with Wilms tumor. No family history of bleeding disorders, no recent medication. Her PT is 18.3 prolonged, PTT is prolonged, and platelet is normal. Her factor 8 is 14, which is quite low, factor 9 within normal limits, as well as factor 5 and 10. Her von Willebrand antigen was 28%. However, the ristocetin or von Willebrand activity was decreased, so her ratio is 0.4. We use a cutoff of 0.6. Decreased very high and high molecular weight multimers consistent with type 2 von Willebrand. So this is probably an acquired von Willebrand disease. This is the course of her treatment. She received fresh frozen plasma, Humate P, which is a factor 8 and von Willebrand concentrate, as well as pure factor 8, IVIG, and she still had persistent hematuria and bleeding. but without adequate sustained and rise in factor levels. She was started on chemotherapy. Again, there is no improvement in the bleeding. Coagulopathy persisted. So prior to surgery, she underwent plasmapheresis. This is another way to try to treat or to control acquired von Willebrand, as well as other supportive measures. She only, the bleeding only resolved after ligation of the arteries during surgery. So the moment you took out the tumor, the acquired von Willebrand stopped. This is our diagnosis. As Dr. Rahaf nicely explained, there's no personal or family history of bleeding. And it has multiple mechanisms. In Wilms tumor, it's because of adsorption of von Willebrand on the tumor surface. When it is antibody mediated or related to inhibitors, it might be better controlled with plasmapheresis, but always try to treat the underlying cause. This is in general the diagnosis of von Willebrand, and this is a very old booklet provided by WHO, and it's free of charge. You can find it on the internet. So this is how you diagnose multiple subtypes of von Willebrand, and you have to remember that acquired von Willebrand, you might not have a decrease in activity or factor, just a decreased ratio. So, and then you confirm by multimers. Another issue about, and you can detect inhibitors in acquired von Willebrand. However, it's very labor intensive and not a lot of labs do it by doing mixing studies and then measuring residual ristocetin and collagen binding, or in ELISA. And again, it's not adequately standardized. So a lot of these cases, you just speculate that there's an antibody, but you cannot prove it. So for our practice, a lot of the multimer analysis is a send-out test. We send to the States for multimers. We received a lot of reports from them saying that in pediatric patients, that there is loss of very high molecular weight multimers. Do not jump to conclusions. This is seen in acquired von Willebrand. However, it is most commonly seen in specimen mishandling. So it's shipping time, heat, delayed separation of the plasma, or problems in freezing, all can cause loss of very high molecular weight multimers. So be cautious about diagnosing an acquired von Willebrand disease in pediatric patients with no obvious cause. These patients probably require repeat multimer analysis. The ratio is very helpful, as I said, in diagnosing type 2 and acquired von Willebrand. Use the cutoff of 0.6, that's the most recommended cutoff. Newer assays, like Dr. Rahaf explained earlier, the von Willebrand factor binding to glycoprotein 1b, R, and M are more sensitive and may replace the classic ristocetin binding in the diagnosis of von Willebrand type 2 in the future. Do we still have time? Or? Okay. So this is actually how to approach a prolonged PTT and a normal PT. First of all, exclude heparin contamination. You can do, if you find a prolonged thrombin time, normal reptilase time, that's probably heparin contamination. Some labs actually provide hepzyme, which is a form of heparinase that degrades the heparin in the sample and gives you the actual PTT. You can start by immediate mixing. If there is immediate correction, think about intrinsic factors, deficiencies, factor 8, 9, and 11. If there is no bleeding, usually it's probably factor 12. If it corrects immediately, prolongs after incubation, think about factor 8 inhibitor, and that you can confirm with the Bethesda assay. Mixing studies with no correction and even prolonged before and after incubation, think about lupus anticoagulant. There are rarely inhibitors to other factors 9, 11, and 12. And confirmation, screening for lupus is by DRVVT, and confirmation is by the hexagonal phase. If you have both are prolonged, please exclude clinical causes such as DIC, liver dysfunction, vitamin K deficiency or antagonist, or oral direct anticoagulants. If it immediately corrects, think about common pathway factor deficiencies such as 2, 5, and 10. Also think about rare combined factor deficiencies such as 5 and 7. Mixing studies, no correction, prolonged after incubation, suspect factor inhibitor, and if it corrects immediately and prolongs with incubation, you might think of a factor 5 inhibitor. Normal PTT and prolonged PT stop and exclude vitamin K antagonists and liver dysfunction. If there is immediate correction after mixing study, do a factor 7 assay, because this is probably 7 deficiency. If there's no correction and there's prolongation before and after, think about a factor 7 inhibitor. This is all I have, and if you have any questions, thank you.
Thank you, Dr. Reem, for very interesting cases. We have a couple of minutes if anyone have a question. Okay, so if there are no questions, thank you, and we'll move on to the next session.
Assalamu alaikum, مساء الخير جميعا. First of all, I would like to thank the organizing committee for giving me and my colleague this opportunity to chair the last session of the Heme Bath Day of the SSBMT activity. My name is Dr. Ahmed Al-Bahrani. I will chair this session with my colleague, Dr. Layla Al-Bashawri. This is the last session, as I mentioned. We have 4 speakers, and hopefully we will conclude on 4:30 because there are some want to catch their flight as well. Our first speaker is very well known in the field of transfusion medicine, Dr. Maha Badawi. Dr. Maha graduated from King Abdulaziz University. She got her MBBS from there. Then she completed her residency program in internal medicine, hematology, and she had fellowship in transfusion medicine from British Columbia in Canada, Vancouver. Currently, she is the director of the blood bank and the transfusion medicine service at King Abdulaziz Hospital, University Hospital, and also she is the program director of the hematology at the same hospital. She is associate professor in internal medicine, hematology, and transfusion medicine. Dr. Maha will tell us about the respiratory complication of transfusion. She had an update about the complication, and you have 25 minutes, Dr. Maha. Thank you very much.
Shukran, Dr. Ahmed. First of all, I would like to thank the organizing committee for inviting me to be speaking to you today. Thank you very much for staying to the last session. Hopefully we'll give you some interesting pieces of information. So let's start. First of all, I would like to mention that I am currently representing the Eastern Mediterranean region in the International Society of Blood Transfusion. I am working as the liaison between our region and the society. If you have any ideas or if you would like to know more about the opportunities that the society provides to individuals and other societies as well, I'm happy to talk to you about that. I'm also working with the Ministry of Health on some aspects related to the transfusion medicine or blood banking changes in the country. So what I'm going to cover today is I'm going to talk about TRALI and TACO, transfusion-related acute lung injury and transfusion-associated circulatory overload. We're going to cover the diagnostic criteria, pathophysiology, clinical features, and mitigation strategies. How can we prevent them? I will not talk extensively about a third respiratory transfusion reaction called transfusion-associated dyspnea. This is a diagnosis of exclusion if patients have respiratory transfusion complications that cannot be classified as TRALI or TACO, then it's appropriate to put them in the category of TAD. But I'm not going to talk about TAD that much. These 2 respiratory transfusion reactions are the leading causes of death related to transfusion around the world. All countries that have national hemovigilance system that were able to collect strong data about complications and mortalities
proved now and again that TACO and TRALI continue to be the leading causes of death in patients who die as a result of a transfusion. For example, these are data of the US FDA covering 2015 to 2019. If you look at the red circle, you can see that TACO and TRALI make up to more than 50% of cases of death related to transfusion, and they are leading among all other transfusion complications. However, during this talk, and whenever you hear about incidence and rates of transfusion reactions in general, please remember, in general, we know those rates are not very accurate. The reason is professionals do not always recognize transfusion reactions. They don't always pick up that this could be TRALI or TACO or even related to the transfusion. And sometimes they do recognize that this is likely related to the transfusion, but they do not report it to the blood bank or the transfusion service for a variety of reasons. For example, this is a study that proved this very clearly. This study was performed in the United States, covering 4 different hospitals. They collected transfusion episodes, 200 transfusion episodes every month for a period of 6 months from 4 different hospitals. In total, more than 4,000 transfusion episodes were reviewed. Files of those patients were reviewed in order to identify any potential transfusion reactions and whether those reactions were reported to the blood bank. Interestingly, 39 cases of TACO were identified by the expert review. Physicians looking after those patients actually picked up that those were TACO cases in about 60% of the cases, but only a minority, only 5% were reported to the blood bank. Similarly, in TRALI, 4 cases of possible TRALI were picked up by expert review. All of them were suspected by the doctors, but only 1 of them was reported to the blood bank. So it's very, very difficult if you're relying on a passive surveillance system. We're working the transfusion or the blood bank. We're waiting for people to tell us about the cases that they are seeing, the transfusion reactions they are seeing. We're not hearing about all of them. If you work in the clinical side as a physician or a nurse, please make sure that you report any complications related to transfusion to the blood bank. Even if you're not sure they are related, the blood bank will do the investigation and determine if this is, how likely this is related to the transfusion, and also determine the type. You're not expected to know the type of the reaction when you encounter it at the bedside. So having said that, those are the data that we have in the literature. So TRALI incidence is 0.04 to 0.1% of transfused patients might encounter TRALI, which is equal to about 1 TRALI for each 5,000 transfused blood components. However, the incidence is variable according to the population studied. So if you look at this table, it summarizes the incidence of TRALI in different hospitalized patients, so in general in a hospital or specifically in the ICU. And repeatedly, we can see that the rates among patients in the ICU are much higher than among other patients hospitalized for outside of the ICU. So keep that in mind. This is the old definition of TRALI. This is the definition that we were used to. It was described in 2004. It is well known as the Canadian Consensus Conference definition or the NHLBI definition. Basically, the definition consisted of a patient who develops acute lung injury, and the definition of acute lung injury is written on the right. So it has to be of hypoxemia, of acute onset, with abnormal chest X-ray, showing bilateral pulmonary edema. In addition to the acute lung injury, there had to be this temporal relationship to the transfusion within 6 hours. There had to be no volume overload, and there had to be no risk factors for acute lung injury. So no burn, no pneumonia, etc. So this was TRALI. In patients who had other risk factors for acute lung injury, for example, a patient with pneumonia or pancreatitis or burns, for example, those patients, if they developed acute lung injury in relation to the transfusion, those were classified as possible TRALI. Possible TRALI was a confusing term, and then another change came that warranted a change of definition of TRALI. In 2012, a group of ARDS experts, or critical care physicians, revised the definition of ARDS. In the new definition that was released in 2012, there was nothing called acute lung injury. It's all ARDS. Patients who had acute lung injury, who were classified as acute lung injury in the past, are now classified as mild ARDS. So the category of acute lung injury is no longer present, which led to the new definition of TRALI that was described in 2019 by a group of experts. It was performed by agreeing on consensus through Delphi technique. Basically, the name TRALI will not change, although acute lung injury is no longer existent. But in the description, you will no longer find the term acute lung injury except in the name itself. So now it's ARDS, and they changed the diagnostic criteria to allow for other imaging techniques other than X-ray. Now, ultrasound is a recognized imaging technique that can be used to prove pulmonary edema, and also CT scan. So X-ray is the simplest and easiest, obviously, but if you have a CT or an ultrasound, that would be enough. The temporal relationship to the transfusion of 6 hours is still there, no volume overload, and if present, the decision must be made on the clinical side that the volume overload was not the main reason for patient deterioration. And no risk factors for ARDS. Those patients are now classified as TRALI type 1. Patients who have ARDS risk factors are classified as TRALI type 2. But they clearly describe that patients who have ARDS risk factors, the respiratory status must have been stable or improving before the transfusion. If a patient was found to be already deteriorating from their ARDS risk factor before the transfusion, then those are not classified as TRALI and are classified as ARDS. So just summarizing the change, there is no longer anything called possible TRALI. It's now TRALI type 1 and type 2. Both are reportable to the blood bank. Imaging can include CT and ultrasound as well. And the term acute lung injury is no longer used except in the name of the condition. Reminding everybody that TRALI is a clinical diagnosis. We don't do a test in order to prove it. Patients may present with dyspnea, tachypnea, hypoxemia, rigors, fever, and sometimes hypothermia, tachycardia, blood pressure changes, and interestingly, transient leukopenia and transient thrombocytopenia. We always need to remind clinicians, if you work at the bedside, please make sure if your patient develops respiratory deterioration during or after the transfusion, please make sure that the file of the patient or your notes include assessment of patient volume status, chest imaging. The chest imaging does not need to be completed within 6 hours. It can be completed within 24 hours. But the onset of symptoms must be present within 6 hours. And there has to be evidence of hypoxemia. Otherwise, with no hypoxemia, this is not TRALI. As I mentioned, there are no tests to confirm whether this is TRALI or not. It's basically purely based on the clinical presentation. However, we could use the presence of HLA and HNA antibodies, human leukocyte antigen antibodies, and human neutrophil antibodies, testing of the donor in order to determine future eligibility to donate. But the results of the antibody testing do not necessarily affect the diagnosis because antibodies are present only in 50 to 80% of donors implicated in TRALI cases. Prognosis of TRALI ranges from mild to severe. Sometimes some of these patients only require supplemental oxygen for a few hours or a couple of days and then they improve. However, 5 to 10% of patients eventually die. But if you compare the risk of death secondary to TRALI in comparison with other causes of ARDS, which is 30 to 40%. Trali is definitely, the mortality rate is much lower than that. However, just reminding everybody, transfusion is expected to be very, very safe at this point in time. So even this low mortality rate is considered high in terms of transfusion-related mortality. The pathophysiology has always been described as the two-hit theory, where the first hit is a recipient, a patient who is primed and ready for the activation of their leukocytes. So the recipient is primed, susceptible because of an underlying condition, receiving a blood product that contains antibodies or contains bioactive lipids or other elements. So on the left side, you can see a list of conditions that are considered first hit. All of them share the fact that interleukin-8 is high in these conditions, including sepsis, pneumonia, cardiopulmonary bypass, burns, pancreatitis, etc. And then when a blood transfusion is given containing those antibodies, primed white cells are activated and then pulmonary edema occurs. However, the two-hit theory could not explain why Trali sometimes happened in otherwise healthy individuals, patients receiving a transfusion in daycare, for example. And that's why the threshold model came out. Basically, the threshold model tells us that some patients, healthy patients who are not previously primed, do not have a first hit, might have Trali if the level of the antibodies administered, infused, was very, very high. The titer was high enough to cause them symptoms even if they were not susceptible in the beginning. In patients who are primed and who have the first hit, a lower level of antibodies might be enough to cause Trali in these patients. Role of platelets is very interesting. As you noticed, I mentioned that some patients have transient thrombocytopenia at the time of the reaction. And this led to an investigation of the role of platelets in Trali. And it was found that platelet sequestration in the lungs was observed in animal models. And this phenomena was dependent on the presence of neutrophils. And platelets and neutrophils aggregated in blood vessels and around alveoli. In animal models as well, platelet depletion protected animals from lung injury. And aspirin use was helpful in improving survival. This was not reciprocated in humans. There was one study, a case control study of 109 Trali cases, which is a lot. Aspirin was not protective. Another interesting phenomena that is seen in Trali is netosis. Netosis is a method of cell death, similar to necrosis and apoptosis, where a white cell tries to perform its antimicrobial activities by releasing DNA as a form of a net. And as you can see in the illustration, it captures bacteria this way. So nets were found in patients with Trali. They increase endothelial permeability, and it's an event that is very fast after antibody challenge. In animal models, aspirin not only affected platelet function and role in Trali, but also blocked net formation. And interventions targeting nets, so affecting the DNA itself, reduced complications of Trali and improved survival in animal models. We still don't know whether this would be helpful in humans. Risk mitigation is the biggest thing in Trali, and given the understanding of the pathophysiology and the role of HLA and HA antibodies, helped blood bankers tremendously in improving the management of blood donors. First of all, we should all agree that the proper use of blood components is the first line of prevention of transfusion reactions. And as we always like to say, the best transfusion is the appropriate transfusion. And then we come to the elimination of high-risk donors. So donors who were implicated in cases of Trali, donors who are known to have HLA or HNA antibodies, and donors who are at risk of having HLA and HNA antibodies based on the risk of pregnancy. All of these are managed differently. And why is that? That's because the prevalence of HLA antibodies was studied in the general population. So if we took men and women with no previous history of pregnancy, the risk of having HLA antibodies in these individuals is less than 2%. Transfused men versus non-transfused men are not very different. So the transfusion per se is not a significant risk factor of developing HLA antibodies. However, pregnancy was found to be a significant risk factor for having HLA antibodies, and the percentage depended on the number of pregnancies. So women who were never pregnant before, as I mentioned, the percentage of those with HLA antibodies is less than 2%. The more pregnancies, the higher the percentage of women with HLA antibodies. Even from one pregnancy, it's more than 10%. And that's why women with a previous history of pregnancy are no longer accepted as donors of plasma or platelets, apheresis platelets. The ABB standards clearly mention that plasma and whole blood for allogeneic transfusion shall be from males, females who have not been pregnant, or if a female was pregnant, she should be tested after their most recent pregnancy and shown to be negative for HLA antibodies. So deferral of donors implicated in TRALI increased the safety of red cells, platelets, and plasma. Limiting donation of plasma and apheresis platelets to donors, to male donors and women who are not at risk of developing HLA antibodies increased the safety of platelet and plasma transfusions. Also, suspending whole blood-derived platelets in male plasma or platelet additive solution further increased the safety of platelets. And finally, the use of solvent detergent plasma from plasma fractionators, diluting any antibodies that could be in plasma, was very helpful in reducing the risk of TRALI from plasma even further. So if this is a beautiful graph, I really like it. It shows how the incidence of TRALI secondary to plasma dropped significantly after the implementation of risk mitigation strategies. So it was between 3.2 to 3.6 per 100,000. This is according to one center, the New York Blood Center, and significantly dropped to 0.4 per 100,000 after use of male or females who were never pregnant. The risk of TRALI from red cells and platelets is still there, and further action is being performed, including use of filters that might block the passage of antibodies. But this is still out there. So moving gears, changing gears to TACO. And TACO stands for transfusion-associated circulatory overload, a transfusion reaction that personally I have seen during my internship and residency. I never paid attention. This was, to me, at that point in time, simply volume overload, like any other volume overload. Nobody needed to know about it. The patient improved with diuretics, and things stopped there. We now understand it is way more serious than this. So this is there are multiple definitions for TACO. I'm just showing one of the important ones developed by the ISBT in collaboration with the International Hemovigilance Network. And this definition contains 5 criteria. The first 2 are, The first, we need one of the first 2, and they should occur within 12 hours of transfusion. So there has to be an element of respiratory compromise by symptoms, for example, and evidence of worsening pulmonary edema based on physical examination and or chest imaging. In addition, we need a total of 3 criteria, so one of the first 2 or both of them in addition to something from this list of 3. So cardiovascular system changes, including vital sign abnormalities, hypertension, tachycardia, jugular venous distension, enlarged cardiac silhouette, or peripheral edema. Evidence of fluid overload, for example, positive fluid balance, or the patient improved after diuresis.
5 minutes, please.
Okay. And results of relevant biomarkers. Biomarkers used in TACO assessment basically are BNP, a beta-natriuretic peptide, and N-terminal pro-BNP. They are not very helpful in critically ill patients because they are high at baseline. In non-critically ill patients, if the levels are low, it can be used to exclude TACO. The incidence is considered around 1 in 9,000 transfusions, 1% of low-risk patients, and 12% of high-risk patients are at risk of developing TACO. There is another two-hit model with a threshold model as well for TACO, where a patient is predisposed to TACO because of cardiac condition or liver or renal disease, or positive fluid status, and then receiving a high volume of blood resulting in TACO. Also, a previously healthy patient could also develop TACO if they received lots of blood products at a very high rate. So, a summary of the clinical evaluation in these patients: if we encountered a patient with respiratory compromise thought to be transfusion related, we need to exclude anaphylaxis and allergy. If the patient had pulmonary edema on chest X-ray or examination, then this could be TACO or TRALI. We would evaluate their physical status, cardiovascular examination, evidence of volume overload, and assess their fluid status. If these were abnormal, then this is likely to be TACO. If those were not there, then this could be TRALI. And if it's not TRALI, then it is transfusion-associated dyspnea. This is the TACO checklist. This is promoted by the SHOT, the Serious Hazards of Transfusion, which is the hemovigilance body in the UK. They recommend the use of this checklist before every single transfusion in order to assess if the patient is at risk of developing TACO because of their cardiac or renal condition. And in these cases, the physician is asked to reconsider whether the transfusion needs to be given or should be given slowly or at smaller volumes. So just to summarize, hypoxemia is necessary for the definition of TRALI type 1 and type 2. It's not necessary for the definition of TACO. Pulmonary edema on imaging is necessary for the diagnosis of TRALI, but not necessarily for TACO. The onset within 6 hours is within the definition of TRALI. Some definitions of TACO say 6 hours, some say 12. Risk factors of ARDS are necessary to say this is TRALI type 2. And of course, volume overload or left atrial hypertension is necessary to make the diagnosis of TACO. So to conclude, updated definitions of TRALI and TACO are available. We need to use them. Respiratory transfusion reactions continue to be the leading causes of transfusion-related death. If you're using BNP or NT-BNP, those are not very helpful for diagnosis of TACO in the ICU, but can be helpful to exclude TACO if the levels are low in patients out of the ICU. And better understanding of pathophysiology of these complications led to effective mitigation strategies for TRALI, not very much for TACO, but hopefully in the future. That's it, and this is my email. Thank you.
Thank you, Dr. Baha, for this excellent review. I'd like to welcome our next speaker, Dr. Ammar Al-Sghayr. He's an accomplished individual with a very impressive educational background and extensive experience in the field of transfusion medicine and hematology. He is chairman of the Transfusion Medicine Service Department at the Pathology and Clinical Laboratory Medicine, King Fahd Medical City, as well as a consultant in transfusion medicine and hematopathology also. And he's also a medical consultant for the Stem Cell Processing Laboratory. His educational background includes neoplastic hematopathology from the University of Ottawa, Canada, and he's also a hemopheresis practitioner from the American Society of Pathologists and Transfusion Medicine. He also holds a Jordanian Board of Hematology and Certification, and he is a certified assessor for the Saudi Commission for Health Specialties and an inspector for the College of American Pathologists. He's known for his expertise and he's highly respected by his colleagues and peers. And he's going to tell us about a very important topic, platelet refractoriness. Welcome, Dr. Ammar.
Thank you, Chairman, for this nice introduction, and thanks to the organizing committee for inviting me to this high-quality HemPath review day. Thank you very much. Can I have my slides? Back, first slide, please. Okay.
In my presentation today, I would like to talk about very important complication or medical problem that we all encounter between our hematology and other clinical colleagues and the transfusion services and also other laboratory services like HLA lab and immunology labs. In my presentation, I will talk about these things, like the etiology of platelet refractoriness, then the different types and the how we diagnose it, and we discuss the different management approaches. The transfusion of platelets is very important to all medical disciplines, from hematology to cardiac to ICU. Our hematology colleagues, they consume, or their patients consume most of our patients, and with the advent of the management of diseases, the life and the treatment modalities extend the lives of the patients and also the treatment. And with this, they extend the pancytopenia, the level of pancytopenia duration. So they needed our transfusion support for platelets, backed RBC, and others. Not only the hematology, all other disciplines, they rely on their patient management on the services of the transfusion medicine, and one of them is the platelets. And only hematology colleagues, they consume or the hematology patients, more than 30% of the platelet support we have. And this is a common consultations or from our hematology colleagues when they encounter a patient who is not responding to platelet transfusion. And they read about many things, and they wanted, of course, they wanted the best to have for their patients. For example, any patient 70 years old who is having continuous platelet support and he is not responding to the platelet support for many reasons, which we'll discuss, and they always ask, can we have a cross-matched platelets? Can we have HLA-matched platelets for this patient since he is not responding after repeated transfusions? For us, this is a clinical problem, and we are a transfusion medicine. We are a clinical discipline too, and we have to know a lot about the patient and to diagnose him is why he is not responding to platelets. And we keep asking our colleagues these questions, and we have to know what is the background, underlying problems, conditions, medications. And for this, we have to agree about certain definitions of the platelet refractoriness. So it is a failure to obtain a satisfactory response to transfusion of platelets, usually randomly selected the platelets, not specified. And this failure to respond can be due to many causes, immunological and non-immunological. The non-immunological causes account for 2/3 of the causes, and the immune causes, which are few but problematic, account for 1/3. But sometimes we have combination of both. So how common is the platelet refractoriness? We have to differentiate between two eras. We have to differentiate between before the introduction of the universal leukoreduction and after. And also it is multifactorial, depends on many conditions. But before the universal leukoreduction was introduced in many countries, Saudi Arabia is one of them, it ranges up to from 20 to 70% of multi-transfused patients. And one other study found it is like 27% of the cases had at least one episode of refractoriness. But after the implementation of universal leukoreduction, the percentage has dropped a lot it went down from 15 to 25%. The non-immune causes are variable. As I said, it is account for 2/3 of the causes, and it could be due to, it is mostly patient conditions, sepsis, febrile neutropenias, splenomegaly, very important, consumption or DIC, liver issues, or VOD or hepatic veno-occlusive disease, GVHD, and others. The immune causes, which is due to the development of HLA class 1 antibodies or or antibodies to human platelet antigens. Also can be due to prior or previous exposure, previous pregnancies, or transfusion of non-leukoreduced platelets or products. So the non-immune causes, as I said, they are the clinical conditions of the patient. For example, hematopoietic stem cell transplant, both allo and auto. And in one study, almost 300 cases out of 500, they experience one or have inadequate response to platelet. VOD in cases, almost 22%, they have poor response to platelet transfusion or refractoriness. GVHD also is another risk factor for refractoriness due to, with many pathophysiological mechanisms. For example, it is the microangiopathy associated with GVHD, also acute GVHD, bone marrow suppression as well. The splenomegaly, the spleen, to remind you, it stores 1/3 of the platelet storage in any normal human beings. And this graph, red, green, and yellow, demonstrates the survival of radiolabeled platelets after being injected into 3 groups of patients. Red is a splenectomized subject, and you see the survival is very high, and because it is not stored in the spleen. In the normal green, see it is less than the red one, but very good survival of platelet after injection. Those who have refractory, they have lower platelet survival, or splenomegaly. Those who have splenomegaly, all the platelets, the platelets goes and get stored in or sequestered in the spleen. And this is how the splenomegaly plays a very big role on or affects the survival of the platelets. So those who has big spleen, for example, and platelet after transfusion, they were not incremented, but it is not after doing the CC, the corrective count increment or others, it is found that they are not refractory. The survival of platelet was better than the right side, who has a normal spleen, but after doing the CCI, it was found that it is primary refractory or genuinely refractory. Another medications, there are hundreds of medications attributed to cause thrombocytopenia. The most famous in the clinical ground is the amphotericin B, which is antifungal, which also associated with the reduced corrective count increment. Other drugs considered immune too. Sepsis or infections, consumption coagulopathy also will consume the platelets, and those will have secondary refractoriness. It's found that those who have red cell antibody development or are prone to develop antibodies to red cell antigens, they also tend to produce antibodies against HLA antibodies in many studies, for example. And this is a reflection of the degree of immunocompetency and immunoreactivity of those patients, so they will be prone to develop or HLA immunization. The immunization to HLA, this is a major risk factor. This is now talking about the immune causes of, or the genuine refractory or primary refractory platelet. As you know, that the platelets, they express HLA class 1 antigens, and they don't express class 2, and they also express platelet-specific antigens. They express ABO also, blood groups. The human platelet antigen system is the illuminization results from production of antibodies to class 1. Antibodies to platelet specific has been described as a cause of refractoriness in some of these patients. There are 24 platelet specific alloantigens present on the platelets, and these antigens appear to be less immunogenic than the HLA. This is one way to measure or to document the refractoriness to platelet transfusion, the corrective count increment. We measure the 1 hour corrected platelet count. If the platelet count is less than 5 to the power of 9 on 2 occasions, using ABO identical fresh platelets. We calculated by measuring post minus the pre-platelet count times the surface area over the platelet transfused in millions or billions. There is also the general rule of thumb that transfusion of 6 units of pooled platelets or 1 apheresis increase the platelet count by 30,000. This is normal in normal settings. This describes the differences between normal and non-immune and immune causes of platelet refractoriness. In the black curve, the normal subjects, when the platelets are transfused, they stay for some time and gradually drop over time. In the green, this non-immune, they have very good response, high response, and they drop immediately. The alloimmune, they have very slow response, and they drop further. So the quicker response in normal, followed by non-immune. So the treatment for those subjects vary whether non-immune or immune. The non-alloimmune causes, mainly the treatment is to treat the underlying conditions, treat sepsis, treat liver disease, treat DIC. For the alloimmune or genuine refractoriness, there are many options we offer. Either we provide cross-matched random platelets, or HLA-matched platelets, or HLA or antigen-negative, HLA antigen-negative platelets from beginning. And there is a software, they call it HLA Matchmaker. It is available in many centers, or not I know of. So this is the HLA matched platelets. You know, there is the value or the importance of HLA was first discovered in the early 1970s. And it was demonstrated that given HLA matched platelets from family members usually give very good response. The HLA class 1 is the most immune cause of platelet refractoriness, and it's estimated to be the cause of almost 30 to 40% of the immune-related refractoriness. The antibody against HLA antigens occurs in 7 to 55% of patients after platelet transfusion, depending on the study. These antibodies usually detected within the first 2 weeks after exposure. This was first described in the landmark trial, the TRAB study in the 1997. And it was found that 17 to 20% of recipients of leukoreduced or UV irradiated, the immunization was there, and in 45% of those who have non-leukoreduced platelets. This is the curve of, this is the first trial, the TRAP, and it was very, after that, the practice had changed. So HLA matched donors can be found either among family members or if we have an HLA, if we have a registry of HLA typed unrelated individuals. And this is a very complicated matter, and we are hoping that we will have a national registries and under national umbrella. The degree of match can predict the success of post-transfusion platelet count increments, and this is, they classify it into grades. For grade A, these are the grades. Grade A, where they will have 4 antigen match. Grade B, 2 to 3 antigen match, and so on and so forth. So those who have grade A and BU, HLA matched platelets are associated with the best of corresponds. If you have grade A, means you have 4 HLA match antigens. The selection of also donors with antigens in the same cross-reactive groups, CREGS, this is antibody to an HLA system that also reacts with other similar HLA groups. So the HLA matched platelets, these are the matching degree. A is a perfect match, B cross-reactive, and For example, if we have the patient who has A1 and 2 and B and 7, so of course if the best match where it is the same, A1, 2, B7. Cross-reactive X, the B1X where there is only one mismatch. In C, there is one mismatch antigen, which is 44, for example. It's not to complicate things. So this is approach where sometimes we, or it is given, if you know the HLA of the donor, of the patient himself, and you cannot provide, do extensive HLA matching. So what you can do, since you have the HLA in the system of the, since he's maybe prepared for transplant, sometimes you give selected antigen negative, HLA antigen negative platelets for this patient. Similar sometimes when we have in transfusion service where we provide antigen negative Baghdad BC and cross-match the patient, and we don't go further to do all the full phenotyping. This is the cross-match compatible platelets. This is a request we receive, but this is not under our services. It's under the immunology labs. So sometimes what you do is you cross-match the platelets from the blood banks with the patient serum. Then using this solid phase technique, combination of HLA and ELISA, so to see the reactivity between the platelets. It's very similar to, it's a cross-match antigen antibody. This is how it works. We have an indicator in red and the platelet antibody in blue, and this donor platelets are attached with the platelet-specific monoclonal antibody. Then the cross-match occurs at a solid phase red cell adherence. This has some advantages if it is available. It is rapid. It can be done within 2 hours. You can utilize large pool of compatible platelets from your inventory. It is an alternative for patients with rare HLA, and it's not affected by the HLA match grade, and it doesn't go into that cost. It's somehow cost effective. ABO matched platelets is, some authors recommend that the initial approach you should start with giving ABO matched platelets, because the platelets, they have some expression of ABO antigens, and non-HLA compatible platelets. Some authors, they thought it is not effective in true alloimmune, where it is due to anti-HLA. However, when available, sometimes extending the match for both HLA and ABO may provide some additional benefit in some patients over HLA matching alone. So this was shown in a study of 50 pediatric patients who have beta thalassemia major, and they have refractoriness following stem cell transplant. And they found that matched at HLA and ABO, 76% successful platelet transfusion. If it is matched only at HLA and ABO, it is not, or ABO incompatible or mismatched, or one of them is mismatched, it is 67, which is not bad, really, compared to 76 to 67. So it is good after all. So this study in the utilization of cross-matched or HLA-matched platelets for patients refractory to platelet transfusion, big study. 32 patients were tested for HLA antibodies or platelet-specific antibodies, and also for cross-matching compatibility. 9 had platelet-specific antibodies. Total of 350 transfusions, for which pre-transfusion and post-transfusion at 1 hour to 4 hour platelet count was available. And they found that at 45%, the median CCI was 0, 42% median CCI is 1.7. And they found that the cross-match platelets were 2 to 3 times more likely to give successful transfusion at 1 to 4 hours and 4 24-hour post-transfusion. HLA matched platelets 2.5 to 6, so much better than it's somehow better than the cross-match platelets.
5 minutes, Dr. Ammar. 5 minutes.
5 minutes. This I will finish soon. So this is the very good approach to manage those refractory to platelet transfusion. So if you, at any time, you suspect alloimmune refractoriness, and you give ABO identical fresh platelets, you measure you document this 2 times. If it is adequate, if it shows adequate increment, so it is not diagnosed as refractory. So if it shows poor increment, then you search for cross-match units, and if you can, and you start with the cross-match compatible units. If you find preferably ABO, if it is adequate increment, you continue with the cross-match increment. If there is inadequate, then you start to search for HLA and hemoplatelet-specific antibodies. If you find negative, you consider this is a non-immune, and you have to look for other secondary causes like fever, splenomegaly. If the antibody was positive, then you have to support, if available, with HLA and HBA antigen negative platelets. Of course, all preferably ABO identical to eliminate other confounding factors. Also you support with HLA, less, this is full HLA if you can. If you cannot, then you go to less mismatch, BU or BX, where 1 antigen mismatch or 2. And all preferably, if you can, ABO identical. So of course we have to treat some other treatment modalities are also available, and our clinical colleagues they know better on these. Recall donor, you have to seek out better HLA matches. Maybe you have donors in your registry. Try national search if it's available. IVIG, immunomodulatory mechanisms, continuous platelet drip or infusion, which will consume a lot of platelets from our blood bank, but sometimes we will support. Some people use Novo-7, especially with the bleedings, if the platelet doesn't work. With this, thank you very much.
Thank you very much, Dr. Ammar. Very comprehensive presentation and practical about the platelet refractoriness. The discussion will be at the end of the session. Our third speaker is Dr. Mukhtar Bouhlega. Dr. Mukhtar, he completed his residency program from Berlin in Germany in transfusion medicine. And currently he is a senior registrar working in the maternity and children hospital in Dammam, Saudi Arabia. And the topic is update on neonatal and pediatric transfusion. You are welcome, Dr. Mukhtar. You have 25 minutes.
Thank you, Dr. Ahmed, for the introduction. Thank you, dear organizers, for inviting me to the very insightful conference today. I would like to extend my thanks and greetings to the moderators, the speakers, and the audience as well. Thank you very much. So I would like to start with some related definitions related to this very important topic related to the pediatrics population, which is neonatal blood exchange transfusion. So in this presentation, I'll talk about the definitions, indications, how to do the procedure, and I will end up later on with some of the complications related. So the neonates or newborns, according to the WHO, a neonate is defined as a baby who's 4 weeks old or younger. As you can see, the definition depends on the time after delivery. It doesn't mention anything more about the baby's state of illness, nor the disability, nor how long the baby was intrauterine, whether it was term, preterm, or post-term as well. This period of time is when the changes are very rapid. Many critical events happen in this period of time. For example, feeding patterns are established, bonding with the parents take place in this period of time, and the risk of infections that may become are more serious and higher in this period of time. Many birth congenital defects as well are first noted in this period of time. The preterm is defined as babies who are born alive before 37 weeks of gestation are completed. There are subcategories as well according to the WHO. Preterm birth is either subcategorized as extremely preterm, which are less than 28 weeks old, very preterm 28 to 32 weeks, and moderate 32 to 37 weeks old. In terms of the birth weight, so the normal birth weight is 2.5 to 4.5 kilograms. Low birth weight is defined as lower than 2.5 kilogram, and very low birth weight less than 1.5 kilogram. For the second part, which is exchange transfusion, it's defined as removing allicouts of patient's blood and replacing it with donor's blood repeatedly until blood volume is almost entirely replaced or exchanged. It's performed in order to remove abnormal blood components and circulating toxins while maintaining the adequate circulating blood volume. So it's vital to mention that the incidence of exchange transfusion is decreasing nowadays as a secondary to the prevention and improved prenatal management as well. The hyperbilirubinemia yet is very important, and exchange transfusion nowadays is the only modality of treatment after phototherapy fails. That's why it's important to learn and provide it as a blood bank service. Now, types of neonatal exchange depends on the blood volumes. These volumes are calculated using an estimate of neonate circulating blood volume, in which the term infants are 80 ml per kilogram and preterm infants have 100 ml per kilogram. The first type is partial exchange transfusion, on which it's used for polycythemia, for example, using normal saline, where desired hematocrit post-exchange is 50%. The second part, or the second type, is single volume exchange transfusion, which replaces around 60% of blood volume, and it's used for non-hemolytic diseases. The third is the double volume exchange transfusion, which is most commonly used for removal of bilirubin, and it replaces around 85% of the blood volume. As you can see, even the double volume exchange, it doesn't exchange 100% of the blood volume due to mix-up and contamination during the procedure between the donor's blood and the patient's blood. Now, the indications, just like I said before, the most common is for exchange transfusion is hyperbilirubinemia, which is caused by hemolytic diseases of the fetus and newborn. The physiology, in simple words, is you're having a high bilirubin crossing the blood-brain barrier, which concentrates in the basal ganglia and cerebellum, and would cause an irreversible damage known as connectors. Now, infants are susceptible to hyperbilirubinemia because of their immature liver conjugates the bilirubin poorly, and because their incompletely developed blood-brain barrier, it would allow bilirubin to transit. The phototherapy would convert the unconjugated bilirubin into water-soluble isomer, aiding into excretion, and just like I said before, this is the treatment of choice. Exchange transfusion is usually done for those patients who failed the phototherapy, and it needs to be performed before the development of connectors. In full-term infants, connectors rarely happens with bilirubin levels less than 25 milligram per deciliter. However, in sick, very low birth weight infants, connectors can occur at bilirubin of as low as 8 to 12 milligrams per deciliter. Usually a double volume exchange removes, just like I said before, 85% of the circulating cells, and approximately 50% of total bilirubin. Just keep in mind that after the first exchange transfusion, bilirubin may re-equilibrate between the extravascular tissue and the plasma, which may necessitate another exchange afterwards. Now, other than hyperbilirubinemia, there are many indications, like polycythemia, congenital leukemias, thrombocytosis, but a person might wonder, like these indications, were they only enlisted in textbooks or were really reported? And the answer is yes, actually. In the 70s, there's digoxin, for example, a report of digoxin elimination after intoxication that was treated by the exchange transfusion. You have a report of paracetamol poisoning was ingested by a mother 16 hours pre-delivery that was treated by ET, and vancomycin as well, overdose by by a patient that was treated as well with the exchange transfusion. This is a report of lead poisoning by a neonate that resulted from the mother having long history of pica and eating glazed pottery, which showed rapid decrease in the neonate's lead levels after exchange transfusion as well. This one is a report about an exchange done post-transfusion, acquired malarial infection in a newborn, which was followed by introduction of quinine. Now, liver diseases, there's a case that was reported in 2013 about hemochromatosis by a neonate that was successfully managed by ET, and alloimmune liver disease that showed great results as well post-ET. Hypertriglyceridemia as well. But a person might ask, is it always green on this side of the field? For example, neonatal sepsis. Here's an RCT about the use of double volume exchange. In severe sepsis that showed a result of 21% reduction in mortality, which might sound interesting actually, but this one is a meta-analysis published in 2020 about the mortality in neonatal sepsis, with a conclusion that says literally the use of exchange transfusion in neonatal sepsis is not directly recommended due to low certainty of evidence, inadequate power, and moderate high risk of bias and heterogeneity. Now, that we know about the indications, the next logical question would be, how do I do neonatal exchange? To answer this question, actually two parts. You have a blood bank part and a neonatology part. Both are technical, but before getting into the details, just keep in mind a few points. First is that the final decision of ET is taken by a consultant neonatologist who's in service to decide on the ET based on the trend of serum, bilirubin levels, the response to the treatment, and if there was any history of intrauterine transfusion, for example, by a referring hospital. Now, other than the blood volume, the hematocrit, which are very important as well, the history of the neonate, special requests as well, and the urgency of the exchange transfusion is very critical as well. Now, the component choice, which is very important for the blood bankers, typically it's RBCs resuspended in ABO compatible thawed fresh frozen plasma. Mostly it's O negative RBCs in AB plasma, but keep in mind that the maternal antibodies, if they are present, should be taken into consideration, because you don't want to use an O negative RBC for a patient who's having anti-small c or anti-small e. The final product should have a known hematocrit of 50 to 60%, leukodepleted as fresh as possible, which is less than 5 to 10 days. Some references say 14 days, less than 14 days. irradiated and used within 24 hours of irradiation. Now, in terms of irradiation, I want to expand a little bit more. Looking and now, the irradiation for exchange transfusion is still debatable, actually. There are many international standards that recommend to start with irradiation. For example, locally or AABB on to irradiate for intrauterine transfusion, yes, but to irradiate for exchange transfusion only after IUT. In Europe, there's a division, and the practice is kind of institutional as well, as there are many international countries as well, and some institutions divide the patient according to their weight. Like, for example, the very low birth weight that they recommend to irradiate for exchange transfusion, primarily some of them don't. Now, how do I reconstitute? This is mainly for the fellow lab scientists in the blood bank. It is kind of straightforward procedure and very easy once you have the basic elements. All you need is a weighing scale, and I'm sure that all of blood banks have a weighing scale. And you only need your high school base math, nothing else. So what you really do is you receive a blood bag, and usually the volume is indicated on this blood bag. Yeah? But what you end up with is, during the process, you would centrifuge it and take the additive solution and rest of plasma out. This means that you will end up with another volume. And the only way to know the volume inside this bag is by weighing the bag on the scale. That's why you need to convert the weight into volume by dividing by 1.06, which is the specific gravity of blood. And then you would subtract the weight of the empty bag, yeah? And using this formula, which is plasma to add formula, you will calculate how much plasma in volume, in ml, you want to add to the mother bag, You want to add to the mother bag. And then, when you calculate the volume, you would add them together, multiply by the specific gravity again, and you would add the weight of the empty plastic bag. The sum of all weights is the number you want to see on your scale while doing the process. It's the sum at the end of it. So please, I urge my lab colleagues, don't go with the back of envelope calculation on which you say, well, plasma is 55% of the blood, I want to give third of this, 23rd of that, bag it, tag it, and transfuse it. No, please. This is the formula, it's easy, straightforward, and I would like them to use it for better accuracy. Now, from the neonatology side, it's kind of straightforward as well. You need the critical personnel to be identified. 2 providers are required for the procedure, regardless of the method. They can rotate, but must be always around the time of the procedure. They order the blood, they calculate the volumes again, and determine the most suitable technique. A sterile bubble must be made during the procedure, and all steps must be documented, especially the pertinent times. Labs must be taken during and after the procedure, and prior to it as well. And you should keep in mind that blood sugar levels should be monitored as well. The vascular access, usual umbilical vein, usually the umbilical venous catheter is used for the exchange transfusion, whether in term or preterm patients. And just like I said before, we have the 2 techniques, which is the isovolumetric exchange transfusion or the manual push and pull technique.
4 minutes, please.
Okay, thank you. The isovolumetric technique You use two catheters, one inserted in the umbilical vein and one in the umbilical artery. They allow a simultaneous withdrawal and infusion of the blood. The manual pull and push technique uses a single vascular axis with a three-way stopcock attached to the unit of the blood, the patient, and a discard container. Usually, the recommendation is to attach a blood warmer as well. Now, important notes is to mention that with both techniques, the absolute maximum volume of each withdrawal and infusion depends on the infant's body weight, hemodynamic status, usually no more than 5 ml per kg of body weight, or 5% of infant's blood volume is removed and replaced during a 3 to 5 minute cycle. The exchange transfusion should not be performed rapidly because of sudden hemodynamic changes that would affect their cerebral blood flow and shift the intracranial pressure, contributing to intraventricular hemorrhage. A total double volume exchange transfusion typically takes 90 to 120 minutes. Now, the complications, which is the final part of my talk, they are either blood-related or procedure-related. For example, metabolic, they include hypocalcemia due to citrate present in the blood bag, probably hypo or hyperglycemia due to additive solution dilution, or hyperkalemia, for example, due to free potassium as a storage lesion or radiation. And by every complication, it's recommended to have a plan while doing the procedure. For example, the metabolic, you might have some infusions available nearby. For the cardiorespiratory, you might need intubation kit, or like for the cardiopulmonary complications, you might need a defibrillator or cardioversion as well. Hematologic complications are mostly dilutional, like thrombocytopenia, coagulopathy, neutropenia as well. And the list goes on. I hereby end my talk. Thank you very much for your listening. Thank you.
Thank you very much, Dr. Mukhtar, for this excellent review with a lot of practical aspects. I'd like to welcome our next speaker, Dr. Maher Al-Juhani. He's a highly qualified doctor and a consultant of hematopathology. He holds multiple positions. He's a part-time consultant at King Abdulaziz Medical City in Jeddah and a full-time consultant at Prince Mohammed bin Abdulaziz Hospital in Medina al-Munawwara. He is chairman of the Department of Pathology there also. He completed his fellowship program in King Faisal Specialist Hospital and Research Center, and also in King Saud University for hematopathology and blood transfusion. He holds the Educational Commission for Foreign Medical Graduate Certificate from the United States of America, and he received several honors and awards. Namely, he was nominated as the Best Resident in Hematopathology Fellowship in King Saud University, and he received, mashallah, the SSBMT Hematology Research Award in 2018. He's also an inventor for the United States Patent and Patency, and he has participated in so many leadership programs. He's a member of so many organizational memberships, including the American Society of Hematology, the American Society of Clinical Pathology, and the European Society for Clinical Cell Analysis, and he presented in many local and international conferences. He will be talking about hemophagocytic lymphohistiocytosis. Welcome, Doctor. Thank you very much.
Assalamu alaikum, jami'an. Thank you for inviting me for this presentation, and thank you for the introduction. Today I will talk about hemophagocytic lymphohistiocytosis. Actually, it's difficult to present something at the end of any conference, but I will try to make it very brief and to the point. Thank you. خلاص we done? This working? Okay. We have a number of terminology related to this presentation. First one is hemophagocytic lymphohistiocytosis, or HLH, primary HLH, secondary HLH, familial HLH, macrophage activation syndrome, cytokine release syndrome. Before I proceed, I have a question to the audience. Is the HLH clinically diagnosis or pathological diagnosis? Both? All agree? Okay, خلاص weird. Okay, we have a small case. This is a 6 years old girl present with emergency department with 2 weeks history of sore throat, fever, rash, lymphadenopathy, abdominal distension, abdominal pain, arrival with high temperature, palpable cervical lymphadenopathy, and splenomegaly. Family, they don't have any hematological disorder. CBC shows leukocytosis, as you see, anemia, severe thrombocytopenia. Actually, clinical diagnosis or the possibility of this presentation, either sepsis, acute leukemia, Burkitt lymphoma, or HLH with infectious mononucleosis. They proceed to have bone marrow, what you see in the picture. What you see, anyone can have an idea or description? You can see the big cell is histocyte, as you see. It's actually, they have large nucleoli with indistinct cytoplasm, so that endless cytoplasm. But inside that cell, you can see red blood cell and some platelet. It's actually partially digested, so that this indicates this patient has hemophagocytic activity. This is another picture. You can see eosinophil, maybe lymphocyte, and some digested cells. So that actually in the bone marrow they have clear phagocytosis. At that stage, they proceed to have more investigation and more workup, starting by estimating the ferritin level, which was elevated. Triglyceride and fibrinogen was normal. They sent for soluble CD25, which was elevated. At that stage, they investigate for viral infection. Actually, they reach to the diagnosis of HLH in base of hemophagocytosis, high ferritin, and also soluble 25, fever, and splenomegaly, and thrombocytopenia. So that this is a classical scenario for HLH. We'll go, has more information about HLH. HLH, they have another name, which is hemophagocytic syndrome. It's an uncommon disease. It's related to dysregulation of immune activity, or overregulation or overactivity. Actually, it has a high fatality rate. You can see the only 5% of primary HLH, they have survival during the first year. Currently, after introducing the regimen for therapy, still they have high mortality rate, which about 40%. Usually, this patient present with non-specific clinical presentation like fever, splenomegaly, and cytopenia. The disease may manifest as a coagulopathy and hypertriglyceridemia, hepatic dysfunction, hyperferritinemia, and a neurological syndrome. This is depend on the infiltration and the involvement of the multiple organ. It is related to inappropriate immune response, starting by dysfunction of natural killer and T cell activity, leading to hypercytokine anemia and result activation of macrophage. So that it is dysfunction of T cell, cytokines, and then the macrophage will be hyperactivated. Cytokine, there is a multiple type of cytokine, including interferon, interleukin, a number of interleukin, and tumor necrosis factor. This cytokine will lead to a classical feature of HLH, which includes cytopenia and fever. This graph just summarizes the condition of normal response, which is starting by T cell and then activation of cells, including the macrophage. But actually in HLH, this dysregulation leading to hyperactivity of macrophage, including the interferon alpha. The predisposing factor for this condition is genetic condition, also infectious disease, including cytomegalovirus, and COVID-19 is one of the possibility of introducing the HLH. Malignancy is another possibility of risk factor, autoimmune disease, and some drug. We mentioned the trigger factor. We have two main categories for HLH, which is either primary or secondary. The primary or the familial type of HLH is around 1 every 100,000 children. But the patient usually presents with early infancy and adulthood, and syndrome may be triggered by infection. There is a number of genetic mutation or dysregulation that related to the primary HLH, include BRF1 and other implicated, MONC and cytotoxin, and another type of cytotoxin. That was the mutation related to granulocyte-dependent lymphocyte activity. Here we have another conditions or syndrome that may induce the HLH condition, include Gracile syndrome and Harmoniski-Bodlik syndrome, and also some other genetic mutation. It's likely other gene will continue to be added as a possibility or introducing or precipitating factor for HLH. Secondary HLH is related to infection, autoimmune disease, and malignancy. It happened to all group of age without preference for gender. Macrophage activating syndrome is a condition that happens in the background of autoimmune disease, so that it is a certain condition, but it's a need to have a presence of autoimmune disease. Some therapy that can trigger the HLH condition, including CAR T cell therapy and some anti-seizure syndrome medication like lamotrigine. Diagnostic criteria for HLH is the Histocyte Society 2004, which is a revision for HLH guideline, HLH 94 guideline. This is the criteria, which include two main elements. The first element is molecular diagnosis, which we mentioned before, and another one is diagnostic criteria, which is 5 out of 8 criteria. You can see here the fever, splenomegaly, cytopenia, which include hemoglobin below 9, and platelet below 100, and neutrophil, neutropenia, and hypertriglyceridemia, hypofibrinogenemia, and triglyceride, fibrinogen, and the HLH activity or homophagocytic activity in the bone marrow, spleen, and lymph node, and low or absence of natural killer cell activity, high ferritin, and soluble CD24. So that the bone marrow is one part of the diagnostic criteria, but not all the diagnostic criteria. Here you can see the percent of the presence of the clinical feature of HLH. You can see the fever is around 95% of the cases. Splenomegaly is 89% of the case. Bicytopenia 92. Hypertriglyceridemia is 90. Hemophagocytosis is only 82%. So that, and ferritin is high and low natural killer activity, soluble CD25 elevation. You can see the hemophagocytosis is only 82%. So that negative hemophagocytosis in the bone marrow not mean this patient is not HLH. You can see also the soluble CD25 elevation is high sensitivity for the diagnosis of HLH. But the problem of this laboratory test, it will take some time because most likely will be as a send out test. So that hemophagocytosis is not pathognomic for HLH. This is a very important message. Some patients may only show hemophagocytosis later in the disease. So that maybe it's at initial presentation, we cannot find hemophagocytic activity. There is a supportive diagnostic approach, which is H-score. It has been provided by Histocyte Society. It is kind of online calculation of HLH probability. So that you go to the link and you accumulate, you fill the forms, and you will have H-score and the probability of having HLH. We have another very important message here. Most of the case with HLH, they have a background of disease, so that you need to investigate the possibility or the predisposing factor or the underlying pathology that trigger the HLH condition. In children, we need to identify is this case is primary or secondary in base of mutational panel. Initial treatment, the initial treatment is generally the same, patient with a primary form or secondary. Infection is the most common trigger factor for secondary HLH, especially in children. Other virus like Epstein-Barr virus bacteria, fungi, and parasite is a possible triggering factor for HLH. The treatment should not be delayed waiting for molecular testing if patient meet diagnostic criteria for HLH, so that we can provide a primary diagnosis according to HLH criteria. The main therapy approach, including etoposide, dexamethasone, and a certain protocol. Familial HLH is rapidly fatal if untreated, as we mentioned before. There is some therapy or targeted therapy that has been introduced recently. It's actually a monoclonal antibody against interferon gamma. This targeted therapy have been approved by FDA for a refractory condition and the primary HLH. Here you can see how this monoclonal antibody is targeting interferon to cut the process of activating of macrophage, so that it will limit the activity of macrophage. This is the therapy that used as a targeted therapy against interferon. This is the approval process for this therapy. Also, siblings with HLH match donor are recommended to screen for genetic before they donate the stem cell. Here the key point for this presentation: HLH remains complex multifactorial disease, relatively rare. It's possible under-recognized. It needs high level of clinical suspicion from the beginning. Actually, is a clinical diagnosis, but the support of the lab and the collaboration between the lab, I mean the clinician and the hematopathologist, is needed. Also, we need to investigate for the precipitating factor or the background disease, which could be autoimmune disease or malignancy, or the primary related to mutation. Some tests may take a long time, like soluble CD25, so that is a need not to delay the diagnosis. It's a life-threatening disease. Here I can summarize. A diagnosis of HLH is a critical step toward a successful therapy, but actually it is a rare disease, fatal, variable presentation, non-specific finding, a background of other disease. But the practical consideration for the diagnosis is essential, and effective communication between the clinician and the pathologist is essential for diagnosis, especially patient with a critical condition. This is my reference. Thank you.
Shukran, Dr. Maher. Very excellent overview about HLH. Now we will open the floor for discussion, questions and discussion. I will ask all the speakers, Dr. Maha, Dr. Ammar, Dr. Mukhtar. We have time for 3 questions only. Any question, Dr.? I think you have a question, Dr. Mohammed.
I would like to thank all the speakers for these very informative lectures and very practical points that they have raised. Might have a question for Dr. Maha Badawi about what we always say as transfusion medicine people, that TACO is probably a silent killer to our patients. And one of the problems is that it is under reported. It's because of, it's very difficult for us as doctors to say that we are actually doing harm. They would rather think of the blood or the material itself causing the problem than our judgment or giving a lot of products. Is there any information about what blood product is mostly linked to this? Is it plasma, as we assume, or any other data regarding the mitigation of that risk? I will go actually to utilization. The overuse of plasma based on the coagulation routine testing may be the driver behind this.
Thank you, Dr. Mohammed. I didn't come across a reference that clearly shows a different rate for different blood components. However, I was very interested when I read about other elements apart from the volume itself affecting the risk of TACO. For example, there is evidence that the red cells, when stored for longer periods of time and hemoglobin is released in the plasma or in the supernatant in the bag, could affect nitrous oxide in the patient. And this was very interesting, and they kind of connected it with studies done on healthy volunteers whose blood was collected from them as an autologous donation and then stored in the refrigerator and then given back to them. Nitrous oxide levels were low when re-administered after storage in the refrigerator, and changes improved when those individuals were given nitrous oxide, inhaled nitrous oxide. So that was an interesting take, that it's not just volume, there are other factors. Yeah.
Any more questions? Dr. Mohsen al-Zahrani.
Thank you for all the speakers, excellent presentations. Just a comment or question to Dr. Maher. Excellent presentation, Dr. Maher. One of the entities that we see more commonly, this disease is rare, but we see now with the transplant, post-transplant, this entity is like becoming, frequently we see it, causing like graft failure, especially when you do transplant for high-risk procedures like haploidentical transplant. So they have similar diagnostic criteria, but the major criteria is the graft failure and cytopenia, and this is the major criteria, and the minor criteria like what you have listed for the HLH 94 criteria. Usually this patient, when we do bone marrow for them, they have hypocellular marrow, and most of the report we get is there is increased histocyte. When we discuss, as you mentioned, communication with the hematopathologist, with our colleagues, then they start looking more and they find this some phagocytic activity. But the major thing, they have hypocellular marrow. And this can change the treatment for this patient because they may need a second transplant or different approach. Do you have any comments regarding this observation?
Thank you, Dr. Zahrani, for this comment. It's actually challenging to diagnose HLH only from the laboratory side, and if we don't communicate with the clinician about the condition and also to review the file. So that active communication between the clinician and also the hematopathologist is essential. Actually histocytosis is not part of a criteria. The homophagocytosis is the the essential part for this criteria. This is one point very important. And also some condition, they have kind of activity without any presence of other criteria for HLH. So that a lot of vague condition here. And usually I like to have a call, I will call the physician to discuss this condition, to have a final comment in my bone marrow report.
Any more? Dr. Mohammadi again. Any other questions?
Again for Dr. Maha, for natural activity. What is the practical option to assess the activity available? Practical.
Up to my knowledge, I don't. It's actually we don't have it in most of our laboratory. This natural killer activity. I think it is the research maybe available in some research center. If Dr. Muhammad, do you have any comment about this? Yeah, but you can send out for some lab the soluble CD25 for this, for diagnosis. But it's take maybe 2 weeks to have this result, so that you need to give a diagnosis for, at early stage. Yeah, exactly. You need to see the other criteria.
So there is a patient with coagulopathy, liver disease, and he has upper GI bleed and he received FFPs and he developed rally. So if he has ongoing bleeding, so how, after how much time FFPs, if he needs, to be given? Yeah.
So it is thought that rally is specific to a specific unit that was given. If the clinical condition requires further plasma administration, keep in mind the patient now is going to be at risk of TACO if receiving lots of plasma units. TACO and rally can happen together. So that patient, if they need further plasma transfusion and they are already requiring supplemental oxygen because of suspected rally, I think that patient should be in the ICU for close monitoring, and if they still need further plasma, that should be given in a critical care setting. Okay. It's not contraindicated though.
Okay. How long, regarding packed RBCs, how long a unit can be out of refrigerator before it is transfused?
So we usually talk about the 30-minute rule if the unit is going to be returned to the refrigerator. Once out of the refrigerator, it must be transfused within 4 hours.
Thank you.
Thanks.
One question there.
First, I would like to thank all the speakers for the interesting topics. My question is for Dr. Mukhtar. In your presentation for neonatal exchange transfusion, you mentioned a formula to use it in case the patient needs blood. If the facility cannot perform this procedure, is there any alternative more safer than this procedure to perform for the patient, for the neonatal blood?
Again, one more time, please.
For the formula, you said that we can mix the blood to give for the patient to do the exchange transfusion for the neonatal. In case the facility cannot perform that for any reason, for example, there is no consultant, so how we can do this procedure?
Well, first of all, you must have some sort of a policy around as long as you're expecting such patients in your facility. And this formula is just simple to use, yeah, and would give you the best accurate calculation of the reconstituted blood. Whether there is a presence of a physician or not, I'm not really clear with your question, because the final decision to go with exchange transfusion or not is the neonatologist who's in service. Am I answering your question?
No, as a blood bank.
As what?
As blood bank.
As a blood bank?
Yeah, we are the one who's preparing this product to give it for the patient. Yeah.
Yeah, well, you have the hematopathologist, whoever is in charge of the blood bank. Yeah, you have physicians as hematopathologists, at least, even if you don't have transfusionists.
For example, can you use the whole blood? Or,
You want to use whole blood for exchange transfusion? Well, it's not really recommended because while processing of the exchange transfusion, you're centrifuging the mother unit in order to take out rest of plasma as well. Yeah, because it might have side effects on the neonate. So whether it's packed RBC with additive solution or a whole blood, both products need to be centrifuged. Yeah, and then you would add a compatible AB fresh frozen plasma to the unit.
Thank you very much.
Thank you.
Shukran. Just I have one question for Dr. Ammar about the platelet refractoriness. Every day we have patients with the platelet refractoriness, and to find HLA match platelet is not an easy tool for us. So what do you think, how can we involve the HLA lab in doing the establishing a registry for the donors? Do we need a national program, for example, or it can be done at the individual levels?
Of course, we need a national umbrella, national program for the HLA lab, like the rare blood groups, like the national registry for the blood donors. Every center is relying on his own facility and efforts to find those things, which is very difficult to find. The probability of finding matched HLA donor in 50,000 donor pool is not like finding it in 1 million donor pool. And so it is very important to have this is why maybe if it is not yet under blood bank, this is why it is not yet done nationally. If it is, we hope that we will establish this under the national blood bank, and there is talks around this is being done to have a national HLA lab. This is one of the strategic objectives of the national blood bank services in the kingdom, which we work in. Hopefully, we'll see that soon, inshallah.
Can we take it as a recommendation, Dr. Mohammed? Recommendation from the conference that to establish a donor registry for HLA match platelet.
Yeah, I totally agree with what Dr. Ammar suggested, and I think we had a conversation with Dr. Maha before that we have two, alhamdulillah, registries for donors, for stem cell donors in the country, but there hasn't been any official channel to communicate with them for the purpose of finding platelets or donors, platelet donors from within this pool of known HLA type. Probably this is an effort that has to be done, and it has to be a collective effort.
Dr. Mohsen has a comment about this issue.
Just a comment on the same point. So in the SCCDR registry in National Guard, Riyadh, we utilized it for this purpose. They have like more than 70,000 donors. Okay. And in some of our patients with the platelet refractoriness, we searched in the donor registry and we identified the donors for those patients, and they donated.
Okay.
So this can be approached by any center. You need to send the search request that for class 1 only, and the donors are distributed around the country. So you'll be lucky if you find a donor in your city. So most of the donors that we found, they were in Riyadh, but there are donors in other cities that can be facilitated to come to your center and donate platelet.
Thank you very much. So we'll call you. So we'll have the closing remark. Dr. Harim Al-Rabih will and we will close to this, inshallah, activity.
Thank you for joining us today. Special thanks to the SSBMT organization, the Saudi Lymphoma Group, namely President Dr. Ahmed Al-Askar, the rest of the organizers and the scientific committee, especially Dr. Mohammed Al-Muhammadi for his guidance and support. Special thanks to our moderators and speakers, and thank you to all the attendees. Please follow us on Twitter for upcoming events, and we hope to see you soon in Al-Khabar. Thank you.